A very good morning and warm welcome to one and all from the doctors and staff of Dr. Sreekanth Eye Care Hospital. This year, we complete 9 years of service in ophthalmic care and have proudly entered our 10th year. The journey has been challenging yet fulfilling. Last year, we achieved full NABH accreditation and are taking our early steps as a DNB training institution. As we all await a festive Onam season ahead and sumptuous Ona Sadhyas, we hope to enrich you all with our academic feast laid out for today. This is our 6th season of OCULUS. This time, we are looking forward to mastering the diagnostics with the help of eminent KSOS faculty as well as national faculty, along with wonderful speakers from right here in Kozhikode. Our afternoon session is going to be a great learning opportunity for our budding ophthalmologists as they challenge each other for exciting prizes and in the process learn from some of our great teachers. We hope all our faculty and all the delegates, including the postgraduates, have a fruitful day ahead. At the outset, I'd like to welcome Dr. K.N. Vimala Haridas Madam to our CME. I'm also honored to welcome Dr. G. Sudha to our ceremony. Thank you. So we go on to the inaugural ceremony. We'd like to call upon the dais, the dignitaries, Dr. Jain Chiman sir, Vice President, Kerala Society of Ophthalmic Surgeons, Dr. Suma Unikrishnan, President of Kozhikode Ophthalmic Society, Dr. Shankar Mahadevan sir, Honorable President, IMA Kozhikode, Dr. Sreekanth Karat sir, our Chairman, Dr. N.V. Shivan sir, our Medical Director, Dr. O.K. Nandagopal sir, Organizing Chairman, OCULUS Season 6, and Dr. Shishira Shivan, Organizing Secretary of OCULUS Season 6. We'll begin with a prayer to invoke the blessings of the Almighty.
ചൈതന്യമേ നിത്യ ചൈതന്യമേ കൈകൾ കൂപ്പുന്നു സമ്പൂർണ്ണ സന്നിധിയിൽ മതജാതി വർണ്ണങ്ങൾ എല്ലാം മറന്നേക മനസായി നമിക്കുന്നു ജാതാന്തരം ചൈതന്യമേ നിത്യ ചൈതന്യമേ കൈകൾ കൂപ്പുന്നു സമ്പൂർണ്ണ സന്നിധിയിൽ മതജാതി വർണ്ണങ്ങൾ എല്ലാം മറന്നേക മനസായി നമിക്കുന്നു ജാതാന്തരം ഹിന്ദുവും മുസ്ലിമും ക്രിസ്ത്യാനിയും നിന്റെ പ്രിയമക്കളാം ഞങ്ങളെല്ലാവരും തോളോടു തോൾ ചേർന്നു സൗഹാർദ്ദമായി പാരിൽ മുന്നേറുവാൻ വരം നൽകേണമേ മുന്നേറുവാൻ വരം നൽകേണമേ ചൈതന്യമേ നിത്യ ചൈതന്യമേ കൈകൾ കൂപ്പുന്നു സമ്പൂർണ്ണ സന്നിധിയിൽ മതജാതി വർണ്ണങ്ങൾ എല്ലാം മറന്നേക മനസായി നമിക്കുന്നു ജാതാന്തരം ചൈതന്യമേ നിത്യ ചൈതന്യമേ.
Thank you, Divya and Libita. Next, we have the welcome address by Dr. Nandagopal OK, Organizing Chairman, of OCULUS Season 6.
Check. Namaste and good morning to you all. It is my pleasure to welcome you all to our CME. Before we dive into the world of confusing images and scans, I'd like to specially welcome our special guests. First, a warm welcome to Dr. Jane Chimman, Vice President, KSOS. KSOS is like sort of a pigment epithelium to our photoreceptors, managing things very efficiently and adeptly handling the tsunami of CMEs thrown at them. It's always a pleasure to have Dr. Suma Unnikrishnan, President, KOS. Your calm and ever-smiling presence always adds value to the occasion. Dr. Shankar Mahadevan, President, IMA Kozhikode branch. A warm welcome. Taking his own words, specialty-wise, we are immediate neighbors. We promise to stay academically healthy always. To the scientific faculty, all the eminent speakers, thank you so much for coming and agreeing to share your knowledge. And thank you even more in advance for sticking to your allotted time. The delegates, a warm welcome. Postgraduates, residents, senior, seasoned ophthalmologists, and everyone in between, a warm welcome. This is your day to ask questions, challenge dogmas, and maybe even have a few arguments over optic disc margins. So let's all learn, laugh, and hopefully leave here a lot smarter than we came in, or at least leave with a few good PowerPoint templates. Enjoy your day. Thank you, and God bless.
Thank you, sir. Next, I request Dr. Suma Unnikrishnan Madam to please give the presidential address.
Dignitaries on the dais, Dr. Jane Chimman, President, Vice President, KSOS, Dr. Shankar Mahadevan, IMA President, Kozhikode branch, and the organizing team, Dr. Sreekanth, Dr. Shivan, Dr. Nandagopal, Dr. Shishira, senior faculty members, eminent speakers, senior teachers, Daju sir, Bhatt sir, Sudha madam, and all my colleagues and friends. Good morning to one and all. Sorry. I'm deeply honored and I'm very happy to welcome, happy to address you in this Sunday morning. And I congratulate Dr. Sreekanth and team for choosing such a wonderful topic, mastering the diagnostics. Not only that, and you have selected the best of best speakers for each session. And also I congratulate for honoring our senior, my guru, former professor and HOD, Dr. Velayanair sir, and a senior consultant and former Deputy Director of Health Service, Dr. Sudha madam, for their lifetime achievement. And so I congratulate Sudha madam and Velayanair sir for this well-deserved recognition. Now coming to the, and I also congratulate once again this team, organizing team, in that each time the OCULUS will be having some special things incorporated. This time they have included a PG session, nothing other than that case presentation competition. So it is very unique, and I again congratulate for that, the brain behind that. So now coming to the organizational matters, I am proud that all our members are excelling in all the national as well as international forums, academic forums. Thanks to the new technology and especially the younger ophthalmologist in this club, Kozhikode Ophthalmic Club, is excelling in all these academic forums. Again, congratulating them also. Now, we are also in the forefront of all academic activities. Every month we are having scientific meeting, and then before this T25 again we are having 2 more, and our secretary Irshad is working on that. I request all of you to participate in all academic activities. Now let me conclude by thanking the opportunity given to me at this forum, and I wish the CME, the OCULUS 6, all the very good success. And I'm sure that this will enrich you with some new take-home messages. Thank you for the opportunity once again.
Thank you, madam, for your kind words. Next, we have the auspicious lighting of the lamp and the inaugural address by Dr. Jane Chimman, Vice President, KSOS.
Satgamaya tamaso ma jyotirgamaya mrityorma mritangamaya om shanti 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 asato ma satgamaya tamaso ma jyotirgamaya mrityorma mritangamaya om shanti 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 asato ma satgamaya tamaso ma jyotirgamaya mrityorma mritangamaya om shanti 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 asato ma satgamaya tamaso ma jyotirgamaya mrityorma mritangamaya om shanti.
President of Kozhikode Ophthalmic Society, Dr. Suma, my good friend Shankar, my classmate Dr. Sreekanth and Dr. Lakshmi, senior leaders, senior madams, senior professors, Raju sir, Bhatt sir. It's a great privilege to be here to inaugurate this CME here today. Sreekanth, I don't think I have told you in person, but let me tell you on stage, congratulations to bringing together such a charming, handsome and talented group into your hospital. We in our batch is always up to date in all the happenings of your institution, because we are virtually participating in all the outings, in all even your monthly meetings we are there. So I am really honored to be physically present in one of your CMEs today here. OCULUS has been a trendsetter in this part of the state. It has been an academic feast which has been looked forward to all the ophthalmologists in the state. So congratulations, Sreekanth, for that again. And KSS, as you know, every week one CME is happening one part of the state or another. In a state, in an era when any information is available at your fingertips, what is the role of a CME, physical CME? I've always wondered. But friends, when we were starting in our career, the doctors per se, or even the ophthalmologists were very few in numbers. But now, as we know, the numbers are so great. Previously, we used to get our respect, but now we have to earn our respect of our patients. So, the academic feast is one way of being up to date in what is happening in our field. So, if you want to earn the respects of your patients, you have to be up to date in what's happening in your field. So, this is one way of enriching your academic caliber. So, congratulations. And I am heard that almost 200, you have crossed the registration of almost 200. So, that's a great achievement. So, congratulations again. And Shankar is also here. So, there are two ways where you have to be up to date. You have to earn the respects of your patient. One is being up to date in the field where you are practicing. And then second is by having an ethical practice. In that, IMA is doing a lot of help. So IMA's main role is ensuring that all the doctors are having a ethical practice and also support all the organizational matters that is happening in the medical field. So congratulations, Shankar, for being up to date in that also. And once again, congratulations for achieving 100 booking within a short period of 1 month. That's a great achievement. I have been following Calicut IMA activities also. So let me wish all the delegates participating here a fruitful experience today, and all the organizers and managers for the wonderful CME and the wonderful sessions you are having today. Thank you. And I officially inaugurate today's CME. Thank you.
Thank you, sir. Now, ladies and gentlemen, we move on to the KSOS Lifetime Achievement Awards ceremony. It is a KSOS President's initiative to recognize the work of senior ophthalmologists of Kerala. Our first awardee is one of the erstwhile ophthalmologists of Calicut, Professor Dr. R. Velaidhan Nair sir, an astute clinician and a great teacher for many among us. It is our greatest pleasure and privilege to have been able to hand over the award to sir at his residence. I request Dr. Almas to please read out the citation awarded to sir.
Dr. R. Velaidhan Nair, a distinguished figure in Indian ophthalmology, esteemed educator and visionary leader. Born in September 1944 in Thiruvananthapuram to Professor V.R. Pillai and Srimati Chinmayi Devi, he pursued his MBBS from TD Medical College and later Trivandrum Medical College between 1963 and 1968. He went on to complete his MD in ophthalmology at the prestigious All India Institute of Medical Sciences, New Delhi from 1972 to 1975. Dr. Nair's academic and professional journey was marked by a deep commitment to excellence. As head of Department of Ophthalmology at Calicut Medical College from 1996 to 2000, he introduced AIMS model postgraduate training programs and spearheaded significant reforms in surgical practices. He served as Dean of the Faculty of Medicine at Calicut University from 2000 to 2002 and held influential roles on academic councils shaping the future of medical education in Kerala. His dedication extended well beyond formal retirement, continuing as professor and later emeritus professor of KMCT Medical College and contributing his expertise at various institutions across the state. He was also the founding president of the Calicut Ophthalmic Club in 1995 and led the Kozhikode Ophthalmic Society as president from 2000 to 2003. Dr. Nair was supported throughout his journey by his wife, Srimati Vatsala V. Nair, a postgraduate in English literature and a dedicated school teacher. Together, they raised two sons, Dr. V. Rajmohan, a professor of psychiatry at KMCT Medical College, and Dr. V. Arjun, a cornea specialist at Comtrust Eye Hospital, Calicut. Dr. Nair's legacy as a physician, teacher, leader, and family man continues to inspire and uphold the highest standards of our profession.
Thank you, Dr. Almas. There is a message for all of us from Dr. Velaidhan sir.
Good morning, respected dignitaries Dear colleagues and friends, I am deeply honored and humbled to receive Lifetime Achievement Award. This recognition is not mine alone. It reflects the guidance of my teachers, the support of my colleagues, the enthusiasm of my students, and the trust of my patients. This moment reminds me how fortunate I am to belong to such an inspiring and dedicated community. I am especially touched to receive this award as part of the 6th season of OCULUS 2025 CME conducted by Sreekanth Eye Care, Kozhikode. Under the aegis of the KOS and KSOS, my sincere thanks to the organizing committee for this honor and to KOS and KSOS for their tireless commitment to learning and excellence in our field. Thank you all.
The next awardee for today is Dr. G. Sudha Madam, one of the pioneers in ophthalmology practice at Calicut. With immense pleasure and pride, we invite you, dear Madam, to receive the award. I request Dr. Privila to read out the citation.
Dr. G. Sudha embodies a legacy of compassion, dedication, and excellence in ophthalmology. She was born to Sri P.K. Govindan and Srimati Leela Govindan on March 28, 1945, in Kannur to a medically inclined family. Her academic journey began with her MBBS at Calicut Medical College in 1962. She then embarked on a distinguished career in government service starting in 1968. Her pursuit of specialized knowledge led her to earn a diploma in ophthalmology in 1985, followed by Master of Surgery in 1987. Her 12 years tenure at Beach Hospital, Kozhikode was marked by her significant contribution to ophthalmology, earning admiration of colleagues and the gratitude of countless patients. Her exceptional leadership led her to serve as Superintendent of Government Mental Hospital, Kozhikode. Later, she retired as District Medical Officer in 2000. Dr. Sudha's compassion and expertise continues to touch lives in her private practice. Dr. Sudha was married to late Dr. T. Sridharan, a respected chest physician. They have 3 children, including her special son, Mr. Venu. Second son, Gopinath, is an IT professional, and daughter, Dr. Anuradha, an anesthetist. She has 2 sisters, Dr. Abha, a distinguished gynecologist, and Dr. Shobana Mohandas, an acclaimed ophthalmologist, who was honored with the Lifetime Achievement Award by Kozhikode Ophthalmic Society in 2024.
I now request Dr. Sreekanth Karat sir to present a Ponnada to Sudha Madam. The KSOS award to be presented by Dr. Jane Chimman. The citation to be presented by Dr. Shankar Mahadevan. Also, we are delighted to welcome Dr. K.N. Vimala Haridas Madam, retired Professor of Microbiology of Calicut Medical College and alumnus of its 3rd batch. She is the proud mother of Dr. Sreekanth and Dr. Srijit, and after retirement, she has been leading the Microbiology Center Lab for the past 38 years, a venture she co-started along with the late principal and distinguished Dr. C.K. Jairam Panikar. She will be presenting a memento to her dear friend, Dr. Sudha. I request Dr. Vimla Madam to speak a few words on the occasion.
ഡോക്ടർ സുധ, ഞാൻ ബഹുമാനിക്കുന്നതും വളരെയധികം ഇഷ്ടപ്പെടുകയും ചെയ്യുന്ന എൻ്റെ ഒരു ഫ്രണ്ടാണ്. പിന്നെ സുധയുടെ പേഷ്യൻ്റായിരുന്നു ഞാൻ കുറേ കൊല്ലം എച്ച് ഹോസ്പിറ്റലിലുള്ള സമയത്ത്. വളരെ സിൻസിയറായിട്ടുള്ള ഹാർഡ് വർക്കിംഗ്, പ്രൊഫഷനോട് വളരെ എന്താ പറയേണ്ടത്, ആത്മാർത്ഥത കാണിച്ച ഒരു ഡോക്ടർ. എല്ലാത്തിലും ഉപരിയായിട്ട് നല്ലൊരു മനസ്സിൻ്റെ ഉടമയാണ്. നമ്മളെല്ലാവരിലും കാണാൻ ആഗ്രഹിക്കുന്ന സിമ്പതി, എമ്പതി, പിന്നെ എന്തല്ല പേഷ്യൻസ്, വിനയം, ബാക്കിയുള്ളവരെ ബഹുമാനിക്കുക, അങ്ങനത്തെ ഇനി എന്തൊക്കെ ക്വാളിറ്റീസ് ഉണ്ട് അതൊക്കെ ഉള്ളൊരു ഡോക്ടറാണ് സുധ. പിന്നെ ഇന്ന് ഇവിടെ എനിക്ക് ഭയങ്കര സന്തോഷമുണ്ട്. കാരണം ശ്രീകാന്തിനെ ഇന്നിപ്പോൾ ഇവിടെ ഓഫ്തൽമോളജിസ്റ്റായിട്ട് നിൽക്കുന്നത് എല്ലാ ക്രെഡിറ്റും സുധക്കുള്ളതാണ്. കൊല്ലങ്ങൾക്ക് മുമ്പ് ശ്രീകാന്തിനെ കൈപിടിച്ച് ഈ ഫീൽഡിലേക്ക് നടത്തിയത് സുധയാണ്. ഹോസ്പിറ്റലിൽ എല്ലാവരും ശ്രീകാന്തിന് നൽകുന്ന എല്ലാ സഹായങ്ങൾക്കും വളരെ സിൻസിയറായിട്ട് കൂടെ നിന്ന് വർക്ക് ചെയ്യുന്ന എല്ലാവർക്കും എൻ്റെ നന്ദി. എല്ലാവർക്കും നന്ദി, നമസ്കാരം.
പ്രസംഗിക്കാൻ അറിയില്ല എന്ന് പറഞ്ഞ് ഇത്രയും വലിയൊരു പ്രസംഗം നടത്തിയതിന് വളരെ നന്ദി. ഡിസേർവ് ചെയ്യുന്നതിലധികം ക്വാളിറ്റീസ് എൻ്റെ മേലേക്ക് ചാർത്തിയതിനും. ശ്രീകാന്ത് ഇത്രയും നല്ലൊരു നിലയിലെത്തിയതിൽ എനിക്ക് വളരെ സന്തോഷമുണ്ട്. ഞാൻ എപ്പോഴും വളരെ എന്താ പറയണ്ടത്, വളരെ സന്തോഷത്തോടു കൂടി നോക്കിക്കാണുന്നതാണ് ശ്രീകാന്തിൻ്റെ ഉയർച്ച. ഇന്ന് കേരളത്തിലെ ഏറ്റവും പ്രധാനപ്പെട്ട കുറച്ച് ഹോസ്പിറ്റൽ ഒന്നായിട്ട് ഉയർന്നതിന് എനിക്ക് വളരെയധികം സന്തോഷമുണ്ട്.
ശ്രീകാന്തിൻ്റെ കൂടെ എല്ലാ സമയത്തും സ്ട്രോങ്ങായി നിന്ന് മോറൽ സപ്പോർട്ട് നൽകുന്ന പ്രിയ മാഡത്തിനും എൻ്റെ നന്ദി.
Thank you so much, dear Vimala Madam, for your kind words, and Dr. Sudha Madam for gracing the occasion. Next, we call upon Dr. Shankar Mahadevan Sir, Honorable President of IMA Kozhikode, for felicitation.
President of Kerala Ophthalmic Society, Kozhikode, Dr. Suma Unnikrishnan. Today's Chief Guest and Vice President of KSOS, Dr. Jane Chiman. Organizing Chairman of OCULUS 6, Dr. O.K. Nandagopal. The Organizing Secretary, Dr. Shishira Shivan. Dr. Sreekanth Karat, Dr. Shivan Sir. All the senior members of ophthalmology, doctors, fraternity, and postgraduate students. First of all, I take this opportunity to congratulate Dr. Sreekanth and his entire team for consecutively organizing an academic workshop for 6 years. See, it is indeed not possible to conduct a CMEs during the present days because it invites a lot of troubles, it involves a lot of efforts from our side. You need a lot of participation and need a lot of manpower to organize. But Dr. Sreekanth has got all of these to do this, and he is an exceptional leader in the sense. So I congratulate this Sreekanth Eye Care for conducting the OCULUS 6 in a very, very grand manner. The KSOS or the Sreekanth Eye Care or even the Ophthalmic Society of Kozhikode has been an immense support to IMA Kozhikode also in various ways. As you all know, the IMA conference, the state conference is to be there in November 8th and 9th of this year. And I think under the leadership of Raju sir, the entire Kozhikode doctors and especially the ophthalmologists have been registering almost 100%. And Dr. Sreekanth Eye Care is the first specialty hospital to register 100% for the IMA Con 2025. So before we tell about anything regarding the specialty or anything about the CME workshops and all, we should also teach our students, postgraduates, and even the junior doctors also about what not to do. I will just quote two incidents which happened recently. എന്ത് ചെയ്യണം എന്നുള്ളതിനേക്കാളും ഏറെ പ്രാധാന്യം അർഹിക്കുന്നതാണ് നമ്മൾ എവിടെ എന്ത് ചെയ്യരുത് എന്നുള്ളത്. അത് നമ്മൾ മനസ്സിലാക്കിയില്ലെങ്കിൽ നമ്മുടെ ഈ ആധുനിക ലോകത്ത്, പ്രത്യേകിച്ച് ഇന്നത്തെ കാലത്ത്, പ്രാക്ടീസ് ചെയ്യാൻ വളരെയധികം വിഷമം നേരിടും. Just I will quote two incidents. I will not name any person or nothing. A surgeon who is also practicing in a peripheral clinic goes there. It's a very small clinic, does a circumcision for a 1.5-year-old infant, gives some local anesthesia. The child collapses. The child is being taken to another hospital. On the way, the child dies. You know what will happen in such a situation. There is no facility for doing such a procedure in a small clinic. No consent has been taken. And these things happen once in a while, but when it happens to you at one particular point of time, then your entire life changes. The second incident, which happened just a few days back, maybe 2 or 3 days back, a surgeon in an FHC, you know FHC, Family Health Center, Wayanad, operates on a ganglion in a wrist, puts an incision. Unfortunately, the tendon to the index finger is also cut. The tendon retracts inside. She's not able to take it from deep inside. And she refers the patient to a medical college, nearby medical college. The patient is there. Suddenly the medical college people sees the patient, and they said it is almost impossible now to operate because it has just gone deep inside. We have to give general anesthesia and all. Today it cannot be operated because there are no anesthetists here. We will have to come the other day. He went to a private medical college. He does the surgery there. A large bill comes. Now she is facing a police inquiry. The bystander, the things that has happened, there has been no bystander while taking the patient to a surgery. Even it is a very minor surgery. You need not have a bystander as such, if you ask. But when operating upon anything, you have to follow a certain etiquette, certain guidelines. If you are not following certain guidelines, you are sure to pay the price for that. It may not happen now, but it may happen some other time in your life if you are not following this. Indian Medical Association has been organizing series of workshops about this. That is what Dr. Jain Chiman has been telling. But unfortunately, members are not interested. That is why I just want to tell the organizers, whether it is a specialty organization, whether it is a specialty center, when you organize any workshop CMEs, put up a session for some medico-legal aspects also, because you should know that when to stop, what not to do, all these things should also be addressed to the members, because this is very important. Second thing which is happening nowadays is we are not able to cope up with the stress around us in our profession. The stress is so much that especially the young generation, the figures, it is almost up to 20 to 25% of the doctors, they are undergoing stress, they are having depression. That is, which means 1 in 5 out of you are having depression within you. But we are not able to find that, we are not able to find a solution, we are not able to analyze that. So basically all these CMEs and all these sessions should also have something like stress busters. Maybe in the afternoon session, you can have a Zumba dance, something like that, which will relieve some sort of stress from you. And basically all these CMEs are for interactions also, one-to-one interaction, personal chats, isn't it? Otherwise, there is no point in completely burdening with you with all the academic activities. So here and after, whenever conducting a CME, whether it is a specialty, whether it is an association point of view, kindly include what I have told here about the legal aspects and also some stress busters. I wish the OCULUS Season 6 all success, and IMA has always been an integral part of all the activities of Ophthalmic Society, and I thank the organizers also for inviting me. Jai Hind, Jai IMA.
Thank you, sir, for your kind words. Now, as a token of our gratitude, we'd like to present mementos to our chief guests. I request Dr. Lakshmi A., our anesthetist, to present a memento to Dr. Jane Chiman, sir. Dr. N.V. Shivan, sir, to please present a memento to Dr. Suma Unikrishnan, madam. Thank you, sir. Dr. Nandagopal, sir, kindly give away a memento to Dr. Shankar Mahadevan. Thank you, sir. I'd request Dr. Sreekanth Karat, sir, to please speak a few words to us today.
Good morning, everyone. In this program, I am a wild card entrant, and I should not be held responsible for delay in time. It's already late. A warm welcome to the 6th edition of our CME series OCULUS. And this year is an extra special as we are celebrating our 10 years of service of our hospital. I'm happy to have, in this occasion, my classmate, Dr. Jane Chiman, as the chief guest. I also acknowledge my classmate star ophthalmologist, Dr. Jason, Dr. Ranjini, and Dr. Safarullah. I think they are here. Swadik couldn't come. And this year's Lifetime Achievement Award goes to Velayudan sir and Sudha ma'am. As my mother pointed out, Sudha ma'am had played a big role in my ophthalmic career. After MBBS, not knowing what to do, somebody said, you do senior residency. to improve your resume. So I did senior residency under ma'am in Beach Hospital, along with Akchama madam was there. She was very kind and she taught me the basics of ophthalmology way back in 91, 92. And this has changed my direction of my ambition also. Initially, I was interested only in radiology. In fact, I joined radiology at Calicut Medical College. Then when I got ophthalmology at Madurai Medical College, I just joined that. Thank you, ma'am. And another important person in my career, without whom I wouldn't have been in Calicut. That is my life partner, Priya. After Shankara, that is in 98, we decided to come to Calicut for 1 year transit period before going abroad. And that 1 year transit never ended. She has been a silent force behind all activities in the hospital. Thank you. Thank you all for coming here on our invitation and making the CME a great success. Thank you.
Thank you, sir. That's one of the rare occasions where we get to hear him through a microphone. Thank you, sir. To end our inaugural ceremony on a warm note, we'd like to call upon our organizing secretary, Dr. Shishira Shivan, who has worked tirelessly over the past several weeks to make this CME come alive today. She'll be delivering the vote of thanks.
Respected dignitaries on and off the dais, a warm good morning to one and all. As we come to the end of this inaugural ceremony, I would like to take a moment to thank each and every one of you for making this OCULUS Season 6 a grand success. So first let me thank Dr. Jane Chiman sir, Vice President KSOS, who readily accepted our invitation to inaugurate the ceremony. My sincere thanks to Suma Madam for all our valuable support and honoring us with the presidential address. To Dr. Velayudan Nair sir and Sudha Madam, we congratulate you on your well-deserved recognition, and we also thank you for being an inspiration for all of us. Our special token of gratitude to Shankar Mahadevan sir for your presence, valuable presence with us. We extend our heartfelt thanks to all the senior ophthalmologists, our dear teachers, all the faculties, panelists, and delegates who accepted our invitation to be with us here today. Now, next, let me thank our own management, Sreekanth sir, Priya madam, my father, Dr. N.V. Shivan, our organizing chairman, Dr. Nandagopal sir, whose all of their motivation, constant motivation and guidance has been our driving force throughout. Then my sincere thanks to all my dear colleagues, including special mention to the comparing team led by Dr. Manjusha. Big thanks to the entire staff of Sreekanth Eye Care Hospital for their excellent teamwork and commitment. Last but not the least, I would like to thank and appreciate all those who worked behind for this program. Mr. Prashant of Mayak Kshetra, the designing company, Mr. Pradeep of the audiovisual team, all the pharma companies, the press and the media, the management and staff of Malabar, Hotel Malabar Palace. Once again, thanking you all. Have a nice day.
Thank you, Shishra. With that, we conclude the inaugural ceremony of our CME. And next, we'll be having the academic session. I'd request all the guests on the dais to assemble together for a group photo. We begin our first academic session on glaucoma. It's the glaucoma diagnostics, enhancing your skills. So first of all, I'd like to extend a warm welcome to our two panelists. I'd request them to please come and sit on the dais. Dr. Jyoti PT Madam, Professor and Head, Department of Ophthalmology, KMCT Medical College. Madam is a highly experienced teacher for most of us here. We're very happy to have you here, Madam. Our next panelist is Dr. Mithun Tulsidas, the cataract and glaucoma specialist at Trinity Eye Hospital, Calicut. He has had several presentations and paper presentations, authored many publications. We are very happy to have you here, Dr. Mithun. Next, I'd like to welcome the first speaker of the day, Dr. Preeti Kamdar. She has accepted our invitation graciously. She has come all the way from Mumbai. She works at Dr. Kamdar's Eye Clinic and Jesham Eye Institute, Mumbai. She's a highly experienced cataract and glaucoma surgeon. And she's a faculty at several national and international conferences. Over to you, Madam.
Children, okay. So, good morning, everyone, and it's a pleasure to be here. And I thank Dr. Sreekanth, Dr. Sisira, and Dr. Manjusha, and the entire organizing team for the opportunity to present today. So, perimetry remains an invaluable tool for treating and monitoring glaucoma that we all know. Just 1 minute, can we switch off that light? It's possible? Just that light. It's, yeah, thank you so much. So it remains an invaluable tool for glaucoma, we know, but particularly in conditions of the optic nerve. Now, when you have an optic nerve like this, you don't know what is it. Is it papilledema? Is it an optic nerve head drusen? Is it NEION? Is it optic neuritis? What is it? So perimetry can play a decisive role when you have to interpret such discs. And of course, they are a window into the brain as regards the visual pathway. And why this matters, you'll see in the subsequent cases, because it's so easy to advise an MRI. Why even bother interpreting? So just a brief recap, the visual pathway begins at the retina, at the photoreceptors, then it passes via the bipolar cells and goes back as the optic nerve. At the optic chiasma, the nasal fibers decussate. They go back as the optic radiation, and at the lateral geniculate body there is a synapse, and then it goes back through the temporal and the parietal lobe into the occipital cortex. And because of this particular arrangement of the nerve fibers, anything which is behind the optic chiasma produces bilateral, many times congruous, homonymous defects. And that is how it helps us in identifying where the lesion is located. One more thing is that this strict division ensures that they are aligned along the vertical midline. Glaucomatous visual field defects respect the horizontal meridian. And because the retinal nerve fiber, because of this raphe, that the arcuate pattern of the nerve fibers, most of them end at the horizontal raphe, do not cross over, and that is why glaucomatous defects will always respect the horizontal midline, and they will always correlate with the disc. This is a typical glaucomatous damage, a nasal step, a sharp nasal step respecting the horizontal line, and corresponding to the inferior notch, you get a sharp superior defect. So this is just basics. I was told to keep this completely case-based. So I'm going to present a few cases. This is a 77-year-old lady. She complained of blurred vision since 5 days. She flew back immediately. No trauma, no unconsciousness, no dizziness. She consulted an ophthalmologist the next day. And these are the findings. The ophthalmologist, this is what the disc picture was. The pressure was borderline 20/22. The fields were done. Okay? And fields were done. This was the disc. The disc is little suspicious in the right eye. Yes, there is an inferior notch. There is a nerve fibular defect. The left eye seems pretty healthy. The scans were done and it shows global thinning. That ophthalmologist said that this is purely glaucoma. The patient came to me for a second opinion and she said, my vision is very good now. And she was 6'6". And I repeated the fields, they were almost similar. So now, is it glaucoma? Is it a neurological episode? Or is it both? So how do we know? Take a minute. Whenever you see a field, take a minute to describe the defect in terms of its location, depth, and additional features. So how can you describe this here? You can describe it in two ways. One is either a superior arcuate scotoma and the beginning of an inferior arcuate too, not beginning, but an inferior arcuate scotoma, or you can say that maybe it is respecting the vertical meridian, maybe it's a neurological defect. And it is nasal. Alright, so you know that glaucoma defects are nasal. So is the person, am I right or is the earlier ophthalmologist right? So does it correlate with the disc? A glaucomatous defect will correlate with the disc. In this particular case, I showed you what the discs were like. Okay, right eye, you may say that it may correlate with the disc, but the disc doesn't appear as bad as it is seen here. So then always look at the other eye. And this is the other eye and that will clinch. Keep the two side by side. And now you start making a diagnosis that probably this could be neurological because which is the side affected? Describe the defect. It is the temporal side. You know most of the times glaucoma defects are nasal. Does it respect the vertical meridian? Yes, more or less. Does it correlate with the disc? Not at all. The disc appears pretty healthy. So that's why I felt that this was neurological. And just to say that even when the vision in a glaucoma patient is hanging by a thread, you will find that the temporal PL is maintained. You will have poor PR, poor projection in the other quadrants, but the temporal island will be maintained. And that's what I'm trying to say, that if the temporal thing is affected, vision is affected, take a break. And maybe it's neurological. So this is what the MRI showed, lesion here. And it was a multiple infarcts and it was a thrombus in the posterior cerebral artery. So this is how it is, that clinched the diagnosis. So the lessons is the field may try to respect the vertical meridian, may not strictly respect it, but they definitely try to. Grayscale gives a good impression, always correlate with the disc. Temporal field loss should raise a red flag. This is another lady who just came to me in March 2024. She had a metastatic CA in the brain. Primary was in the breast. And she was terribly worried about losing vision due to radiation. Radiation was given to the brain mets. When she came to me in March 2024, vision was 6 by 6 and 5. These are the disc pictures, looks very healthy. I did an OCT also because she was complaining incessantly. All right, not complaining, worried. These seem all right. And the fields. These are March 2024 fields. She came to me again in October 2024 with worries of losing vision, that I'm scared I'm going to lose vision. It remained 6 by 6. I did not do a field on that day. In July 2025, now she complained there is actual blur vision. And 6 by 9 and 8 and maybe early cataracts. So then I did a field again. Now look at the field. Again, as I said, take a minute to describe the field. Is it a cloverleaf scotoma? Because it seems like that. There is no one single scotoma. Is it an artifact or is it a mixture of the two? So what I said is, first is turn to describe the defect. I can't describe it. Second is, does it correlate with the disc? It does not. Does it respect the vertical and horizontal meridian? Maybe this does, but there is a scotoma here, there is a scotoma here. How do I know? So then, does it correlate with the disc? No. How is the other eye? Now this was the other eye, and that set me thinking, is the field defect an artifact or is it a true defect? So if you see that there are three loci where there is a defect. But when you, so that's why I repeated the first field, and this is what showed. So here it is a homonymous, but every time it's not going to be a hemianopia, but it's a homonymous defect. And it means that now the visual area of the brain is getting affected due to the meds. So how do you differentiate between two? This is a similar paracentral scotoma which is seen in glaucoma also. But if you see, it is not respecting any line. All right. So this is how you differentiate. And OCT, particularly the ganglion cell complex, can be a good differentiator. You can see the homonymous defect, and the RNFL was absolutely normal. So sometimes that's not the way to use GCC, but you can use it as an adjunct. So the lessons which we have to learn is the vision drop not correlating with the disc. All neurological fields will not have a hemi or a quadrant anopia. Compare the two eyes. In a neurological field, the patient is aware of vision loss. In a glaucoma patient, usually it's not there, and glaucoma loss always correlates with the disc. This is a 70-year-old lady with a known case of glaucoma with field defects. And these were the original field defects. She came to me saying, I have loss of vision since 2 hours. And actually the vision had dropped from 6 by 6 to a little low. These were the fields before the episode. Take a minute to describe it. Yes, there is a superior scotoma, and this is again a more denser superior arcuate scotoma. I asked for, again I did the fields. The field pattern has changed. If you remember, if you realize now it is respecting the vertical meridian. So this probably is glaucomatous plus a neurological effect. I was very sure. I immediately within an hour I got the MRI done. The MRI was normal. And so now, who do I trust? I trust myself or I trust the MRI? But I said no, I trust myself more. A field cannot go wrong. And that's why I got the MRI done again, which took another 5 hours. And that time, a small defect was shown. And that's because I realized, I didn't know this exists, that if it's a very hyperacute phase, it may not show up, and in fact will not show up. In fact, because 6 hours or 5 hours had gone after the episode, that is when this defect showed up. So this is why it's very easy to do an MRI, but you trust the field more than you trust the MRI. And immediately on my recommendation, they started thrombolytic therapy. She recovered vision, and the visual fields are back to what they were before. So this is why it's so easy to do an MRI, but the field never lies. This is an asymptomatic 45-year-old male, mentioned that outer letters of the vision chart are fuzzy, disc right very healthy, left very healthy. It was, but because he said there is a fuzziness, I did a scan, I did a perimetry. And this is the earliest 6 by 4 vision. So this is the earliest pituitary adenoma I have diagnosed in my practice. I'm going to show you so certain, I don't have time, this is just one thing. Now these are two identical looking fields. One is neurological, one is glaucoma. Which one? So whether A or B, which one is glaucoma? So now let's describe the defect. That's always the key. Now here if you see A, temporal, superior, or you can say a superior arcuate more involving temporal, inferior arcuate more involving temporal. This is, okay, a superior arcuate involving more of the nasal field and less of the temporal. So that is one, describe the defect. Does it respect the vertical meridian? In part A, it does. Does it correlate with the disc? Let's see the discs. This is the disc of A, this is the disc of B. They both look just pallor, there is no glaucomatous defect. But what I can tell you is that this is a reversal of cupping which was seen in a patient who had glaucoma, pressures were 40. I operated for a trabeculectomy and there was reversal of cupping, and this is what, so it's difficult even it's not correlating with the disc. But then you look at the other eye, both the eyes of field A, and now you know it's a neurological field defect, and when you see B, field B, the other eye is normal. So neurological fields will be similar, they will affect both eyes to a certain extent. I have finished 15 minutes, can I have 1 minute more please? Yeah. So again, now this is bitemporal hemianopia, 1. Again, hemianopia, but this was an advanced case of a tumor which spread over to the other side. So it will not strictly respect the vertical meridian. So the lessons is early and late stages will follow the hemianotic pattern, but not strictly. Temporal involvement differentiates them. Visual fields side by side helps. Early stages disc may not show changes. I'm not going to go into the details. So what I want to say is that neurologic will respect the vertical meridian. Bilateral, congruous fields do not correlate with the disc. So in a nutshell, respect for the midline, whichever, vertical or horizontal, and congruousness. Evaluating both fields together, put them side by side. Correlation with the optic nerve is mandatory. Use OCT and clinical exam together. Retest suspicious fields. Awareness of visual defects is a sign of neurological fields. Assess for neurological symptoms, and when in doubt, of course, neuroimaging. So thank you once again for a very patient listening and for the invitation. Good day to you.
Thank you so much, madam, for that enlightening talk. We'll have the panel discussion at the end of the session, and the audience can please keep their questions ready. Our next speaker for the day is Dr. Girija K. Madam. Madam is the Senior Consultant and Chief of Glaucoma Services at Little Flower Hospital and Research Center, Angamali. Over to you, Madam.
ഞാൻ ഓപ്പൺ ചെയ്താൽ മതിയോ? Good morning, everyone. Thanks to the Sreekanth Eye Care team for inviting me and giving me this opportunity. Optic disc in focus for OCT analysis of glaucoma diagnosis. How does OCT help us to diagnose glaucoma cases? So as all of you know, it's a non-invasive, non-contact imaging technique, and there are various machines by different companies. And each machine has got different glaucoma scan patterns, algorithms, and display outputs, and it's very difficult to interpret and compare each of these glaucoma OCT maps. And this is actually a patient 48-year-old patient, who came to our OPD. He was having a lot of systemic comorbidities, but the vision was 6/6, and the cupping was, there is a 0.8 cupping here, and you can see that clear-cut RNFL defects are seen, and the visual field also is showing inferior arcuate scotomas, but the OCT, look at the OCT. OCT is not showing a proportionate thinning here. So by looking at the OCT, never suspect this is a clear-cut glaucoma case. So OCT can be misleading too, unless you evaluate you look at the scan and evaluate it properly. This is another case of early glaucoma, where again you can see there is a inferior polar notching, an RNFLD, and here the visual field is showing only a single scotoma here, a paracentral scotoma. But the RNFLD, the thinning, and the macular GCC showing a inferior infratemporal thinning. All these features are point towards a glaucoma. So the Ceres, I will be concentrating on Ceres SD-OCT. It analyzes the optic nerve head, the RNFL, and the macular GCC. The three areas are scanned. And the RNFL parameters, it gives the most important thing, you have to look at the thickness map, see whether there is any RNFL thinning. Then it gives the Tisnit map, the temporal, superior, nasal, inferior, and the temporal. It has normally it has two humps. And the right eye is represented by a continuous line and the left by a dotted line. And it gives you the quadrant and the clock hours. And it is color coded. By comparison to the normative database, it is color coded as green, red, and yellow. And the green is definitely the normal. And always look at this is another one, it's actually an artifact, a split RNFL defect. You can see there is a splitting here, and this splitting is shown here, like you can see there is a valley between the two humps, and that there is also a temporal shifting here. So the whole map is shifted temporally, which will give you a thinning here. It is actually an artifact. It is not a real thinning. Actually there is no thinning here, but it is shown as a red color here. So never go by the color. And the average RNFL thickness and the inferior sector RNFL thickness are the most accurate parameters. And always understand that the structural changes precede the functional damage. So even before the visual field defects start appearing, you will get OCT changes. That is, with a specificity of 95%, 19% of the patients showed changes in the OCT 8 years prior to any visual field defect start appearing. So an OCT defect has to be taken with a pinch, and you have to follow up the patient if you suspect glaucoma. And these are the optic disc parameters, the rim area, the disc area, and the CD ratio and the cup volume. Except for the disc area, all these are compared with the normative database and color coded. And this is a newer parameter which may aid in early glaucoma diagnosis, that is the Bruch's membrane opening minimum rim width, BMO MRW. The BMO, the termination of the Bruch's membrane is actually, it's the anatomical edge of the disc, and the BMO MRW, that is the minimum perpendicular distance from the BMO to the ILM. That will give you actually it can give this value, you can follow it up in the OCT. It is available in the spectralis as well as in the SD-OCT. You can get it as a parameter for aiding the glaucoma diagnosis. It will give you a clear-cut, more accurate assessment of the neuroretinal rim. And macular parameters, as all of you know, it is the macular thickness map, and there is the deviation map and the pi sectors. So you have to look at all these. Here you can see there is a thinning in the left eye. So all these areas have to be carefully analyzed. So when you are analyzing an OCT map, just like you are analyzing in a visual field, you have to look at the various zones. I have marked them in numbers. So all these zones have to be carefully looked at before reaching at an impression. The macula also can give you, sometimes early changes may be appearing in the GCC map. This actually, the top one is a healthy eye. So you can see that everything is normal here. But this is an early glaucoma, a preperimetric case. The fields are normal, but there is an RNFL thinning if you look carefully, which is shown here. So macula actually initially shows it. Then this is an established case. Here there is an RNFL defect, there is an inferior scotoma, and that is seen here as a supratemporal GCC thinning. This is again another established case. So you can see the large disc with a visual field defect, and there is corresponding thinning here. The left eye is normal. It's not moving. It's not moving. This is again another case of preperimetric glaucoma. See, the visual fields are normal, but you can definitely see the inferior notching here, RNFL defect, and the corresponding thinning here. So you can definitely start treatment with the disc appearance and the OCT confirming the changes. Now coming to glaucoma progression, this is actually more challenging, whether the disease is progressing. So because of the very slow progressive nature and also these various devices, by looking at the different OCTs, it may be difficult. And there is no standard to differentiate between the glaucomatous change and the measurement variability or the age-related changes. The machines have, the SD machine, SD-OCT machine has the GPA. Here there is the event-based analysis and the trend analysis. And once the RNFL thickness has reached the floor effect, that is the minimum value of around 30 to 40 microns, where there is no nerve fibers left, but only the glial tissue and the blood vessels, the OCT becomes useless then for assessing the progression. You have to rely entirely on the visual fields then. The one case, a 30-year-old female came to us. She was a myope, -3 diopters in both eyes. Her father had glaucoma. And the disc there was an asymmetric cupping with 0.65 to 0.7 cupping in the right eye and a 0.6 cup in the left eye. So her visual fields and OCT were normal when she presented. She presented in 2015, but IOP was high. So she was started on anti-glaucoma medications, and then she was regularly coming and the visual fields were like normal, but the OCT was showing RNFL thinning. Then in 2022, the IOP suddenly started going up. So we had to step up the anti-glaucoma medications, and then she was lost for follow-up for 2 years. And when she came in 2024, suddenly she had this paracentral scotoma. And the OCT was also, like there was a worsening in the OCT. So you can clearly see this is the 2021 and this is the 2025. That is, in 2024 actually she underwent trabeculectomy, and this is the picture. You can definitely see that it has progressed. This is her GPA. You can clearly see that this is, the progression is here depicted in yellow and red color. And left eye, which was like 0.6 cupping, that is also showing some sort of progression. But that is also having an high IOP. So she is already on 3 anti-glaucoma medications. We are keeping her under observation. This is another clear-cut case of glaucoma. She had 0.8 and 0.65 cupping. There is a superior thinning and superior RNFLD, and there was an inferior field effect. And you can see this RNFLD, and the RNFL thinning can be seen clearly here. And you can see that the supratemporal thinning is seen here. High myopia is it's actually a confounder. So here there is lot of changes at the disc and around the disc. So here this patient had a 0.75 cupping with an inferior thinning, and recently I think this one has there is a splinter hemorrhage here. Patient had a enlarged blind spot only when she was being followed up, but recently she is starting to get these superior scotomas. Already her IOP was high and she was on anti-glaucoma medications. This OCT, see the OCT scan is very difficult to get in high myopia. High myopia is actually a common cause for red disease. Even with the normal RNFL thickness, you may get some red areas in the OCT map. This is actually again a normal OCT. She came for screening. Here again, there is it's a horizontal cup. You can see a horizontally oval cup with a superior thinning. But the OCT is looking all green. The patient has to be kept under observation. And healthy disc of another physiological cupping with normal OCT. This is a case of advanced glaucoma who presented in 2016. She was already on maximum medical treatment, and she underwent trabeculectomy, phacotrabeculectomy in both eyes. This is almost stabilized now. She is on a single anti-glaucoma medication. So once it has reached that level, then OCT actually doesn't have much role in assessing progression. This is her daughter's this thing, but she also had a cupping and high IOP was there. She is abroad and she is already on anti-glaucoma medication started from there. But she is being followed up. Actually, the OCT is showing some yellow, some thinning is there, but we are just following her up. This is a large disc with a large cup. But see, the OCT is showing slight thinning here. This is again, patient is being followed up, not started treatment yet. This is again another myopia. You can see that there is generalized thinning here. See, generalized thinning here, and there is a, actually there is thinning here. There is 0.85 cup and a 0.7 cup. Patient is actually abroad. He is in US, so he comes once a year or once in 2 years. He was having a borderline IOP of 20 millimeters. So I had started him on latanoprost, explaining that he has to go there for follow-up, but not yet started following up there. But this year, anyway, he has agreed to go for follow-up because, as you can see, the field started showing some defects here, which is not corresponding to the changes, but some defects. Even on repeating the field, it was there. So I have advised him to undergo regular follow-up. This is again another myopic case. Actually, this is actually two OCT reports 5 years apart. So you can see that the progression is evident even without a GPA. You can see that it is showing progression here. And the fields are also left eye slightly progressing. So the lower ones are the 5 years later. So you can see that it is showing progression. It is comparatively more damages there. Within the ONH, now certain parameters have come up, like the lamina cribrosa, that is the cupping, the measurement of the depth of the lamina cribrosa. So this is actually a preoperative and a postoperative picture. You can see that the depth has come down, it has become shallower after operating in POAG and PXF. This is also, see, high IOP and then moderate and a normal IOP. So the lamina cribrosa may prove to be an important parameter for assessing progression. Now you have to have an idea about, I know that time is running out, maybe 1 minute more. Artifacts are something you have to be aware of. That is, you have to be aware of the red and green disease. Red disease is a false positive diagnosis. No glaucoma, but all over red. Green is sometimes false negative. It can be due to a device-related artifact or a normative database. And myopia is one of the common cause of red disease. See, there is no glaucoma, but it's red. This is diabetic macular edema. So the macular edema, but this is a clear-cut glaucoma case with field defect and dischanges, but you can see that it is appearing green because of this macular edema confounding the RNFL thickness. This is an unscanned area, so it is coming as red. But when the field was repeated and with proper scanning, it is showing the normal result. With unscanned area, you are getting a floor effect here in the Disney map. This is actually before cataract surgery. So the results are not clear, but once after the cataract was done, see, you can see that it's clearly seen all the results. This is actually a motion artifact. You have to follow the blood vessels, see whether they are continuous, and you have to exclude such films. And see, you can see here also there is the missing data. This area was not scanned. So that is appearing as red. It is not due to real RNFL thinning, but due to the unscanned area. Similarly, here also motion artifact producing red areas. This is a keratoconus with and without RGP. Only with RGP you are getting the proper result. Here it is not clear because the amount of light entering is limited in keratoconus without RGP. This again a VR traction, again confounding, you are getting very high values. Here also it's a V-ring appearing in the center, see, that is producing a floor effect, and then that is when the eye was moved, that has disappeared. So identification of the, this is an optic disc drusen. And poor image quality is also, you have to look at the signal strength. If the signal strength is less than 6, then it's better to repeat. And the signal strength may be low in patient factors like dry eye, refractive opacities like cataract, fixation disorders, etc., or device factors. A lens may be dirty, the machine may be very heavily used. So that also you have to look at. So always look, never look at the color, never go by the color, red or green. You have to look at the OCT in toto, and you have to reach a diagnosis. And it is always, remember that glaucoma is an asymmetrical disease. You don't get a symmetrical data in both the eyes. And all the artifacts you have to keep in mind. And output always clinically correlate. The data should be always consistent with the clinical data. And technicians should be trained, and they should be trained to identify the artifacts, and if required, they should repeat it. And all the ocular comorbidities, macular abnormalities you have to keep in mind. And always correlate clinically. Thank you for your patient listening.
Thank you, madam, for that very detailed talk. Our next speaker for the day is Dr. Bindu Ajit, madam. She is the head of glaucoma department, Comtest Eye Hospital, Calicut. She is also the secretary of the Kozhikode Ophthalmic Society.
Thank you.
Over to you, madam.
A very good morning, and thank you for this invite. So to start with the basic, the general principle, we know it's the low coherence interferometry, where a beam splits the light into two, and then one goes to the reference mirror and the other goes to the object what we have imaging, and the light that comes back is the difference in the reflection is what is the image that we get. It is, the evolution has started from Visante, and now we are in the era of Cassia. Now what is the basic difference is, the longer the wavelength, better the tissue penetration, but more the penetration, you have lesser the resolution. But the advantage here is, with the swept source, we get more number of images. The speed of image is so much that we get to see the whole 360-degree and phase image of the angles. Now, why do we want to do an ASOCT? The basic reason is we are lazy and we don't want to do the gonioscopy, and which it shouldn't be. It is basically for the quantitative assessment of the anterior chamber angle, and also to better understand the pathophysiology of the angle closure disease. Now, when we take a picture of the ASOCT, like how does this help us to assess the angle? The first basic thing what we have to identify is the scleral spur. It is the inward protrusion of the sclera, the junction between the inner sclera and the corneal curvature. What it is the surrogate of the trabecular meshwork which is in front of it. So we have to identify that, and only then the question comes like, if the angle is open or closed. But what is the consistency of visualizing the scleral spur? It is not always that we find the scleral spur, and studies have shown that only 72% of the time we can identify the scleral spur. Now, the other parameter that we look into is the anterior lens volt. Now, that is the line joining the scleral spur and the anterior most part of the lens. This is the anterior lens volt. It alone doesn't give you any information. You have to take it in consideration with the line that is the anterior, the whole vault also. Because the lens vault in relation to the anterior chamber depth is more important for us. So that is the relative lens volt, ratio of the lens volt to the anterior volt. Now the studies have shown that excess anterior lens volt, that is when you compare the lens volt to the anterior lens volt, if it is more than 1/3, then there is a risk of angle closure due to the lens itself. Now, the next thing what we want to see is, we want to see the orientation, or which side it is, or which angle we are visualizing. Here you see this is the nasal and temporal. So you get to see the nasal and the temporal. And here also you can visualize the superior and inferior angle. And you can always, when you take the inferior angle, the lid comes to hinder the view. But then we can retract and then take a view. This is the superior and inferior angle. Now the other parameters, there are n number of parameters which are all used for the study purpose. Like I already mentioned, the most important is the lens volt. We know that higher the lens volt, there is a risk of angle closure, and the lens is the culprit, and we are all happy to remove the lens. Now the other thing which is this anterior width, chamber width, that is the line from this scleral spur to this scleral spur, and this whole area is the anterior chamber width, and it is an independent risk factor for angle closure. Now the others, studies have revealed that like iris parameters like the iris thickness, iris curvature, and the iris area, they're all individual risk factors for angle closure. So all these measurements are available from our ASOCT. So that is what the difference we get from a gonioscopy here. Now how do we define an angle is closed in a ASOCT? I told you this is the scleral spur. Any area of contact between the iris and the cornea in front of the scleral spur, you define it as an angle closure. And here it is open. Here you see the scleral spur, and here that is the area of contact. This defines the angle closure disease. Now what we basically want to do in ASOCT to understand the pathophysiology of the angle closure. So it could be a pupillary block, it could be a plateau iris, it could be a lens volt, or it could be a malignant glaucoma. Now we'll just look into some of the examples. Here you see, this is this pupillary block, and the space between this is less. This is more of a pupillary block angle closure. And this is more anterior placillary body, and this is a flat iris and a plateau iris. So that is what you see in a gonioscopy also. And here you see the iris is pushed forward and the whole lens is thick, and this is the high lens volt. Sorry. This is the high lens volt. You can see the characteristic of the iris here. It is like this. And for your pupillary block, it is like this. So that is the basic difference here. And the other one we know is the malignant glaucoma, where there is a contact here and there's a posterior direction of the aqueous. So that is how we understand the mechanism of angle closure in that particular patient. Now we come to some of the other uses of ASOCT. Here, this is a post-PI, a fully patent PI, and here you see the PI is not patent. So these are additional information that we can get from an ASOCT. Now is the era of ICLs, and here there is an angle closure by the ICL, which can be picked up by the ASOCT. Now, this is a story of a bilateral anterior subluxated lens. Yes, we could pick up that in ASOCT also. And you could also get information regarding the weakness of the zonules and plan your surgeries accordingly. A better planning of the surgery. Now, most of its use is in trauma cases especially. So this is a case of a trauma. And here, with a macular injury, and this is what we saw in ASOCT, there is a posterior subluxation of the lens. And this is the angle recession. You can compare both the angles, and this is the angle recession in the ASOCT. Now, another case of trauma where the lens is subluxated anteriorly, and this is the anterior subluxation which is picked by the ASOCT. When there is corneal edema, when the IOP is very high, you won't be able to visualize. ASOCT comes handy at this time. Now, this was a child who was sitting in the lap of his grandfather in a car, and with an RTA, with an airbag injury, with a lamellar corneal tear and hypotony, but Seidels was negative. When a child to do a gonio, and especially in a hypotony, it is very difficult, we know. And on ASOCT, found the cyclodialysis cleft. So this is the cyclodialysis cleft. Now, when we do trabeculectomy, we want to know whether the bleb is functioning. So even in that cases, ASOCT comes in handy to assess the bleb morphology. You can see the cavities filled with aqueous, the flow, the sclerotomies, and if there is any PAS, if there is any ostium block with the PAS, all can be looked up, and also the amount of fibrosis. This is a functioning bleb with lot of spaces, and this is a large only cyst and lot of fibrosis and a failed bleb. And also this is a post-trab where the ostium is here, there is a PAS that is occluding the ostium. So all this could be picked up via ASOCT. We want to see the placement of tubes and valves, whether it is touching the corneal endothelium, causing any corneal trauma. So this is the tubes of the valve, which is well centered, not touching the cornea or the iris. So that also we can visualize with an ASOCT. And this is a post-GDD presented with hypotony and corneal striae. Was it a tube touch? No, it is well placed in the sulcus, but he had a CDs and ciliary effusion. That was the cause of the hypotony in him. Now, the role of ASOCT has got a tremendous or helped us much in this disease complex, which is the drug-induced angle closure, which is very common nowadays. So this actually is a case of phacomorphic glaucoma, then presented with hypotony. It was a diamox-induced ciliary effusion. So this is the ciliary effusion which you see. So this is the phacomorphic, the fluid-filled AC. Again, this is a post-myringotomy, single dose of diamox given, presented with bilateral AC shallowing and a ciliary effusion and forward shift of the ciliary body. So that was the cause of the raised IOP, and it is not an acute angle closure. So unless you do an ASOCT, you cannot diagnose this. So that is the amount of effusion here. So both eyes. Now the other group of drug is the antipsychotic drug. So this is a shallow AC, and here again you see an effusion presenting as acute angle closure glaucoma. And here you can also see a subluxation of the lens. That is also known to be produced by antipsychotic drug. This patient ended up in TRAB with phaco surgery because the lens was also subluxated. So all this could be picked up only with an ASOCT. Another, again, patient with bilateral angle closure. Again, these are drugs which we have to be very careful, and patients may not come out with the drug history, especially in psychiatric. And there are a lot of CDs also in this, causing this choroidal folds and hypotony also here. So this is the amount of effusion that drug is induced. Now the most common one, the topiramide-induced angle closure in both eye. Again, the amount of effusion you can see. This is the Visante picture. We had the older Visante picture actually. That is the difference here. So again, why do we want to identify whether it is drug-induced? It's mainly because the management is totally opposite. Where if it is an acute angle closure, you treat with pilocarpine. If it is drug-induced, you have to go with a atropine or homatropine cycloplegics. So that is why we have to have the diagnosis to start the treatment in these patients. Again, this is a post-nephrectomy patient. Single dose of Diamox. See the peripheral CDs here, and you can see the effusion here. So even when you give a Diamox, be aware of this situation, because we use Diamox without knowing this complication. Just stopping the Diamox reversed everything. Now this is another case, again, bilateral shallow AC, but ASOCT revealed an effusion here. Again, B scan. Always when bilateral angle closure, do an ASOCT, do a B scan. See, there are multiple exudative RDs here. And this was a weak age presenting as bilateral shallow angles with increased IOP. Another culprit is the posterior scleritis, which again presents as a bilateral angle closure. And you can see the B scan picks up the T sign and ASOCT picks up the ciliary effusion. So if you just see this angle closed and go for a PI, your diagnosis is wrong and your management is wrong. That is when ASOCT helps you. So this is another interesting case where the patient presented with acute angle closure and we did a PI. But actually it didn't have any effusion as such, but this is a rare cause of angle closure glaucoma, so I thought I'll just present this also. After PI, we did the IOP was not coming down, so we did a dilated fundus examination and something abnormal like this. This is the dilated vessels there. Your diagnosis could be either CCF or an anophthalmos. That was what we suspected, and the investigation on that part was done, but the anophthalmos was ruled out. But we ordered an MRI, and the diagnosis was something very different. It was a craniofacial fibrous dysplasia, which is causing the venous congestion and AC shallowing and producing the angle closure, and literature search showed a rare cause of the similar presentation, 2 publications. So this is also, like when we go and investigate more, we find more causes. That is what I want to summarize here. And this is another case. It was presented as acute angle closure glaucoma, referred as an acute angle closure glaucoma case. But to our surprise, there's some amount of proptosis and chemosis. Yes, with lead edema, acute angle closure, yes, you can have this. But then on an ASOCT, we found a lot of effusion here. And then B scan also showed CDs, increased RCS thickening complex, and on MRI, the diagnosis was an orbital cellulitis presenting as an acute angle closure. So this is the wide range of disease which can present as an angle closure glaucoma, which could be only picked up by investigations like ASOCT. So sometimes we are having cases like this where you don't know the details of what is underlying that. Again here, ASOCT can give you details of the anterior chamber, like the posterior synecdoche, the adherent iris. If you're planning for PKP, you have to take this also into consideration. So that is what the informations you get. It could be a virtual gonio. I am much ahead of the time. I didn't notice it. Just one more minute. So since you have a new kid at your hospital, you want to explore more and more. I don't think I have time. I just wanted to ask the PGs actually this. The orientation here it is. This is superior angle. This is inferior angle. So this is the orientation here. This is something in the superior angle. Do any one of the PGs want to take a guess here? Yes, very good. So that is the silicone oil here. That is the inverse hypopyon. Just have a look of everything so that you can get a feel of it. So this is, we now do a lot of MIGS, so I just wanted to see what is happening in the angle after the procedure, and that is what I was seeing in the ASOCT also. Now the prominent Shalby's line. How does it look in an ASOCT was the curiosity which I had. So this is the prominent white line here. That is the prominent Shalby's line. So this is a very obvious iridodialysis, but still have a look at it. So is this an iris cyst? No, it is an ACIOL producing that pupillary block element. This is the lens here. So to summarize, yes, it helps in documentation and patient education. Definitely patient understands much better, and also add information on understanding the angle closure disease. It's a black and white picture, and your gonio picture is this. So it is not that you replace your gonioscopy, but see the clear pictures of NVIs and PAS, the extent of PAS, all this cannot be seen in an ASOCT. Gonioscopy still continues to be the crucial and integral part. ASOCT gives you more information to that only. Thank you so much.
Thank you, madam, for that detailed talk. I'd like to invite the speakers, Dr. Preeti madam, Dr. Girja madam, and Dr. Bindu madam on the dais for the panel discussion, please.
Good morning. We had excellent and insightful presentations on the different diagnostic aspects of glaucoma, which is highly essential in the modern era of diagnosis of glaucoma. And finally, at the end, we always learn that always correlate clinically. That is very, very important. And now it is open for discussion. I'm sure the audience will have several questions to ask, and the experts are here to answer the questions.
All ICL cases, do you do ASOCT to find out how is the posterior surface of the iris? I'm just asking because we have been told like that and we are trying to do. Because we get some cases with irises which are rubbing on the ICL and causing a lot of pigment dispersion. And nowadays we have started doing it for all cases. Do you think it is relevant?
No, only cases that come referred to glaucoma department with IOP high we investigate. Otherwise not in pre-ICL. Pre-ICL, yes, they refer for assessing the gonioscopic angles. Yes, they do. But we don't do ASOCT in all cases. But we try doing gonioscopy in all and see whether the angles are.
We do in all cases ASOCT, but the problem is the resolution behind the iris to get it a bit difficult. That's very, very important, as you said. And another one thing I just want to put into is when you do an ICL, long term, as a lens thickness increases, they can also present with angle closure. So we must always rule out for the cause for angle closure. Is it the ICL is also a problem?
All the deliberations were excellent. Just I wish to ask you, you have shown me one case in which you have performed trabeculectomy and later on it is a neurological defect as well.
Sorry, I didn't get your question.
One case you have shown that you already performed trabeculectomy and later
yes.
on neurological deficit has been detected later on.
No, in that patient there were two different patients. One patient had a glaucomatous damage and the other patient had a pituitary adenoma which was long standing, and so that's why there was no strict hemianomic defect. It had filtered over onto the other side also. I always mention that compare with the disc. The disc in glaucoma, the disc will correlate with the visual field damage. But in that particular case, because I had operated, there was reversal of cupping. Earlier
Cupping,
the patient had
usually
a
we
complete
don't-
optic. Yes, so that time it will not correlate with the disc and you will be confused that there is pallor and there is damage. So is it neurological? Is it glaucoma? So in this particular case, wherever in a few cases you do have reversal of cupping after the intraocular pressure goes down, and that is the time when it will not correlate with the disc. The field will not correlate with the disc. So they were two separate patients. But yes, a similar scenario can occur. One patient which I showed had glaucoma and had a neurological defect on top of that. That's
Fine. So always we have to be very careful.
Very careful,
while
yes.
seeing the disc and proceeding.
That's right. Yes.
All the talks were excellent.
What if the patient is already having glaucoma but developing a neurological condition? In that case, actually I had a patient like that. She was under follow-up for so many years and MRI was taken in the initial stages because she was young then, around 50. But later she developed a neurological tumor and then the field worsened. How will you advise following up such patients?
So one is whether sudden worsening, yes, which my patient had. In 2 hours, she said my vision has dropped and MRI came normal. And I was very, very surprised. How can MRI be normal? But then I read up and I realized that in very acute cases, the MRI will be normal and the infarct will show up only after after about a few hours. That's why I repeated. But neurological tumor, this was vascular. If it is a tumor, it will be a slow, gradual diminution of vision. So, and there will be diminished vision plus the defect will enlarge. And that's why in glaucoma, you should continuously, whether the patient is symptomatic or no, do serial fields, maybe every 6 months, maybe every 1 year, depending upon how much the damage is. Then you are able to pick up.
Dr. Ashwin.
Yeah, so I think to continue the same discussion, sometimes it's very difficult, especially in tumor, because glaucoma and tumor both are gradually progressive. However, not only on fields, but if you look at the clinical picture, in glaucoma, because it's predominantly a disease of an arcuate fibers, your color vision continues to be normal till very late in the disease. So if you have, as Dr. Priti very rightly said, that if the disc and fields are not matching, one of the clinical ways, before you embark on MRI and acute stage, you have to do the MRI, as he said. You look at the pupils and color vision. There is a very high possibility that if tumor is asymmetrical, patient would have RAPD. Glaucoma also can have RAPD, but the cup disc ratio difference between the eye has to be more than 0.4. So if you have a CD ratio difference between two eyes less than 0.4 and you find RAPD, think of neurological. As she said, there are no clear-cut rules, and look at the color vision. In a compressive lesion, color vision will go early because very high chance that papillomacular bundle gets affected early.
Also one more thing, that vision. I have had patients with tubular vision and they say, you are saying I have low vision. I am able to see everything. But in a neurological case, the patients are aware that their vision is dropping. So one more thing.
Yeah, just adding to what Sir told, we had a case, sometimes this AON will be mistaken as glaucoma because even if you do a fields, it will give an altitudinal defect And some cases of normal tension or low tension glaucoma might come close to the fixation point also. So it will actually give a similar picture when you do the perimetry. But like sir told, doing a color vision and a pupillary reaction can actually give us an impression like whether it is more of a compressive or ischemic lesion or a glaucoma point of view.
And the visual loss
Vision
also
loss.
is sudden.
Sudden vision loss, yeah.
We had a patient who was treated as a low tension, normal tension glaucoma for a long time. And then when she developed some headache and abnormal behavior and slight pallor of the neuroretinal rim, an MRI was taken and it was shown to be frontal lobe meningioma. So these compressive lesions also should be taken care of in any patient who presents with normal tension glaucoma. So what are the red flags that you will think of a neurological cause rather than a glaucoma alone?
So first would be, there have been patients, just one, can we just reduce the light there really on the eye? These two lights, please. Please. Thank you. Yeah, that's nice. So first is the history. As I said, we are not looking at fields or thing in isolation. The history, but there are many times when I have seen patients, no neurological deficit. For 20 years, she was referred as glaucoma. But one is vision loss. Second is color vision, as Dr. Rashmin Gandhi mentioned, color vision. Third is asymmetry, does not correlate with the disc. The rapidity with vision loss occurs, the field loss occurs. Those are red flags, and temporal field being affected more than the nasal. These are, and color vision, these are the red flags that maybe this is not glaucoma. Just look at the other eye, just look in more detail and do an MRI. So normal tension glaucoma is, it's a actual headache to investigate because they spend a lot of money on investigations. You will do a diurnal variation, you will do 24-hour ambulatory blood pressure, MRI, carotid Doppler, and then when you exclude every single thing, including angle closure, that is when you say, okay, this person has normal tension glaucoma. That's
the field, the threshold value also may give you a clue. Actually, that will be 0 in neurological. Whereas in glaucoma, even the black scotoma that you see may be having 20, that is actually compared to the normative database. Actually, there is a dense scotoma that is seen in neurological field also.
And also the eyes post-acute attack. They might actually give a pale neuroretinal rim. So that is another thing where you might be confused whether it's a neurological case or a glaucomatous case, because it will be a little more pale than how an open angle glaucoma looks like. Again, I think a perimetry would definitely help you to actually distinguish. And in any glaucoma case, there is actually no harm in ruling out the neurological pathology if you suspect, because most of the time we miss that. So there is no harm in working it out and getting an MRI done if you actually suspect, but not in every case.
That's what, yeah. So that's why your clinical has to be so strong. So acute angle closure, I have seen many presentations, but as a vision recovery, when there is an acute angle attack, sometimes in some patients, you get vascular insufficiency. And after that, they do not recover their vision, and the optic nerve becomes pale as you would get in a NAION, that kind. But in many patients, there is no vascular insufficiency. You control the intraocular pressure and they get good vision. So these are two kinds of, what you are talking about is the second one. And if 5 years later the patient goes somewhere else, that is when the person will say, oh my God, the disc is not correlating, it's pale. So yes, you are justified in doing MRI, better safe than sorry, but not in every patient.
I hope there are no more.
So take-home message is never interpret these perimetry or OCT alone. Always correlate clinically, because you can misdiagnose and mismanage many cases if you are not correlating it clinically. Thank you all the speakers for your excellent presentations.
Thank you, and
and
have a good
audience
day.
for your active interaction.
Thank you. Thank you to the speakers and panelists. I would like to present the speakers and panelists with mementos as a token of appreciation. I request Dr. K. Ramachandra Bhatt sir to please do the honor for us. Sir will be awarding Dr. Preeti Kamdar. Dr. Girija K. Dr. Bindu. Dr. Jyoti PT. And Dr. Mithun Tulasidas. Thank you all. It's been a pleasure and a privilege to have all of you with us today. Please stay back for a group photo of the session.
While the photo session is on, we'll lighten up things after a heavyweight session. So I'll be asking a riddle. Anyone can answer. The rules are according to the Indian democracy. The loudest shouting person gets the prize. There are more than one shout. It will be a tiebreaker, number guessing. Deal? Okay, here we go. When I am there, the liver is usually messed up. I love to be golden, brown, gray, or green. I got 1, 2, 3, 4 answers. Okay, now I'll think of a number between 1 and 20. I'm closing my eyes. Whoever says the number will get the prize. Okay, here we go, shoot. Who said 12? Well done. Time permitting, I'll be back after the next session. Thank you.
So we go on to session 2 of OCULUS 6, which is Corneal Diagnostics and Optical Biometry. I'd like to invite the panelists. Dr. Jason VA, I'd request you to please occupy the dais. Sir is Chief Medical Officer, Jyotis Eye Care, Kannur. We have Dr. Vijay Lakshmi MS, Senior Consultant, Corneal and Refractive Surgery, Comtrust Eye Hospital, Calicut. Next we have Dr. Anjani K, Professor of Ophthalmology, Government Medical College, Calicut. Our first speaker for the day to speak on topography is Dr. Jagdish Kumar Reddy. Sir is Director of Shankara Eye Hospitals, Coimbatore. And sir is been a regular speaker at our OCULUS series. And thank you, sir, for gracing us once again.
Thank you for the invitation and good afternoon. Good morning only. So the talk is today, my talk is on, can you shift? Yeah. So corneal topography. This corneal topography is, for example, you take a OCT or any other thing, a scan by ultrasound, it is the same instruments we are doing. But if you take a scan, you can do with ultrasound, you can do with now OCT based one, either swept source or like that. In corneal topography also the data is collected in different methods. It's not all topographers don't take the data in the same way. So I just introduce that. I don't go much into the details to try to be as, so I don't want to load you with too much information, so the one enters, the other goes off. So few points I try to restrict. So we have three methods right now. We have three. One is the Placido one, which one started long time back. Placido is there for a long time. Only thing is interpretation, they have done it digitalized interpretation. Instead of just visualizing with your eye, the Placido disc, they interpreted computerized interpretation. That's computerized anatomical corporation. They started in US, they designed the first one. The second one is the Scheinflug. That is usually the technology used in military applications for topography mapping of the earth by the geography to document that. That is the technology which they are using in Scheinflug. And the last one is the OCT based one, just like our retina. The Placido, as you saying, simple rings. It's a day. What is the advantage? It just takes a fraction of a second. Just give a shot, that's all. So the patient has to look straight here also. If the patient looks somewhere little bit up, little bit down, why it will happen? Patient have a tropias, phodias, or they can have amblyopic eye, they cannot see the light, or high powers, 6, 7, 8, 10 powers. Because you are taking without spectacles, they cannot see fixation light as a small source. The light will looks like a unfocused white one. So we said, look at the light, look at the light. But problem is, a -8 fellow, -9 fellow, you put a +10 in front of eyes and see a light, a fixation light. You can't see it. So he can't see that because he is not having a focusing without spectacles. So these cases, amblyopia, macular problem, they cannot see it. So they look somewhere else and you get wrong readings. So you should be prepared for that. First, you should understand the patient, then only you can interpret the topography. That advantage is fraction of a second. Just a second, you get the map. So that the computer will interpret. So we have a compact units, we have a well-suited units. Many companies are making. The first one is the Tomy, CSO is very good one. So these are very good instruments. Very reliable, very good. The data is perfect. So you get a ring like that from the cornea. What is important here? The opening of the lids. A ptosis, you can't get good results. Or even lower scleral show and upper lid comes down, they can't get it. So all this, there are some issues, or dry surface, because it is a reflect based. So it's based on the reflection of the cornea. So you need a very good cochlear surface. You put a shimmer test, then take it, the abrasion, you don't get corneal abrasion. And you get too much tears, you can't get, because all the tears will produce irregular reflex. So this should be, first you should finish that, then you should go for all this fluorescence staining. Shimmers are all for your Lasik patient screening. You should not touch the eye, you should not do anything. First take the one. And the upper lid, you retract, try to take it, more reflex tearing, they blink it and you get wrong readings. Somehow we have to manage it, and looking up face, turning the face up and down, you have to get the at least 8 millimeters cover is good enough. This is the Scheinflug based one. Here you don't see the rings, okay? The one is the center one is the slit beam, rotating slit beam. The bottom one is the camera. This is a rotating slit beam. Usually they use a blue color because scatter is less. They use a blue color slit beam and it rotates, camera rotates. So this is a close-up view. It becomes vertical, rotates. So there is some noise and rotation. So it brings the attention from the patient. So once it starts moving, they try to look into that. Okay, it brings a little bit attention to the patient. So we have to inform them, look straight, don't, you'll have some noise and everything. It takes some time, few seconds it takes. So 3 seconds to 6 seconds it will take depending upon the cue. So that much time patient has to not blink, should look straight and should not move the eye. So these are very important. Not like in Placido. Placido just takes less than a second. So you get maps like this, the scans, 16 or 32. So that depending upon, we can set it, how many you want, you can take the maps. So these are basically, it's not reflectometry, no radius, nothing. These are the elevation maps, how much the cornea, how it is. So these are all reorganized by the computer. Each section is reorganized in 32 sections and it forms a shape. That shape it will take, then it will calculate the radius of curvature and everything for the data interpretation. You get additional information, ACD depth and what is the curvature, how it looks like, and the cornea, how is the shape is looking like that. You get this, what is the corneal thickness. So all this additional information you get when compared with the Placido disc. Placido you don't get anything, only anterior corneal surface. Here you get this additional posterior corneal curvature, or you get additional information in this Placido. There are some companies like CSO. They attempted, these are hybrid. They have a Placido and they have a shine fluid, both with the same machine. So what they does is they take as Placido and they do shine fluid. So you get the thickness, and wherever you can't get in Placido, for example, nose obstructing the field, that area will be filled by the shine fluid image. So you have both the things combined in a single map. So these are becoming more popular now. And this one, the third, as I told you, the OCT based one, anterior. Here, no moving parts. Okay, there are no moving outside, no lights like in Placido, no irritation for the patient, and everything very comfortable. Patient has to look, but it takes some time because these are also slit scans. So the OCT will do scanning of 32 or 16, whatever you want. So that again, it will make a shape. For example, you get scans like this. These scans will be reorganized just like a shine fluid, and you develop a map. Here also you get additional information, thickness, ACD, angle, all into extra information, you get it. So coming to the interpretation of the maps now. So be brief, this Placido based one. How the Placido, we have to look at the rings first. Without looking at the rings, we should, even a small mucous thread on the cornea will show it as an abnormal, totally abnormal cornea, because based on the reflection, so the mucous thread will give a lot of irregular. So they say cornea is bad, it will say, even the small. So we have to first look at the rings, then you have to look at the findings. Here in Placido based one, you get a keratoconus screening program and severity incorporated in all the machines. Most of the machines, Tomy all. Some machines they don't give Shinnipan like that, very simple low cost machines, remaining all. So it will give both similarity, how much it's similar and why it is similar, which index is bad, opposite sector index or surface area analyzer, what is wrong with this, it will give. And it will give what is the severity also. Is 51, some scoring it will give. So next time when the patient comes after 10 years, you take it after 2 years, looking at the score, you can say it's becoming worse, it's becoming good, what is the one, what has happened. It is a very useful instrument, these Placido based ones. So then it comes the Pentacam. This is a shine fluid, one of the gold standard. There are many machines with shine fluid, but Pentacam is the gold standard. You have a lot of maps, but mostly we see look at the only 4 maps, quad map we call it as. And you have a lot of data here. Pupil center, where is the thinnest and what is the K-max, all these readings. So looking at the map, you have a pachymetry map and you have a whatever you want, but usually you put axial or sagittal curvature, posterior float and anterior elevation, posterior elevation. We call it a posterior, how much it is elevate, the cornea is away from the ideal spherical shape for the cornea. More than 14 microns, 20 microns, if we take it as problematic, 12 microns, okay, like less than, and 18 we take posterior elevation, it's a really keratoconus interpretation. And then comes the bad, Bellina ambrosi enhanced ectasia display in this. This is the screening program for that too, this is not, the Pentacam was not made for keratoconus progression, dissection, disease management or for detection. They designed Pentacam to exclude not suitable cases for Lasik. So the purpose of mission design is different. So they want to exclude cases that are not suitable for Lasik. So here in this program, it will never say it's a keratoconus screening program. Okay, it's a ectasia display, it will say. Then it will give all the readings and all this one, and ultimately it gives a D value. This D value in color coding also they give white, yellow and red. So if the D value comes around 1.6, 1.8, they say it's okay. That again age dependent. If 20 years old 1.8, they say it's not good. If 30 years old for 1.8, they say it's all right. If 20, 18 years, they say even 1.6 be suspicious of keratoconus. So 1.4 is good. Like that, they keep on changing the values. But these are all just there. They don't publish, they don't do anything. When you ask them, they just tell, that's all. So here, it will never say what is the keratoconus. It is similar keratoconus patient. Pentacam will never give you saying this patient is having keratoconus, similar to keratoconus or severity of keratoconus, nothing it will say. It will just give some values, and based on the values, you have to think it's a keratoconus or not. It's left to your decision. Then comes to the anterior, OCT based ones. These are the latest ones. So here also comes many maps, but usually we select the quad map like that. One is the curvature, one is the thickness, posterior and anterior. And it gives extra information, epithelial thickness. What is the epithelial thickness it will give? And the scoring. Here the scoring pattern is completely different when compared with the pentacam or with the corneal topography of the placido disc. Here they take a different. Anterior K-max, this more or less like little bit towards the placido based one. So anterior K-max they will take it, and anterior K-max opposite side. If the K-max is up opposite side, what is the K-max? And inferior superior difference above and in the inferior, what is the opposite sectors. Always cut the cornea, take in the opposite side what is happening, look into that. So for that they will give the value, and they will give thinnest point, that what is the thinnest cornea. Placido you don't get thinnest value, so that parameter is not there in placido, that I have included extra in this. So you can put it in the keratoconus screening program. You got a here cornea ectasia report. You change to that, it gives a rad map. I don't know how many of you familiar with rad map. These are the one now everywhere, for everything is represented in rad maps. Radial map, you can have any number of ones. Here they have taken only 6 parameters. You can have 10, 20, even anything you can do rad map for your finance, for anything you can do it. Even simple, your health, all you can do rad map. So in the rad map, it will show you which are within the limits and which one. This one, it will keep on occupying if there is something abnormality. The score they give it 0, less than 0 is good, 0 to 1, plus 1 is suspicious, above 1 it's definitely keratoconus. But the report will never say this patient is keratoconus. Okay? Is only like pentacam, your interpretation. Whereas a keratoconus or non-keratoconus, it won't say. It will just say ectasia score. So even ectasia score also, it won't say anything. It just gives a red line, like a police red line, it will give like a signals, that's all. So then we'll see what happens in pentacam. Same patient, we put on pentacam, put on this one, the other machines, what happens. For example, this is a definitely keratoconus. Anybody will say opposite sector is got. And the thinnest cornea, reasonably good, not bad. 500 microns, that's pretty good. It's not bad for Indian standards. So, but posterior float is going up. So you put that for ectasia map. Then it will show index of very high, and all the reds. They change it to red, this is suspicious, this index is okay, like this out of the 5. White one, this is pass through, that is thickness. For 500 is pass through. Nothing to worry about that. But elevation is bad, and everywhere totally the D value is gone up and gives a red, saying that this patient is bad. You should not touch this patient for Lasik. Same patient, I put same patient on anterior. So it is also shows maps here. Then you go for the score, it will show the value is high and K-max is high and everything high. Thinnest package, so it's yellow. It's all right, 530 and everything. Then you put on the scoring, the rad map all becomes, you see this parameter is high and K-max is high. Thickness is okay, like 500 it has gone up to green it's touching, remaining all abnormal. So in the rad map you can see these are all representation of statistics, that's all these maps. So the opposite eye, when you want to check it, it will also show the score is almost 8. Though it looks not that bad, the score has gone up because of anterior K-max and opposite K-max. These are very high. Thickness is good and anterior irregularity is good. Posterior elevation is high. These 3 parameters has pushed it up to 8. Then for example, it looks very subtle. It looks more or less okay. The Pachy is very good, 518 Pachy. So it looks like a symmetrical bow tie, a little bit small apart from that. So you want to test, but it's showing the score is high. When you put an ectasia scoring, where is wrong in this? So it says the posterior elevation is wrong. So the K-max is good, opposite K, difference, astigmatism, that difference also very good. Only thing is inferior superior is a little bit abnormal, and anterior irregularity also is good, surface. Only thing is posterior elevation is wrong, so it is a suspicious keratoconus, 2.8 is the score, so definitely a keratoconus patient. So same patient I put on pentacam, what it will show. So the pack is very nice, 525. So little bit 44.6, 47. This opposite sector little bit different. 1.2 is all right. Above 1.2 suspect. Then you put on the extra match. It says posterior elevation and anterior elevation, and then posterior. Then you go to the D value. D value is also very high. All the parameters. Thickness good. 0.037 white. It passed it. Yellow also passed it. But 3 are abnormal and you are landed. So what we got from doing this? So another keratoconus case. So you put them on that. Where is the wrong, we can say. The K-max is good in this patient. And opposite inferior is good, thickness is bad, and posterior elevation is bad, irregularity is good, anterior K-max is good. So each machine is interpreting different data, but the results are the same. All machines able to diagnose keratoconus. But each one is interpreting different data. One is interprets surface, one interprets thickness, one interprets elevation, but ultimately the data was the diagnostic capacity of keratoconus is good. But only problem here is, so the same patient again we repeat in pentacam is also showing the same thing. So then comes the hybrid system. As I told you, Sirius, CSO, this hybrid system. So what they do it, the newer ones. So you take a map. This is a quad map. You can see the rings. So these non-ring parts where you don't get for Placido, this will be filled by the shine fluid. So you get a total map. So this is the curvature, this is the pachymetry and everything you got it. This 476 is the pachymetry. So you become suspicious. Why so thin cornea? It may be keratoconus. But it gives classification normal. The cornea is normal, you don't need to worry. So there is no keratoconus. And why it is normal also, it will give all indices. What is the one, what is the one, what is the red, what is green and everything. So it's pretty easy. So then you put on the keratoconus screening program. Here the button, you click the button, it gives different maps, and again it says classification normal. Why it normal also it explains to you. And keratoconus patient, you put on that, put a screening program, it will say classification keratoconus. This is the only machine that gives classify as this patient keratoconus. Okay, based cornea is very irregular, so this fellow is telling keratoconus. So you put on a patient of keratoplasty, where the cornea is very irregular due to sutures, irregular astigmatism, thickness, not keratoconus. We know it's not keratoconus, but if you put the same patient on Placido or Tomy, it will say keratoconus, similarity of keratoconus. But if you put this machine on serious patient and check it, and this is with the topography, with the pachymetry, and it says classification, it doesn't say classification, it says other. It is not normal, it is not keratoconus, but it is other, some other problem, you check it and verify. So same thing when you put this machine, same patient without pachymetry data. I removed pachymetry data and I told it to classify. There is no pachymetry here. Only curvature, tangential one, elevation and Placido image. Still it says same thing. It is the other, it's not one. So they developed a nice system in this area, so we don't need to worry about whether keratoconus, what is the value, what is the D, what is the P. There is no need to worry. You just read here why it is there. It says so you will get the results. Thank you very much.
Thank you, sir, for that detailed talk. Our second speaker for the session is Dr. Manuelsons from Chaitanya Eye Hospital and Research Institute, Thiruvananthapuram. Welcome you, sir.
Good morning, ladies and gentlemen. Thank you. So thank you, Dr. Sreekanth, for the invitation. And this was a scary invitation because I have never presented on biometry till now. I have been doing biometry, making people do biometry and do cataract surgery. And of late, there was no problem at all. And that's why I have not been looking at anybody's problems. I'm not going to show problem cases, because എനിക്ക് അങ്ങനെ പ്രോബ്ലം കേസ് ഒന്നും കിട്ടുന്നില്ല, ഇങ്ങനെ ഇത് വരുന്നില്ല. അപ്പോൾ ദാറ്റ് ഇസ് വൈ തന്നെ നിങ്ങൾ പിടിപ്പിക്കുക മാഷ, അതിനാണ് ഞാൻ ഈ സമയം കളഞ്ഞുകൊണ്ടിരിക്കുന്നത്. അത് ശരി. സോ ഐ ആസ്ക്ഡ് ശ്രീകാന്ത്, ഇതെങ്ങനെ ശരിയാവും, ഡ്രൈ ഇയാളങ്ങ് ആക്കും മാഷ എന്ന് പറഞ്ഞു. അപ്പോൾ ഞാൻ പറഞ്ഞത് എനിക്ക് വീഡിയോ കാണിക്കാതെ പറ്റില്ല, പ്രസൻറ്റേഷൻ പറ്റില്ല, ഇതിനകത്ത് എങ്ങനെ വീഡിയോ കാണിക്കും? ഓക്കെ ആണോ? ഓക്കെ ആയിരിക്കും, നോക്കൂ. അപ്പോൾ പുള്ളി പറഞ്ഞ് ഇടയ്ക്കിടയ്ക്ക് വീഡിയോയും കാണിച്ചോളൂ എന്ന് പറഞ്ഞു. അപ്പോൾ ഇത്ര നേരം ഐ ഹാവ് നോട്ട് സീൻ എനി വീഡിയോ ഹിയർ. So I will show some videos which may not be connected at all to keratometry. And after JK, very difficult to convince people regarding technology and all those. JK എവിടെ? So corneaയുടെ full doubts towards JK. Jason നോക്കുന്നുണ്ട് ഇതിനകത്തേക്ക്. നമുക്ക് ഒരു പിടുത്തവും കിട്ടാത്ത സംഭവമാണ്. അപ്പോൾ അതുകൊണ്ട് anyway, cornea part we just leave to JK and we'll go to cataract surgery part. So I have no financial interest in this. ഇങ്ങനെ പേരിടാമെന്ന് പറഞ്ഞു തന്ന ശിശിര is here, thank you very much. Hitting bullseye with accurate biometry in cataract surgery cases ഞാൻ ആഡ് ചെയ്തതാണ്, because surgery has to come somewhere, because there's no point in trying to hit bullseye and do bad cataract surgery and you won't get good outcome. Okay, so then after last 1 or 2 months I have been going around the hospital trying to find out what are the instruments being used. അവിടെ ഇവിടെയൊക്കെ മൾട്ടിപ്പിൾ സിറിയസ് ഇരിക്കുന്നു, പെൻറ്റൊക്കെ അപ്പുറത്തിരിക്കുന്നു, പിന്നെ ലെൻസ്റ്റർ, ആൻറ്റീരിയോൺ, അത് ഇത് ആൻറ്റീരിയർ സെഗ്മെൻറ്റ്, OCT താഴെ മുകളിൽ, ആകെ ഞാൻ പെർപ്ലെക്സ്ഡ് ആയിപ്പോയി. ഇത്രയും ഇൻസ്ട്രുമെൻറ്റ്സ് ഒക്കെ ഇവിടെ ഉണ്ടല്ലോ, ഇതൊക്കെ യൂസ് ചെയ്യുന്നുണ്ടല്ലോ. എനിവേ ഐ ഫൗണ്ട് ഔട്ട്, റിയലൈസ് ദാറ്റ് ഇഫ് യു ഹാവ് വെരി കൺസിസ്റ്റൻറ്റ് ടെക്നീഷ്യൻസ് who do good scanning and reporting, then you are relatively safe. പക്ഷേ അവരെ ഐഡൻറ്റിഫൈ ചെയ്യണം, എന്നിട്ട് പോസ്റ്റ് ചെയ്യണം. So that is very important, and I have no financial interest in any. ഞാൻ ഇതുപോലത്തെ ഒരു മെഷീൻ വാങ്ങിച്ചിട്ടില്ല, എനിക്ക് ഒരു ബന്ധവുമില്ല ഇവരുമായിട്ട്. Anyway, so these are my teachers. I remember them before any of my talk, especially PN sir who passed away recently. And to introduce, I know, we all know that precise IOL power calculation is very, very important, because we are doing good surgery. And 6 parts ആണെങ്കിലും ഇങ്ങനെ എല്ലാം, I'm not generalizing, but there are a group of people who come and with grim face and tell 6 blurred കാണുന്നുള്ളൂ, എന്തു പറഞ്ഞാലും ഇങ്ങനെ ഇരിക്കും. അപ്പോൾ അതാണ് പ്രശ്നം. സോ അത് കണ്ടു കഴിഞ്ഞാൽ തന്നെ നമ്മുടെ മൂഡ് ഔട്ട് ആവും, അതാണ് ഈ പ്രോബ്ലം. സോ ചലഞ്ചിങ് കേസ് സിനാരിയോസ്, ഇങ്ങനത്തെ പേഷ്യൻസ് ഒരു ചലഞ്ചിങ് കേസ് സിനാരിയോ ആണ്. ബട്ട് അതർവൈസ് ചലഞ്ചിങ് കേസ് സിനാരിയോസ് ആർ ദീസ്. സോ വിൽ ഗോ വൺ ബൈ വൺ. ഐ എം നോട്ട് ഗോയിങ് ടു ഷോ കേസ് ബൈ കേസ്. ഞാൻ പറഞ്ഞില്ല, അങ്ങനെ കേസ് എനിക്ക് കിട്ടുന്നില്ല, അങ്ങനെ വരുന്നേ ഇല്ല, അതാണ്. സോ principle ultrasound, we use optical and ultrasound, we all know. So who all have optical biometer? Who all have optical biometer here? 1 2 3 4 5 6. അപ്പോൾ അതുകൊണ്ട് ജെക്കെഡിലുണ്ട്. എനിവേ ബാക്കി ഇങ്ങനെ പറഞ്ഞു കഴിഞ്ഞാൽ പ്രോബ്ലം ഇസ് ദാറ്റ് വി ആർ ടോക്കിംഗ് സോ മച്ച് ഓൺ ഓപ്റ്റിക്കൽ ബയോമീറ്റർ വിച്ച് ഓൺലി ലെസ് ദാൻ 5% പീപ്പിൾ ഹാവ്. വെരി വെരി കോസ്റ്റ്ലി ഇൻസ്ട്രുമെൻറ്റ്. സോ സ്വെപ്റ്റ് സോഴ്സ്, OCT, ഇതിനെപ്പറ്റി ഒന്നും ഞാൻ പറയുന്നില്ല. സോ അതെല്ലാം ഇപ്പോൾ പറഞ്ഞു കഴിഞ്ഞു. So we should realize, other than axial length and keratometry, these machines have the advantage of utilizing other parameters like anterior chamber depth, white to white, lens thickness and all those, which go into newer formulae and they give you better results. And newer formulae, it is very, very easy to approach. So prior cataract refractive surgery patients, so we are getting many of them nowadays, is it not? Most of us are getting refractive surgery, post-refractive surgery patients. And yesterday only one patient came and said she had refractive surgery when she was 18, in 90s. In the 90s she had refractive surgery, early 90s. And now she said after a few years itself I got regression, sir. I had 3.5 and all those. Ippozhum 3.5 plus vechana gone. Means 3 plus with plus add. So anyway, prior LVC eyes, topography we heard, topography, we have to do topography. So Placido we know that we don't, and then we have to do an optical biometer. But if you do a good immersion and people are good enough to do it, it's good enough. പിന്നെ ഈ ACRS and APCRS website is freely available, free. Barrett is also free, and they have a formula, a page where you can input all your findings and they will give you. That's it. You have to take it. That's all. It's as simple as that. But patient counseling, you show them, I show them that printout. ഇത്രയും 13 ഫോമുലയാണ് നിങ്ങൾ കാൽക്കുലേറ്റ് ചെയ്യാൻ യൂസ് ചെയ്തിരിക്കുന്നത് ഇൻ്റർനാഷണലി, അമേരിക്കൻ സൊസൈറ്റി. ദേ ഓൾസോ ഡോണ്ട് ഹാവ് വൺ ആൻസർ. എനിക്കും ഇല്ല, അവർ പറയുന്നതേ പറ്റൂ. ഇതാ നോക്കൂ, ഇതിനകത്ത് തന്നെ വേരിയേഷനാണ് അവിടെ ഇവിടെ. അപ്പോൾ കുറച്ച് അങ്ങോട്ടും ഇങ്ങോട്ടും വേരിയേഷൻ വരും. ഇത് പറഞ്ഞിട്ടേ ഓപ്പറേഷൻ ചെയ്യുള്ളൂ, ഇത്രേ ഉള്ളൂ പ്രശ്നം. പറഞ്ഞിട്ട് സമ്മതിച്ച് ശരി തല കുലിക്കുക, ശരി സൈൻ പോട്ട് വാങ്ങണം അടിയിൽ, അത്രേ ഉള്ളൂ. patient counseling, and careful choice. Care എടുക്കാനൊന്നുമില്ല. Don't care എടുക്കുക, എല്ലാം careful. എന്ത് careful? Take only monofocal. Multifocal വെച്ച് കഴിഞ്ഞാൽ പിന്നെ ഇങ്ങോട്ട് വരരുത്, നിങ്ങൾ വേറെ അപ്പുറത്ത് മറ്റേ ഡോക്ടറിനെ വേണമെങ്കിൽ പോയി കണ്ടോളൂ എന്ന് പറയണം, വെച്ച് തരാം. Then we have to tell about this refractive top-up. So many patients are not told this. So if you have a 0.5, 0.75 something, rather than an exchange or something, there is something called a refractive top-up. You can do it after 3 months, 4 months, whatever. That is quite easy, and they can hit emetropia. So everybody knows anterior posterior curvature has changed. So normal keratometry or topographers do not realize this, and there is a change. So as JK was telling, dry eye is very, 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 very common in cataract people. So please do realize that, and then do fresh on the cornea. That is one point. And irregularities, please take multiple measurements. I take 3. First when the patient comes first, and the second when patient comes for pre-op evaluation, one in one machine, one in another machine. So എല്ലാം ഡിഫറൻ്റ് ആണെങ്കിൽ എന്ത് ചെയ്യുമെന്ന് ആരെങ്കിലും ചോദിക്കൂ. അവരെടുത്ത് വീണ്ടും പ്രിൻ്റ് ഔട്ട് എടുത്ത് കാണിക്കും, ഇതാ ഞങ്ങളുടെ മെഷീനാണ്, നിങ്ങളാണ്, നിങ്ങളുടെ 3 പടം, 3 വേറെയാണ്, പോയിട്ട് വേറൊരു ദിവസം വാ, ഒരു മരുന്ന് തരാം, ഗിവ് ടിയേഴ്സ് ആൻഡ് ആസ്ക് ഹിം ടു കം സം അതർ ഡേ. അവിടെ കിട്ടുന്നത് മേ ബി ഡിഫറൻ്റ് ആയിരിക്കും, ബട്ട് ടേക്ക് ദാറ്റ് ആൻഡ് കമ്പയർ വിത്ത് ദ പ്രീവിയസ് വൺസ് ആൻഡ് ടേക്ക് ദാറ്റ്. ടെൽ ദം ഇപ്പോൾ എല്ലാം ശരി, അപ്പം ദേ വിൽ ബി കൺവിൻസ്ഡ്. പിന്നെ മൾട്ടിപ്പിൾ അവിടെ ഉള്ള നമ്മുടെ കയ്യിലുള്ള മൾട്ടിപ്പിൾ ഓട്ടോമേറ്റഡ് റിഫ്രാക്ടർ കാണും, ടോപ്പോ കാണും, എല്ലാം എടുത്ത് വെച്ച് ചെറുപ്ര അടിച്ച് കാണിക്കുക. എന്നിട്ട് വ്യത്യാസം ഉണ്ടെങ്കിൽ പേഷ്യൻ്റ് എടുത്ത് കാണിച്ചാൽ മതി, പ്രശ്നമില്ലല്ലോ. സോ ദെൻ എ സ്കാൻ, ഇമേർഷൻ ആൻഡ് ഓപ്റ്റിക്കൽ ആസ് വി നോ. അപ്പോൾ വീഡിയോ, ഫസ്റ്റ് വീഡിയോ ഇങ്ങനെയാണ്. ദിസ് ഇസ് ഹൗ ദേ ടേക്ക് ഇൻ ലെൻസ് സ്റ്റാർ. യുനോ ഇറ്റ് കംസ് ഓട്ടോമാറ്റിക്കലി, ഒന്നും ചെയ്യണ്ട, എടുക്കുന്നു, ആ സർക്കിൾ കംപ്ലീറ്റ് ആവുന്നു, പടങ്ങൾ ഓരോന്ന് സൈഡിൽ വരുന്നു. ചുമപ്പാണെങ്കിൽ പ്രശ്നമാണ്. ഇപ്പോൾ JK പറഞ്ഞ പോലെ ചുമപ്പാണെങ്കിൽ പ്രശ്നമാണ്, ചുമപ്പ് ഡിലീറ്റ് ചെയ്യുക, ബാക്കിയെല്ലാം എടുക്കുക. വെരി ഈസി. ആൻഡ് റിപ്പീറ്റഡ്ലി സിമിലർ വൺ കിട്ടും. വലിയ ചുമപ്പാണെങ്കിൽ കട്ട് ചെയ്ത് കളയുക, ഇത്രേ ഉള്ളൂ. അത് കഴിഞ്ഞ് ബാക്കിയൊക്കെ ഇങ്ങോട്ട് എൻ്റർ ചെയ്യുക, അതിലും കൂടെ തെളിഞ്ഞു വരും. ഇപ്പം വളരെ കറക്റ്റായിട്ടാണ് ഇപ്പോൾ എല്ലാവർക്കും കിട്ടിക്കൊണ്ടിരിക്കുന്നത്, ഉള്ള കാര്യം പറയണേ. സോ വെബ്സൈറ്റ് ആസ് ഐ ടോൾഡ് യു, ഗോ ടു ACRS വെബ്സൈറ്റ്. അതിനകത്ത് എഴുതി വെച്ചിട്ടുണ്ട് IOL പവർ കാൽക്കുലേഷൻ ആഫ്റ്റർ ഹൈപ്പറോപ്പിക് ലാസിക്, മയോപ്പിക് ലാസിക്, വാട്ടെവർ. ആൻഡ് ദെൻ അതിനകത്ത് ഇത്രയും ഫോർമുലയുണ്ട് അതിനകത്ത്. ഫൈനലി nowadays last 1 or 2 years I have started using the Barrett also. So in Barrett also they give you one. Here you get a minimum, maximum and an average, but Barrett gives you 1. So nowadays I have started going with Barrett, and it is very, very accurate. Very, very accurate. Very, very accurate. And choice of IOL. എല്ലാം കാണിച്ചിട്ടൊന്നും ഒരു കാര്യമില്ല. Maybe you can use a monofocal plus also. Up to EDOF also is fine. Multifocals please. ഇട്ട് കഴിഞ്ഞാൽ ആർക്കാണ് പ്രോബ്ലം വി ഡോണ്ട് നോ, ബട്ട് ദെൻ പ്രോബ്ലം വരുന്ന ആൾക്കാരുടെ അടുത്ത് പറഞ്ഞുകൊണ്ടിരിക്കാൻ വലിയ പാടാണ്, ഡിഫിക്കൽട്ട്. സോ മൾട്ടിഫോക്കൽ എല്ലാം കോഷൻ, ഇതെല്ലാം ശരിയാണ്, ഇതെല്ലാം നോക്കണം. ദേ വിൽ ഹാവ് ആങ്കിൾ കാപ്പ്, ഓൾ ദീസ് പ്രോബ്ലംസ്, ഇതെല്ലാം നോക്കിയിട്ട് ലൈക്ക് യുവർ റെഗുലർ മൾട്ടിഫോക്കൽ പേഷ്യൻറ്റ്, ചെക്ക് ഓൾ ദീസ്, ബട്ട് ദെൻ സ്റ്റിൽ ദേ ഹാവ് ദിസ്. സോ നേരത്തെ പറഞ്ഞ പോലെ വെരി, വെരി ഇമ്പോർട്ടൻറ്റ് 2 points are patient counseling, ആൻഡ് ഇങ്ങനെ ഒരു ഏർപ്പാടുണ്ട് എന്ന് പറയുക, ദാറ്റ് റിഫ്രാക്റ്റീവ് സ്റ്റോപ്പ് ഇസ് പോസിബിൾ എന്നുള്ള പറയുക. വിനയുടെ പ്ലേസാണ് ഞാൻ എടുത്തിരിക്കുന്നത്. JK കഴിഞ്ഞിട്ട് ഇപ്പോൾ സംസാരിക്കേണ്ട സിറ്റുവേഷനായി. Okay, so challenging after, there is one thing called RK. We are not seeing it very common. Are we seeing RK very common now? Are you seeing many RK patients? I don't understand. കേരളത്തിലുള്ള RK-കാരൊക്കെ എവിടെ പോയി എന്നറിഞ്ഞില്ല, അതോ ആരും RK ചെയ്തിട്ടില്ലേ? Very, very occasionally I get RK patient. Problem is more difficult. Anterior, posterior, both difficult, always changing, hyperopic shift, diurnal variation, all this. So corneal tomography, as it was shown there, not the top placido disc. So again, ACRS website, ഇത് അടങ്ങുന്നു prior RK. അങ്ങോട്ട് ചെയ്തു കൊടുക്കുക. പക്ഷേ ഹിയർ ദ വേരിയേഷൻ മൈറ്റ് ബി മോർ ദാൻ ഇൻ ലാസിക് എക്സൈമർ പേഷ്യൻസ്. സോ ടാർഗറ്റ് ലിറ്റിൽ മയോപ്പിയ ആൻഡ് ബാരറ്റ് ട്രൂ കെ. ഇത് കുറേ നാളും പറഞ്ഞു ട്രൂ കെ, ടോട്ടൽ കെ ആൻഡ് ട്രൂ കെ. Total K for people who to assess the include the posterior corneal curvature also. True K for people's posterior corneal and anterior corneal do not match, but we can get a total true K from Barrett. Monofocal again. വന്നു. അപ്പോൾ ഇങ്ങനെയാണ് സർജിക്കൽ കൺസിഡറേഷൻസ്. സോ ദിസ് ഇസ് 8 cut. So paracentesis, always avoid the cut area. And incision, if it is not possible, multiple means goes scleral. And don't go into cornea. I have seen scleral incision going into cornea and entering through this one. That's no point. There is no point. So remain limbal and then suture that. Don't go into the cornea at all. And then they are high myopes. Remember, they are high myopes. Adu maarittilla. So axial length is very high. So your bottle height low and your intracameral lignocaine, if you want, they have reverse pupillary block. So remember all those. And then they usually have higher grade nuclear sclerosis. And then remember that and continue your phaco. And if you want, you please suture. But do not include these cuts in your corneal incision. And if you are scleral, remain scleral. Final refractive outcome, it takes more time in RK patients. Okay, again, second thing is dense cataract. We all have dense cataracts. We have very dense cataracts, and many of our patients we don't get in this one. So use immersion. And please do not do this contact method of indentation. Please don't do. And that's so this details first year PG the spikes and all those things. I don't want to tell all those. But the point is to show again video. So I went recently to video. This one, Sreekanth once showed this in very great detail. And then I went and saw. So, entry, patient positioning, very important. Head pillow better, but then still you can have the patient lie flat and it should be facing up. You have to tell him that something is going to be put on your eye and all those. Kind of thing. And you have to place the iris parallel to the ground. അപ്പോൾ താടി നേരെ വെക്കണമെന്ന് താടി പിടിച്ച് താഴ്ത്തി കഴിഞ്ഞാൽ പേഷ്യൻ്റ് വാതുറക്കും ഇങ്ങനെ. അതല്ല എന്ന് പറയണം. വാതുറക്കാൻ വേണ്ടിയല്ല താടിയിൽ പിടിച്ച് വലിക്കുന്നതെന്ന് പറയണം. അപ്പോൾ എന്നിട്ട് then look up and look straight and then open the lids and place this cup and it fills with fluid. You can fill it up and then സൈഡിൽ ഈ സാധനം വെച്ചില്ലെങ്കിൽ ആ പാടെ വെള്ളം അവിടെ എല്ലാം splash ആയി. It happens in a flash and it is quite good actually. If done well, these trained people are so good that they do it very well and you get good spikes and you get good results. So again, dense cataract on the problem, pressure inside. Intumescency, the gaps you see there in between, those are fluid fill spaces. So, oro gel, no financial interest in that. Sodium hyaluronate, very important to use to flatten the anterior capsule. And then leaking it a little bit, a straight cut is avoided. Take a little turn so that it is curved. Then use your micro forceps. Don't use your thick, large forceps. And bring it around and don't go backwards or radially. Always make it circular or curvilinear. And then finish off a small one. And once you do this, it's 100% repeatable. 100%, except for very young patients with silicone oil and very intimate lenses, you touch and it breaks and gives you an Argentinian flag sign. Except that, every case this technique works. This is reproducible in every other. You can go even smaller. You can make 2 millimeters. But then while aspirating the cortex, don't stretch too much on the rexus margin. It may break. And then after making a slanting nick on the capsule, you enlarge it and do like a regular case. So here I use this long chopper, 1.75, 2 millimeters. It doesn't hit the PC, doesn't hit endothelium, never worry. And Appasamy makes this chopper for me, no financial interest. Now say Epsilon is making it for me. And one side is sharp and one side is blunt for me. And it works for all cataracts. And this hold is most important, hold and splitting. And even if you don't split the posterior plate completely, you can come another round. Don't insist and don't split too much in the bag. Remember, these capsule bags are thinner, more brittle, not elastic. So don't stretch too much. Once you stretch in the periphery and the center doesn't crack, still you can go around and then go deeper and deeper into the crack and gently separate so that you don't pressurize too much and you can finish off the mature cataract like this. Challenging scenario തുടരുന്നു. Keratoconus, irregular cornea എന്നൊക്കെ പറഞ്ഞിട്ട് JK was telling so many things about all those. So care reading we know how to do the topography. Finally, it is the Sirius. ഞാൻ കണ്ടുപിടിച്ചു. In our hospital there is Sirius. So Scheinflung and Placido both together. So no worries, nothing. Everything done fine. The way to do, they have told you. And then comes the formula. See, formula, again the Barrett True K with the KC option in it. That is very, very useful. Kane, Hill RBF, everything is good. But multiple കാര്യങ്ങൾ ഇപ്പം ഒരുപാട് കാര്യങ്ങൾ അറിയാതിരിക്കുന്നതാണ് നല്ലത് എന്നാണ് എനിക്ക് മനസ്സിലായത്. If it is giving reproducible, repetitively same thing, മറ്റേതൊക്കെ ഉണ്ട് fine. But then focus on this. I have seen Dr. David Chang operating in his facility in 2004, I remember. Every case the same technique. 32 cases he did, 31 cases were regular dilated small soft cataracts. Same technique. So please repeat the same thing which gives you similar results. So again, keratoplasty cases. So topography is very useful, optical biometry and topo. But anyway, if you have Sirius is fine. But otherwise depends on what you have. But again, surgical sort of post-PK case. So this is using a femto. There is no need to use a femto. Just because patient wants to have femto, use femto. So if it's a large graft, don't do a clear corneal. Go, here I'm using a little bit of sclera, but I'm going into the cornea also because I have space. But if it's large graft, remain scleral and suture the sclera. And here this one is fine, the rhexis is fine, and finally I'll go, no time. I thought, how will I finish 15 minutes? But it is where is the result? Okay, finish phaco. And later I realized when I put a pilocarpine, I realized that there was a large PI here. See, look at the size of this PI. So when you put pilocarpine, it becomes like a very large one. So I have done a pupilloplasty here to convert that PI into a smaller PI so that the vision outcome is better. So remember to correct these kind of finer aspects for these kind of patients. So again, challenging tira axial length, extreme axial length, high myopia, Barrett Universal 2 works best foremost. Hoffer Q for smaller eyes, fine, but then it's freely available, works very, very, very well for me. I'm not using any other formula. Maybe there may be fine changes, 0.25 and all those things, maybe there, but I'm not getting much of a residual at all. But we are doing it regularly on a daily basis. Poor fixation corneal scars. Like they said, somehow you have to do, JK Paranjali, somehow you have to do the keratometry and get keratometry. Yeah? So multiple K readings through multiple instruments and validate. Last when there is corneal opacity, visualization very, very difficult. So for that, what is going inside? A light pipe is going inside. Light pipe and switch off your microscope light. Then you see like you're seeing in moonlight. Switch off you, petanate. See, now you will see the capsule. So if you notice here, the corneal opacity but you see this kind of this corneal opacity here is quite large. Red glow you will think that there is nothing. But this is a big large opacity very close to this one also. Now I realize that a pinhole pupilloplasty can bring down the effect of this one rather than going in for a keratoplasty. This has been popularized by try this, and if you do suture, these are now I'm putting 2 4-throw pupilloplasty. So take 2 bites, bring the loop outside, take 4 throws here, just pull around, no more knots, and then 2 here and 2 here. And if you want to dilate, Prakash chirikunu, Ashok chirikunu, ellarum chirikunu. Retina engane nokkonnu nokkan pattum. It can be dilated, each side dilate down 2-3 millimeter. They have become big experts now. They can see till periphery with 3 millimeter pupil. പറ്റില്ലെന്ന് പറയില്ലല്ലോ പറ്റും അതാണ് അപ്പോൾ അതുകൊണ്ട് തന്നെ 3 millimeter pupil they can. So there are machines also which can see the periphery with 3 millimeter pupil. So this one actually, see, you should make sure that the P1 and P4 will overlap and it will be in the pupillar area. That is one thing we have to make sure. With that, challenging onnu illa. Silicone oil filled eye, optical angle, there is no need to make any change, but put it into the silicone oil mode. Even in ultrasound and in optical, if there is no silicone oil mode, do this multiplication factor. That is not required. That is all. RD patient, macula off. Sister patient PG varum. Sir, this is kittiriyana. Ee prasham cheyidapol 27. Oru prasham cheyidapol 25. Aa edu edukkanonu retina consultant choichu. ഞാൻ പറഞ്ഞു ഒരു കബഡി കൊണ്ടുവരൂ, നമുക്കത് വെച്ച് ഇങ്ങനെ നിരത്തിയിട്ട് ഇങ്ങനെ ഓരോന്ന് ഇങ്ങനെ വെച്ചിട്ട് എടുത്ത് നോക്കാം. അല്ലാതെ ഇപ്പം ഇങ്ങനെ ഹൗ ഡു യു ഫൈൻഡ് ഔട്ട്? സോ ഇഫ് മാക്കുല ഇസ് ഓഫ്, look at the other eye. Unilateral high myope ആണോ എന്ന് എങ്ങനെ അറിയാൻ പറ്റും? Look at the previous kannadi which patient had. That is a good idea actually. Ask him what kind of kannadi you were wearing and all this. But എന്നാലും I would say എന്തായാലും they'll put silicone oil. ഇല്ലേ? Silicone oil. അപ്പോൾ പിന്നെ silicone oil ഇട്ടാൽ you have to take it out. Till then, patient is not going to see much. Perception of heat technique, perception of light, perception of heat. Anyway, if they are improving with silicone oil later on, improving to 624 or 636 something, silicone oil mode you can easily calculate and then put it while removing one, you put it bag 5 rows. We can put a 3-piece lens in the sulcus and optic capture and we'll do the best job for you. But then please don't insist on putting IOL in this RD patients and so much of variation, and finally you end up with a very bad. Please try to postpone. Then vitreous hemorrhage also you can use this one. See, like this you can see ഇതാണ് വിട്ട് ലൈറ്റ് പൈപ്പിൻ്റെ ഒരു ഗുണം. ഇവർ വിട്ടു തരില്ലെങ്കിലും ഇവരുടെ നിന്ന് നമ്മൾ അടിച്ചു മാറ്റി എടുത്തു വെച്ച് ഉപയോഗിക്കണം ഈ റെറ്റിന പീപ്പിളിൻ്റെ നിന്ന്. So then you can see like this, see with such no red glow, black glow, still you can see everything like this. Switch off your light and enjoy phaco. Practical pearls, repeat cross check, compare with both eyes, multiple modern formula, Barrett Universal 2, Barrett Universal 2, Barrett Suite for all the possibilism. And validate with clinical history the glasses kind of things which you are wearing, and manage complex expectations. No single formula, you tailor your approach, do multimodal biometry and communicate realistic outcomes in challenging situations. Thank you very much.
Thank you, sir, for that very interesting talk. Next speaker for this session is Dr. Sujit
അത്
Nayanar.
വിനയിൻ്റെ ട്വിന്നാണ്, സുജിത്താണേ.
I actually regret my decision to talk third. Now it's even more difficult for me to. A very good morning. Thank you for the invitation. First of all, congratulations to Dr. Sreekanth and his team on their 10th anniversary. Happy to be part of OCULUS Season 6 and every OCULUS till now. Thank you for that. The topic is very tricky and lengthy with two components in it. I'll try to do justice in the allotted time. So actually, both these investigations, both are studying the various aspects of the cornea. One is more into the anatomical aspect of the cornea. The other one is studying the functional aspect, whereas as a clinician, we need both to understand the diagnosis and treat the patient. And we are all skilled with the slit lamp biomicroscopy in looking at the structure as well as the function. We can have retroillumination or specular view of the slit lamp to use this. But these newer investigations have given us more courage, more enthusiasm in diagnosing, coming up with newer classifications, documenting it, counseling the patient, pre-op planning, and also the monitoring the disease and the treatment. So starting with the ASOCT, it is the current utility of ASOCT has actually spanned right from the tear film up to the anterior chamber. Starting from, identification of the anatomical layers, it is very rightly termed as optical biopsy, because if you look at the picture from a biopsy, cornea biopsy, it actually replicates, it's a digital form of a biopsy that you see on the left side, where every layer you can, based upon the resolution of the various OCT machines that you have, you can actually see each and every layer. One thing I want to point out here is that the first layer, every layer here is either hyporeflective or hyperreflective. The first hyperreflective layer that you see is not the epithelium, it's actually the tear film. So it is also a component of the cornea OCT, and never miss that. The epithelium actually comes a little hypo than the tear film. And the pathology-wise, the hyporeflective other lesions are like edema, the shadow of a foreign body, a cystic space, or some healing stage of an ulcer. Whereas the hyperreflective, you will have infiltrations, scarring, inflammatory plaques, KPs, tear films. Can I have the slides? Yeah. Tear film, KPs, and all those things. Dr. Shishira specifically told me go only with the clinical pictures and the utility, what a comprehensive ophthalmologist can take, rather than going into the technical aspects of it. From the conjunctiva also you can have a similar picture, but compared to cornea, the various layers under the conjunctiva, like the subconjunctival space, tenons or episclera or sclera, is not very well demarcated, but still you can understand and if you have a particular pathology in mind. Just to go through the various acquisition, anyway, you need a good image acquisition to have this thing. Most of the machines will have an anterior segment adapter which needs to be connected. Most of the thing is automated. All you need to keep the patient chin, the chin rest. The operator will be centering the image and click capture. That's all. The rest everything is done, and you'll get an image either in the grayscale or in the colored image where the hyperreflective will have a more a brighter color or a hot colors. So coming to the various indications, or to start from anteriorly, tear film, one indication in tear film study or dry eye study where the anterior segment OCT is used is for the TMH, the tear meniscus height. It's a very important indicator for studying the dry eye. Various methods are used for TMH, but anterior segment OCT is now very well utilized for this particular indication where you can actually measure the height, the angle, area, and you can have a pictorial description of it where you can use it for the monitoring of the after the treatment also. Another very important indication is the various growths on the conjunctiva or the limbal area, including pincicula, pterygium or an OSSN. This is being widely used nowadays, and we have actually, the management of OSSN has changed a lot after this, and nowadays the diagnosis is, rather than taking a biopsy or going for an impression cytology, most of the diagnosis is based on the anterior segment OCT, where three particular features are being pointed out, like epithelial hyperreflectivity, the thickened epithelium, and an abrupt transition from a normal to abnormal epithelium. Three classical features, of which the thickened epithelium, which more than 120 or 140 is said to be very highly sensitive and specific for OSSN. Another very interesting and exciting updates are happening in the area of limbal stem cell with the OCT angiography, looking at the areas of ischemia at the limb. This is very interesting, and it can be very useful in the treatment of conditions like chemical injuries. Coming to the cornea, I don't know where to start. I just started with one of the most common indication which we do, the keratoconus, with a cross-linking. After the cross-linking, on slit lamp as well as on anterior segment OCT, you can see a demarcation line. Demarcation line is the only indicator of a treatment. Once you do a C3R, you don't have any other method to see whether the C3R has actually happened, the cross-linking has happened or not. So Theo Seeler and FAC came up with this idea of looking at the demarcation line, and it actually, you can look at the various depth of the demarcation line to understand where actually is the limit, or where actually the cross-linking happened. I mean, the layers above this demarcation line is supposed to have the cross-linking, and below which is not done. So if it has gone too posteriorly, means you have actually endangered the endothelium. If it is too superficial, then that means the only superficial part of your cornea has been cross-linked. This, a very similar image you can have in post-Lasik also. This looks like a demarcation line. This is a post-Lasik flap, but more superficially. In the cross-linking, it will be around 250, 300 microns below, but this is around 120 to 130 microns. Very similar picture, but if you look at the pathology or the histology, the both are actually different. Here there is an interface, or there's a space. The cornea, the stroma has been cut, and two stromal layers are coming up there. Optically, the cornea is clear. You don't see any scar or an opacity, but you see in the anterior segment OCT, you see a hyperreflective this thing. But in cross-linking, again, optically it is clear, cornea is clear. What you have is a hyperreflective image only, but the pathology, there is no interface. Both look same. One is having an interface, other is not having an interface. So very aptly said in one of the previous talks, the clinical picture we have to, the investigation we have to read along with the clinical picture. Just looking at this, we cannot say whether it's a demarcation line or it's a Lasik flap. Similar one, going more deeper, if it happens, this is a case of a lamellar keratoplasty. The anterior cap of the cornea has been changed. It has been put on the posterior cap. So again here, it looks like a demarcation line, but it is actually a space. An interface is there. It is an anterior lamellar keratoplasty. But if it comes to a deep anterior lamellar keratoplasty, big bubble technique, you have gone up to the descemet membrane, you cannot actually make out the differentiating line because it has got attached to the descemet membrane. Descemet membrane is already having a hyperreflective appearance, and this both hyperreflective has now come together. You cannot actually make out whether this is a PK or a DALK. But looking at the graft-host junction, actually you can make it out because in the penetrating keratoplasty, it may not be as uniform as this posterior graft-host junction. And again, in DALK, it is another important indication in DALK is post-operatively, sometimes you can have an double anterior chamber in DALK. The suture tract and the aqueous can leak in through the suture tract and form a, you can see this is a fluid collection in the interface area. So that is a very important indication for an anterior segment OCT where you can go in and drain the fluid and put in an air into tamponade and get it corrected in the postoperative period. Coming to DSEC, again there is an interface. We are putting a little bit of stromal bed is there over the descemet membrane. So wherever stroma meets stroma, there is an interface, there is a demarcation line coming up in the DSEC. But if it is, in a DSEC, see, if it is, you are looking at the day 2 of this patient, the cornea is edematous, you may be thinking there is a rejection or failure or primary failure, whatever it is happening. But if you look at the ASOCT is actually a graft shallow detachment. So if you go in rebubble, it's going to clear up in next 24 hours. So DMEC. In DMEC, it's looking actually like a pure pristine cornea. There is no interface because only the descemet membrane, if you look at this very temporal edge, there is a small detachment yet to attach. But otherwise, you cannot actually make out the surgery has been done because there is no actual interface that can be made out. Something like a DALK. But in DALK, you have a vertical interface here because you have approached the cornea from anterior. Here you are approached the cornea from within the eye. So there is a vertical interface is here. Again, this entry point is scarred and is showing a joining of the host and the donor cornea. So this graft-host junction is a very important thing. In some cases of post-penetrating keratoplasty, you can have very high astigmatism. And if you look at this graft-host junction, the attachment of the graft-host junction may be very bad, and you may have to redo it to correct the astigmatism. So for that also, anterior segment OCT is a very good mode of investigation. DMD, going a little more deeper, you can have descemet membrane detachment after cataract surgery or any anterior segment surgeries. You can see I'm actually moving the cursor on the cornea and trying to locate where is the attached area of the descemet membrane so that I can enter through that area and try to put in an air or a gas tamponade to attach it. And DMD management now it's entirely based on anterior segment OCT. The entire classification has changed. There is one Dua classification and this is one from the Jacob et al. The classification is based on the anterior segment OCT. Another a condition which now is managed just purely on anterior segment OCT is an acute corneal eye drops, where you can have a similar condition and you don't know where actually is the descemet's break, and the descemet based on the descemet's break and the orientation of the edges, whether it's a scrolled edge or a flat edge, there is classification and based on which the management is planned. And in acute eye drops, now the understanding is it's not just a breaking of the descemet membrane. So we have in DM detachment also you can have a hole in the descemet membrane. We are not having a eye drops in that condition. Why eye drops is happening here? Because the posterior stroma is also rupturing along with the DM. So that became more clear after the anterior segment OCT came up. So descemet membrane detachment along with the posterior stromal break is causing the fluid ingress into the cornea, causing a severe acute eye drops. So this is based on the ASOCT, how the first line of management nowadays in most cases of acute corneal eye drops is compression sutures, and this is how the compression sutures are planned based on the anterior segment OCT. So, and this has already been discussed by Bindu Madam, the ICL and the vault and this thing. In this particular condition, you can see that this is the ICL, the vault, the anterior surface of the lens. This particular condition, you have a very high vault going in for an angle closure glaucoma, and this ICL had to be replaced with a smaller size lens. Again, a little more deeper, you can have actually see a little bit of the IOL also. This is an IOL calcification. Coming back to the cornea, see if you look at this, what you can understand is that there is okay, along with the clinical picture, if you're seeing this patient, you don't know whether it's a scar or what is happening, whether you should go for a keratoplasty or whatever. So for planning, if you look at the ASOCT, you can see that it's basically a very hypertrophied epithelium. There's a very clear space between the actual cornea and the epithelium. If you just peel it off, you can have a very clear cornea underneath rather than going for a more invasive corneal surgery. A similar condition, a very infective cornea came. This was a case of multi-drug resistant pseudomonas, which was not responding to any of the medicines. Finally, it started responding to piperacillin in topical. If you look at it, it looks like a stromal abscess, but when you look at the anterior segment OCT, there's a clear differentiation between the cornea and where the exudates is. So it was the entire exudate was in the AC, and the cornea was not at all much affected, and AC wash simply did the trick, and the cornea was not that much affected, or there was no stromal abscess. But in this case, it's a very similar case, but if you look at the ASOCT, the stroma is having the abscess, and the cornea, underlying cornea or the descemet membrane hyperreflective layer is clear. And this patient also is pseudomonas. It actually shed off. That entire sloughed off, and in few days, only the descemet and posterior stromal fibers was left out, just like it was about to rupture, and it had to undergo a therapeutic keratoplasty. Endothelitis, you can have, in this picture it's not clear, but you can have few KPs also very clearly seen in the posterior layers of the stroma, and the endothelium hyperreflective, more hyperreflective than this thing. And if you have a clinical picture along with it, you will have a very circumscribed corneal edema at this particular area. Endothelial plaque, like what you can see in most of the fungal infections, you can clearly differentiate that it is not in the cornea, just stuck to the posterior aspect of the cornea. This was a case of interface infection. You can see actually it was a post-DSEC. Initial, it was all okay. Then a small opacity started appearing in the interface. Here, you can see that behind the infiltration, there is actually shadowing. That is also very important, where you see in some cases of very severe infiltrations or foreign body, you can have a shadowing beneath this. In few days, it was not actually responding to the topical, because topical medicine is not getting into the interface. In few days, it started increasing. Then an anterior approach was taken, and antifungal was put directly into the interface. This patient actually survived it, and the entire infection got corrected later on. And other subepithelial deposits, just for a demonstration, subepithelial deposits after adenoviral conjunctivitis, epithelial basement dystrophy, and stromal dystrophy at various depth. And in these things, you can see these deposits are not having shadowing, like what you see in the last picture. These things actually help in identifying the level at which the lesion is, and help you in making treatments like PTK treatment if these dystrophy patients are having recurrent corneal erosion as the symptoms. A stromal foreign body, this is going up to the descemet membrane, quite deep. This is from a case report published, and they have actually made this, depending upon the depth of the incision, they have gone deeper, made a femtoflap, took out the foreign body, and cleared it without much scarring. And refractive surgery also have some indications. This fluid collection, where it is called the pressure-induced stromal keratitis, where many years after you can have a fluid collection in the interface. You can have inflammatory cells in the interface, which is known as the sands of Sahara or diffuse lamellar keratitis, or epithelial ingrowth, which you can very well document using an ASOCT. CTK and post-PRK haze, these are severe fibrosis-like condition or opacities that are happening after the Lasik or PRK, which is seen as very hyperreflective in the anterior stromal layers. Objective quantification of corneal haze is also being tried, and classification is being made based on this. Intact is another indication where you have to put the rings at actually 2/3, 1/3 depth, and that depth is identified. And post-operatively, you have to track whether you are in the right place. This is a reported case where it has gone quite deeper and intruded into the endothelium by eroding the posterior layer. One of my own case, due to severe itching patient, post-operatively, it had an anterior extrusion, which had to be removed, finally landed up in a scar. A very important and recently identified an indication of ASOCT is looking for a KF ring. Most of the time when you look at the KF ring on slit lamp, you will not be very confident to identify whether it is there or not, like always doubtful, especially in the early cases. The reports are coming up that you can use anterior segment OCT to look up at the superior and inferior descemet membrane for hyperreflective changes. That may be a KF ring. A very clear-cut case where you have a very dense thickening of the descemet membrane, stromal edema, subepithelial bullae and epithelial edema, a case of bullous keratopathy. But in every fuchs, you may not have the same condition, same picture. There will be a little bit increase in the corneal edema, corneal thickness, very hyperreflective descemet membrane, and cornea will also be little a case where Dr. Menu and all can very easily do phaco, but without using a pipe. But these are the cases where we need the second instrument, where we have to look into the function of the cornea, where the normal endothelial cell morphology is maintained or not. So coming to the second part of my talk, the specular microscopy actually looks into the arrangement of the hexagonal cells, monolayer, if it is perfectly arranged on the endothelial side of the cornea, which if there is any stromal opacity or any anterior segment, anterior layers of edema, because of the backscattering of the light, you will not get a clear picture. And most of the time, it is not a very useful case. I mean, if you have a very clinically, the cornea is having pathology, that's not a very useful instrument to have. But still, in a normal, otherwise looking cornea, you can, for the cataract surgery, you can use it for screening. And it's also useful in various endothelial dystrophies, planning intraocular surgeries. It's guide decision making in endothelial keratoplasty and post-op monitoring also. In analysis, you have to look into qualitative as well as the quantitative aspects. Various parameters have been described. This I'll skip how to look. This is the classical printout which you get with the specular. You will have a clinical picture of this area that you have been studying, and also the quantitative data. The quantitative data, except the patient ID and all, you have to check. Then you have to look, the first and most important thing that you have to look at this is, genuinely speaking, all of us look directly into the number of cell count. That is not the most important data. First, you have to look at the number of cells studied. If you can read, it is 120 or 130 written on it here. Anything more than 100 is taken as a reliable thing. If it is just 10 cells studied, this report is not a reliable. Just what we do in a HFA, the reliability index of this particular report is not high. So once that is okay, then you look into the other aspects of the cell. Again, we have the most important two things that you have to look, and we normally don't check, is the percentage of the hexagonal cells and the coefficient of variation. We all know that in childhood, we start with a very high number of endothelial cells, which gradually with age, it falls down. That's a regular event. And anything less than 1,000 or 750, the various literature say various number, is a critical value if such patients are being taken for a cataract surgery. The two important things, pleomorphism and polymegathism. Pleomorphism is the variation from the hexagonal cells. If you have the number of hexagonal cells are less, then there is pleomorphism. If the size of the cells is very much different from the normal mean size, then it is a polymegathism. So two important things other than the cell count are the high CV, CV and the hexagonality. Something that shows a poor endothelial function is high CV and low hexagonality. So just for an example, if you look at this, you look, a lot of cells are there, and if you are just looking at the cell count, 3,000, 2,900, 3,000, they are all high count. But if you look at the CV, coefficient of variation, it's all above 40. So a good CV is something between 20 to 30 or anything less than 35. A high CV and a high CD is actually a poor endothelial function. And qualitatively also, after the quantitative assessment, you have to also look at the qualitative thing. You have to look at the picture that comes along with it, whether the cells are looking healthy, the intercellular, the black areas is equally arranged, is there any deposits there. This is the classic thing which we always see. One or two Gette-like features like which we see as the in elderly also we can see in the periphery is not that significant. If it comes to the center, then that's when we call it as a fuchs. The difference between these Henle bodies and the fuchs is actually this is abnormal desmet that is coming between the endothelial cells. These are excrescences, not actually loss of cells. These are excrescences that is happening, sitting on the cells. So when these are in fuchs, the adjacent cells to these excrescences are also affected. They are abnormal. In advanced fuchs, you can see actually white dots in the center of this. So these are very fine features. These blebs, vacuoles, and cilia, they are all physiological changes, not of any pathological importance. These black dots may be mistaken for Gette, but these are actually inside the cell. If you look at it, this is the cell, and inside the cell you have the black dots. They are blebs and vacuoles, just physiological changes. Again, small dots inside the cell known as the cilia. Endothelial stress, if there is a chronic contact lens wearer or a post-surgical, post-keratoplasty, you can have some endothelial stress lines or white opacities over the cells. Elongated cells, again a sign of stress factor. Desmet folds. Artifacts, poor quality image, these cannot be reported or will be useful. Inflammatory, in uveitis, actually the cells looks okay. The intercellular area, these black areas will be having thickened spaces. And in ICE syndrome, there is something called a reversal pattern. Classically, the cell pattern is not seen. And PPCD, again, tam-track appearance with similar Gette-like features arranged in this is a non-progressive condition which look like a Gette. So certainly the main pitfall for the specular is actually if there is any sort of opacity, even if it is a nummular opacity or a little bit of edema or a fluid in the anterior stroma, there will be backscattering and the image will not be clear. And it is very difficult to image the same area every time, so the repeatability is also not that as good. But it's still, it's used in institutes mainly for the research purposes and studying the various results of the various endothelial surgeries and all. But for a general practitioner, it will be a good aid if you have, you can screen it every cataract surgery to prevent any sort of post-operative endothelial decompensation. Sorry for giving more than what you can actually chew. Thank you.
Thank you, sir, for that detailed talk. I request the three speakers, Dr. J.K. Reddy, Dr. Minumathan, and Dr. Sujit,
one
sir,
doubt.
Yes, ma'am.
to join the panel.
So as you said, the specular is not going to help you when you have a case of Fuchs dystrophy and planning for cataract surgery. So how do we go about it? I mean, routinely, all of us have that doubt, whether to go for a triple procedure or take a two-step surgery, like after cataract surgery, going for corneal surgery.
As per the American Academy guidelines, it is the CCT. They have kept a CCT, I don't know the actual current this thing, it was around 600 or 630. If the patient is having cataract and the CCT is above 630, 650 or something, they prefer doing combined surgery rather than doing it sequentially.
So actually, specular, as you said rightly, has no much role in
such cases, specular will not, see, you have clinically diagnosed Fuchs, then specular is not going to help you. Probably those are the conditions, the specular will help you in conditions where clinically it is not that evident, and you simply, because of your busy practice, you may just pass on cataract for the cataract surgery. It may be picked up in a routine, this thing, that the cell count may be low. Again, just not the cell count, again you have to look at that CV and other factors.
And the CCT, you prefer some other
in such cases, doubtful cases, I always cross-check with 2 instruments at least.
Okay, thank you. Dr. Minu, ഒന്നും ചോദിക്കരുന്ന് പറഞ്ഞ് എന്നാലും ഒരു സംശയം. ആ ലാസ്റ്റ് കേസ് ചെയ്ത corneal with corneal scar, how did you take the biometry?
Very difficult, as I said, try to get it from topography, AR, കിട്ടുന്നില്ല സാർ എന്ന് പറഞ്ഞുകൊണ്ട് വരും. കിട്ടുന്നില്ല സാർ. അപ്പം ഞാൻ വന്നാൽ കിട്ടുമോ? എവിടെയെങ്കിലും ഞെക്കിയല്ലേ പറ്റൂ. നിങ്ങൾ ഞെക്ക്. Then they again go to lens star. See, ultimately, if you don't get, you go with the standard K or the other eye K. That's what basically.
So go for the other eye. In this case, do you remember? Just അറിയാൻ വേണ്ടി ചോദിച്ചത്. Other eye ആയിരുന്നോ?
അത് ഞാൻ വന്നാൽ ഞാനൊരു സത്യം പറയട്ടെ, ഞാനത് ഓർക്കുന്നില്ല.
Thank you, Minu.
Minu, you had shown in a post-RK patient for cataract surgery. Would you like to explain what way the keratometry is different from post-Lasik patient?
See, the problem is RK is the flattening happens only in the very center, within 3 millimeters. Whereas in Lasik, in PRK, whatever you do it, minimum 5.5 mm, you will have a nice. So keratometry, manual, even manual keratometry, 2 points apart from 1.5 mm distance. Okay, that means 2 points, 1.5 not radius. That's not diameter, radius. So almost 3 mm you need 4-5 mm very good cornea only you get keratometry. Otherwise, what you have to do is you have to take topography and keep your mouse on the center of the topography. Take those readings and feed.
You mean to say in the post-RK patients, the anterior corneal curvature and posterior corneal curvature both are flattened?
Both are flattened, but
Both are
only in
flattened?
the center.
Only in the optical zone is small.
Very small.
Very small. And your measurement will be usually going outside the optical zone.
Measurement. If you do manually.
Yeah.
If you do even with the topography, if you look at the readings, the simulated K, don't take the readings. May be correct, it may be wrong, but try to take the readings in the center. Then you don't go wrong.
Can you explain the diurnal variation in keratometry?
No, it doesn't matter. It doesn't. 1.5 diopter, 0.7 diopter, it doesn't matter.
What about the progression of keratometry?
RK?
RK.
For RK, what progression it happens is progress towards the hypermetropy. Because it becomes flat over a period of time if incision opens up. So that's why we try to always correct it little bit myopic.
Okay. Thank you.
In topo, in the series which we have, it gives the readings within 3 millimeters, within 5 millimeters. அப்படி இருக்கு pattern. Central 3 millimeters. So take only central 3 millimeters. Simulated எடுக்காம central 3 millimeter மட்டும் எடுக்கலாம். There is an option in that where you can take the central.
Keratoconus, how to do keratoconus patients who are coming for the surgery, for example, last week we had a case. So keratoconus patient, he is on contact. 58 is 63 is K reading. Okay, actual length is 28. His IOL power calculated according to topographer is -30. So what you will do? So you can customize lens, but the problem is putting the lens -30. If tomorrow he needs for PKP, then he will become +10. So what we do in those cases is we put a standard K. As he said, when you don't get a K, you put a standard K, 43, 44, and take the same action length and do it. And give the contact lens for keratoconus. Anyway, he is wearing contact lens. So tomorrow, if after some time you go for a keratoplasty also, you don't have an issue. You are near to the normal.
Minu, you said for our case, just do the scleral section, no corneal entry. So how will you manage the iris?
How will you manage the?
Iris?
Limbal. See, how will you manage the?
Iris.
Iris prolapse. See, you have to be very specific about your size of your incision. It has to be exact to there should not be any leak, and it is limbal, not scleral. You should not be entering into the clear cornea where the cut is there, but you should be entering till limbus.
But it will be so
No, it's okay. It won't prolapse too much. It is a high myope. Always there are high myopes. The chamber will be very deep, and the section will be very tight. And then usually it doesn't leak through the section, and not much of. Stop your irrigation before coming out. Every case, every situation, stop irrigation and come out.
JK said, there is some description of putting a suture also, Lasik suture, something.
Cases where they become very irregular, usually what happens in a post-RK progression, which never stops. Hypermetropia, they became irregular, but they become like a keratoconus. Inferior portion only, the incision open. Somehow superiorly, they never open. Inferior temporal, the cornea opens up like keratoconus. Then you have to suture that. You put a pursing, we did few cases, 9-1 nylon, 9-0 proline, or 8-0 proline. So proline, should not use a nylon, or put a pursing and tighten it, and it improves.
You're doing for the vision correction or as the
Irregular cornea.
no, as a prevention to opening up during the surgery, is there possibility?
Okay, well.
When you're performing in a case of keratoconus patient, when you have a toric taking, we go by the spectacle correction or by the contact lens?
This is very tricky. Sorry, what they are doing, we have to understand. So one patient, very VIP in Coimbatore, a very nice man. So he went for keratoconus with, he is always using contact lens. Okay? He's executive and he attends a lot of meetings, everything. Very active person, 65 years, developed a cataract. So what they did is, they put a toric. Okay, 6 diopter. Vision is 6-9, but multiple ghosts. He got 10-20 ghosts, one over the other, 10 latest. He can't tolerate. Now he put a contact lens, so it neutralizes. Then again he is left with a toric in the eye. So now he is put the contact lens. Again he has to wear -6 spectacles to have a clear vision. Now we cannot explain because very late. And what happens? So never go for what the patient is doing. We should understand. If he is using contact lens, only sphere, no toric. If patient is not using any lenses, he is just moving around, only spectacles, then look at the spectacle correction. That cylinder you have to use it, not on the keratometry.
The patient is tolerating around -13 and 5 cylinder. Patient is tolerating with spectacles.
Yeah.
We can go with the
-13.
5 cylinder.
Yeah, we can go, but you can't get that lens. You have to customize.
Yeah, but
so,
we can
but
go for
you
the
have to
spectacle
here
correction.
also you have to see whether the patient probably needs a keratoplasty in future. If that is situation, then you can have to replace the lens. So it all becomes very messy. But otherwise, you can go ahead.
Thank you, sir.
In a patient, when we did keratometry, it's showing regular astigmatism, fit for a toric lens. Then when we did topography, it shows early keratoconus. So is this patient fit for toric lens?
Yeah, that's the problem. You go for pentacam, that's what I'm telling. Pentacam, it doesn't give severity of keratoconus. Okay, it just gives a bad value, D value, something like that. Whereas when you go for the other machine, for example, Sirius or something, it gives the grading of keratoconus. Early cases, yes, you can go. If it is not very severe keratoconus, you can go. If it is severe keratoconus, it's a bit, you have to really do a lot of calculation.
Thank you.
So as we are running short of time, we wish to conclude the session. So this was an extremely useful brainstorming session with stalwarts in cornea and refractive surgery. Our postgraduates and ophthalmologists, they gained a lot. They can write an essay on corneal diagnostics and optical biometer after hearing this session. Thank you all.
Thank you. I request Dr. K.V. Raju sir to present mementos to the speakers and panelists on our behalf. Dr. J.K. Reddy sir. We'll have a very short tea break of 15 minutes. Dr. Minu Matan sir. Dr. Sujit Nayanar. Dr. Jason VA. Dr. Vijay Lakshmi. And Dr. Anjini K. We request all the speakers and panelists to please stay back for a group photo. We request the panelists for the next session to please come to the dais. Dr. Rajesh P., Retina Consultant, Abate Eye Hospital, Perindalmanna. Welcome, sir. And Dr. Shabarish MD, Consultant VR Surgeon, Putlat Eye Hospital, Kozhikode. We request all the delegates to please come in for the next session. Our first speaker for the day is Dr. Prakash VS. Sir is Medical Director and HOD Retina, Comtrust Eye Hospital, Calicut. Sir will be speaking on OCT and Opta.
So good morning all. Thank Dr. Shishra and team Dr. Sreekanth Hospital for this opportunity. My talk is on enhancing retinal diagnosis using OCT and OCT angiography. It's actually a very challenging task to cover OCT and OCT angiography in 15 minutes. So it's actually, I think, one day's talk. So Dr. Bindu has already very well covered the principles of OCT. I am not going to the details of that. Only thing we have what is known as time domain OCT, which is almost like an optical ultrasound, which is become obsolete nowadays, and we have now OCTs based on the Fourier domain principle, of which we have the spectral domain OCT and the subsource OCT. Spectral OCT is basically understand that it has got a light source of a constant wavelength which is around 800 to 870 nanometer, and it passes through an interferometer, and it is detected by a spectrometer, which will give the retinal layers as an A scan, and multiple A scans are combined to give what is known as a structural OCT or a B scan, and multiple B scans are combined to give what is known as the C scan, which are like how we see the retina from front. And subsource OCT is a newer addition to our collection, and it has got a varying wavelength light source, which is more than 1000 nanometer wavelength, so it has got better penetration, so that we can image the choroid much better, and it gives a best OCT angiographic pictures, whereas for structural OCT, still SD OCT has much transverse and a better axial resolution. So before we go to the OCT in detail, I'll just briefly go through the various layers of the retina. Starting from the anterior most, we have the posterior cortical vitreous, which can be normally seen separated from the retina on the nasal side, and there is what is known as a pre-retinal space there. Then we have the first high reflective layer, that is ILM together with the nerve fiber layer. Then we have two moderately reflective layers, a ganglion cell layer and the inner plexiform layer. Cell layer. To understand that almost plexiform layers are slightly hyperreflective or moderately reflective, whereas nuclear layers are always hyporeflective. So then comes a hyporeflective layer, that's the inner nuclear layer. Then comes a moderately reflective layer, that's the outer plexiform layer, which mainly comprises of the dendritic portions of the outer plexiform layer. Then we have a broad hypo area that consists of outer nuclear layers as well as the axonal portion of the OPL. And that is on the towards foveal side, we call it the Henle fiber layer. Then we have a thin hyperreflective layer, that's external emitting membrane. And then we have a hyporeflective zone, that's a myoid zone. Then we have the second hyperreflective band after the NFL, which is ellipsoid zone, which is very important because it is the most metabolically active portion of the retina. It contains some mitochondria and all of those things. So its presence or intactness or abruptness, everything is very important in assessing prognosis of retinal disease. Then we have again a hyporeflective area, that's outer segments of the photoreceptors. Then there is a variable hyperreflective layer. It may be seen sometimes separate from the RP Brooks complex, sometimes may not be seen separate from this thing. It's the intradigitation zone. Then we have the after the RP Brooks membrane is the fourth hyperreflective layer. Then we have the choriocapillaris and the larger choroidal vessels and the chorioscleral junction. So when coming to the principle of OCT angiography, again it's almost like OCT. Only thing is it compares between consecutive A scan. One A scan is done and second A scan is run. All those structures which are present there between two A scans are regarded as non-mobile things. And when a thing is absent, like one A scan, this red dot, that's RBC is not there. One A scan, it is there. Then it considers that thing as a mobile thing. So it's something in motion. So it detects changes between consecutive A scans and detects motion. And it gives a picture and it recreates a picture on a topographic, on a map. And that will give, if they are continuous, then it is given as a blood vessel. It is shown as a blood vessel. So this is a normal angiogram of the, OCT angiogram of the retina. We have 4 vascular plexus in the retina, especially in the macular area. We have the superficial venous complex consisting of the nerve fiber layer vascular plexus and the superficial venous plexus. Then we have the deep vascular complex, which consists of the intermediate capillary plexus and the deep capillary plexus. So this is the area where we look for all the retinal vascular diseases. Then we have a broad avascular area where if you see new vessels or any vessel that is abnormal vasculature, that's the area where we look for AMD or any pathologic myopia causing CNVM, etc. Then we look at the choroid and choriocapillaris where we detect the pachychoroid spectrum of diseases. So the biggest question always asked is whether OCT angio can replace FFA. This is a constantly asked question, but the answer is it cannot replace fluorescein angiography because both are, even though both are called angiography, both are separate entities. Because FA shows leakage, it shows structural integrity of the vessel wall, whereas OCT angio cannot do that. And also OCT angiography does not give a full field. You can, with the wide field angio, we can see up to aura nowadays, which is not possible right now with OCT angiography. Then artifacts and other things make it difficult to interpret. So it is that OCT angiography is good for certain indications, but there are certain indications where FFA is a must. So it rather complements than replaces dye angiography. So So I'll briefly rush through some of the clinical applications of OCT and OCTA in common retinal diseases, starting with the most common disease, that's the diabetic maculopathy. So here is one situation where we use a quantitative analysis, a volumetric analysis, other than the nerve fiber layer thickness. This is probably this other situation where we use. So here it gives two information. It gives what is the volume of retina, what amount of fluid is contained in the retina due to the exudation from the diabetic damaged capillaries. So that is represented as pseudo colors. The green is almost like normal thickness, yellow, red and white are varying degrees of increasing thickness, and blue is decreasing thickness. So this will tell you, and there is actually a grid here, ATDRS grid, which will give you the average thickness within each circle. So we use this as a central subfield thickness or the central macular thickness. If it is more than 300, we call it center involving macular edema and treat those patients with intravitreal injections. And also this is very useful when you are treating patients for follow-up. So the middle one actually shows before injection, and after the injection you can see decrease in the area as well as the thickness. Both are decreasing and it is moving away from the center of the fovea. So this will tell you where exactly the edema is concentrated also. And the third picture here actually shows the change in thickness, average thickness after the injection. So this is very useful for following up these patients when you are treating them with intravitreal injection. And then we have, of course, the qualitative markers also, which we call as the biomarkers, which are actually, I cannot go into the detail of these things in this talk, but we have the bridging retinal process, high reflectile foci, which are small 30 micron size particles without causing a backscattering. And this is differentiated from hard X-rays because they cause some backscattering, and they are actually larger clumped particles, and there you have submacular detachment. And one useful biomarker which you should keep in mind is the disorganization of inner retinal layers. That is, the normal striations of the inner retina is lost. This is a sign of macular ischemia because most of the inner retina is supplied by the inner retinals from the retinal circulation. And also it will tell you, OCT will tell you to identify associated vitreoretinal interface disorders, which is common in diabetic retinopathy, and these people are resistant to treatment and may require vitreoretinal surgery. Octa in diabetic macular edema is not routinely used, only for academic purpose, and Octa in PDR we can use if you have a wide field Octa and you can detect new vessels with that, but still we may all be using fluorescein angiography for that in a better way. And coming to other retinal vascular disorders, CRAO is one indication where OCT is very useful because the moment a patient presents to you with a sudden loss of vision, before dilating itself you can get an OCT. You can put a dilating drop, send the patient for OCT, and by the time he comes back you can die. So your urgent treatment or the golden hour treatment of CRAO is possible by using an OCT. Here the finding is the loss of the inner retinal layer opacification. The normal striations are lost and it becomes opacified. It becomes hyperreflective. This is actually due to the cytoplasmic swelling, intracellular edema that is happening, unlike the extracellular edema that happens in diabetic macular edema. And you also see a pseudo widening of the outer nuclear layer because of this inner layer. This is actually an artifact, and you can sometimes see a prominent RP at the fovea. And an old CRAO, this is many times when before you do a cataract surgery or if you unexplained loss of vision, if you do an OCT and shows inner retinal layers alone thinned out with no stratification, but the outer retinal layers are intact, then this tells you that this is probably an old CRAO. Visual prognosis may not be good in those cases after cataract surgery. Retinal venous occlusions, again the same swelling at the macular center is the indication for treatment, intravitreal injections, and also again very useful for following up of these patients as well as assessing the treatment response. AMDs is probably the second most common indication where we all use OCT. It's very important to identify it is used, you can identify of course where the location of the neovascular complex will tell you whether it is a type 1, type 2 or a type 3 or a PCV. So type 1 is under the RP and type 2 is above the RP, but more important than that is the sign of activity. See, whether it is type 1 or type 2 you are going to inject. So it's very important to know the activity. So you have to look for the fluid, where the fluid exactly is. If it's an intraretinal fluid, that's the most important indicator of showing activity of a CNVM, and those patients definitely require treatment. And if you are following up the patient, if there is a recurrence of intraretinal fluid, that's an indication for retreatment. Subretinal fluid, again, is not as important as intraretinal fluid, but still is one of the most important biomarkers of activity in a CNVM. So we look for, once you are injecting, you look for disappearance of these markers. And Octa this is one area where Octa is very, very useful. You can see a type 1 CNVM, which is seen as a branching vascular network in the OCT angiographic picture, and you can see the treatment response. After injection it reduces, and after one more injection it almost disappears. So this is very useful area, very useful to have an OCT angiography. You can do away with fluorescent angiography in many cases. Type 2 MNV, as I told, it's again above the RP, most of the thing. Again, it is the intraretinal fluid or the subretinal fluid that decides treatment. And again, Octa is useful in following up these patients. Various patterns of BVN has been described, CFAN, tangled medusa head and all in literature. And PCV diagnosis is now we used to use OCT and ICG for diagnosing PCV, but now it is possible almost with 99% accuracy to diagnose PCV with OCT alone. So when you have a suspicion of PCT, you have to look for the markers which tell you it is not with a single finding, multiple finding you have to use, and if more than 2 or 3 findings are present, then you consider this as PCV. So if you have a pachychoroid, you see a thick, large pachychoroid is a large choroidal vessel or a thickened choroid under the RP. And if it is present, then your suspicion of PCV is more compared, because in normal AMD you get a leptochoroid or a thin out choroid. Notched PED, you can see a notch here, that is again suggestive of highly suggestive of PCV. You have tall PEDs which are called as thumb-shaped PEDs, and you can sometimes have what is known as the double layer sign. Here you can see there are 2 lines at the RPE Brooks level, because the polyp grows between the RPE and Brooks membrane. And sub-RPE ring-like lesion, you can see the small lesion attached under the RPE here. So that is actually suggestive of a polyp. And if you look at NFOS, NFOS OCT is actually the transverse section. This is seen only with an OCT angiography when you take the OCT angiography. And here if you look at the PED nature, you can see this complex or multilobular PED as seen here. That is highly suggestive of PCV. So all these findings together, almost you can replace an ICG. You don't need an ICG. With an OCT alone, structural OCT alone, you can identify polyp. And OCT angiography, what we routinely use, SD OCT angiography is not very sensitive to pick up polyp, because the flow is slow inside a polyp, unlike in normal blood vessels. But some cases you can see 50% of the cases like this, you can pick up the polyp on an OCT angiography. But a swept source OCT angiography can pick up polyps in most of the cases. Not only does it pick up, it also changed our understanding of polyp. We used to think polyp as an aneurysm, but now it shows very clearly that it is actually a tangled vascular network, and that's why it's probably responds to anti-VEGF injections, unlike an aneurysm which shouldn't be responding to anti-VEGF injection. So with a swept source OCT, you can pick up most of the polyp. And just like in DME, we have the prognostic markers like subretinal hyperreflective material, outer retinal tubulations, which are all endpoint indicators, or we have the multi-layered PED or the perichoroidal cleft. All these are biomarkers in AMD, which can be used for deciding on treatment and when to stop treatment. Other retinal degenerative conditions, myopia is very major important indication, because they may be clinically, you might miss a myopic CNV. A patient may be very minimally symptomatic. Always, whenever you have a pathologic myopia, posterior staphyloma, always do an OCT at least once in a year for the patient. So these lesions are very small, unlike the our routine CNVM. There may be a round coin-shaped hemorrhage associated with it, but you can see the small intraretinal, that may be the only sign of activity. The small intraretinal fluid above the lesion is the only sign of activity, and here also Octa is very useful. It can pick up, the lesion is very small, you can see the lesion here. And this is post-treatment, see how much it reduced, the size reduced and the vision almost improved to 6.6 for this patient. And again, for looking at the structural changes that can happen with pathologic myopia, posterior staphyloma and a posterior pole RD may be missed on a cursory examination. And myopic traction maculopathy, that is small changes happening inside the retina, in the inner retina, due to elongation of the globe, may be missed on a clinical examination. It's very important to, unless you do an OCT, you may miss this particular change, mainly because many of them do benefit by doing surgery. This is post-vitrectomy. You can see the anatomy has drastically improved after surgery, or even sometimes you can do a macular buckle. This is a post-macular buckle where you pushed the sclera up into the staphyloma and compensated for the mechanism that was pathologic mechanism that was happening there. And coming to the most important area, that's vitreomacular interface disorders, epiretinal membrane, again diagnosis and treatment decision making. So the patient is symptomatic and you have this fovea which is distorted, which is normal U shape is lost and the foveal, this thing is going up, then you know this is probably a candidate for surgical treatment. And also prognostication, what is known as ectopic inner foveal layers. That is, we normally see a fovea here, but the fovea is missing and the layers become continuous. here the inner retinal layers become continuous, that is known as the ectopic inner foveal layers or Eiffel, which is a poor prognostic sign in ERM. Also you have the disorganization of inner retinal layers, which is also a poor prognostic sign. So that will help you what to expect, tell the patient what to expect after the surgery. And macular hole, again staging of macular hole, what stage it is, because if you see this vitreous attached here, then it is probably stage 3, it is not, has a good prognosis. Also you see this bulbous ends, you see the intraretinal fluid inside the edge of the macular hole. All these tell you this is not a very old hole, the patient has a good prognosis if you do surgery. And also it will tell you what is the chance of surgical success. If you have a small inner hole diameter compared to the outer hole diameter, then there is a high chance of this hole closing after surgery. So that will predict the surgical success. And also after surgery, to look at what is happening at the macula, it's very useful. You can have this type 1 closure where it is a nearly perfect closure in this case, because almost all layers have become continuous after the surgery. But sometimes it may not be as good, still it is a type 1 closure, but the layers have not become continuous in this after the surgery. And then you have the type 2 or the V-shaped closure where you still have a defect. The edges have become flat and opposed to the RPE, but you have a defect here, that's a type 2 closure, which is not very good. And also it will also help you. This was a patient who presented with 6/9 vision, some visual discomfort. Clinically nothing was visible, but if you do an OCT, there is a full thickness macular hole. And do we have to advise surgery? No need. You can observe these patients closely. This is what happened over a period of few months. In about 6 months, a hole closed spontaneously. So some of the macular holes can close spontaneously. So that's again a good application for OCT. And VMT is one major problem, especially when you do before you do a cataract surgery, it's very difficult to clinically identify presence of a VMT. So if you have a dull foveal reflex, because the foveal dip is lost, so when the dip is lost, the concavity of fovea is lost, so you have the loss of the foveal reflex, which is created by the concavity of the fovea. So there you have to suspect a vitreomacular traction, and OCT will tell you whether it is present or not. Let's say, and you can decide on surgery. It can progress from just a small foveal attachment to a retinal detachment, macular detachment, which needs surgery. Also, it can result in a full thickness macular hole. And then the most important area is CSCR and pachychoroid spectrum of diseases. Do you need an OCT in CSCR? Yes, you need, mainly because you can at least document and show the patient. In follow-up visit, so many of these patients are very, the character. So it's very important to show them that this is decreasing, the fluid is decreasing. So that is the main reason what most of us do OCT. And also there are biomarkers which will tell you whether it is acute, like this photoreceptor outer segments. And some atypical features when they are present make you doubt whether this is CSR or not, and here OCT clearly picks up. You can see the turbid fluid inside the CSR, which is actually fibrin, and the small clearing area where there is probably a microrip and the fluid is coming out. And pachyvessel and pachychoroid again is associated with CSR also. And also you can identify chronicity. Chronicity is, it's important to identify whether it is becoming chronic, because at the time you would go for treatment modalities in CSCR. So appearance of intraretinal fluid, which we usually don't see in a CSCR. Also you see the double layer sign, and you can see the hypertransmission tail suggestive of macular atrophy. All this if you see, that is these are signs of chronicity. And optic pit maculopathy is something which whenever again if you see schisis or inner retinal fluid along with a CSR like picture, don't think it is a chronic CSR always. Whenever you see an inner retinal fluid, always look at the disc also. There may be an optic disc pit which may be missed, because the management is entirely different. Many of them do respond very well, gratifying results with surgery. This is the sclera which is used to patch the pit, and you can see the immediate early post-op result, and the late post-op it resolves very well, and it's quite useful. Again, OCT is very useful. Macular telangiectasia, again many of times it is missed unless you do an OCT. The early signs are like subsident sign where the outer photoreceptor layer goes and the inner layer starts sitting down. That is known as a subsident sign. Then you have the advanced signs like the ILM remains at its position, rest of the retina goes down. So the ILM remains where it was, that is known as the ILM draped sign. Also it develops, it's actually not fluid filled spaces unlike DME. These are degenerative spaces because of the Muller cell opathy that happens, and the retina is actually the degenerative spaces developed there, which is again a sign of advanced macular. And the worst situation is where you have a CNVM. Here OCT is the only useful tool which can diagnose a CNVM because fluorescein angiography will leak at any stage of mactel. So you cannot, by looking at the fluorescein angiography also, you cannot tell whether there is a CNVM present or not. So whenever you see thickening, because mactel always produce thinning of retina, so whenever you see thickening, always suspect a CNVM. And Octa is very useful here to confirm the presence of CNVM as well as the treatment response. And inflammatory diseases, again, OCT is very useful to document like the different types of choroidal involvement, granulomas, and you can see the vascularity of a TB granuloma, post-treatment response. VKH, again, it is one of the most diagnostic thing. You have what is known as the Ballard or the bacillary layer detachment, that is a splitting of the photoreceptor layer at the myoid zone. And you can have this bumpy RP, which tell you this is not a normal CSR. Whenever you see a CSR with a bumpy RP, always think of inflammatory causes. Toxoplasma, you can see the abnormal inner retinal involvement as well as abnormal vitreoretinal adhesions. Serpiginous choroiditis, where you can see the outer retinal changes, thickening of the RP. And in Mutes lesion, where you see small defects in the RP without any transmitted fluorescence. So all this is very useful in inflammatory condition. Again, tumors mainly for documentation. This is choroidal hemangioma. Opta is very useful. You can see the club-shaped choroidal, deeper choroidal vasculature, choroidal mets, OLH melanocytoma. Again, primary vitreoretinal lymphoma. Again, diagnosis is by an OCT. It will show subretinal material that is lying as well as a bumpy RP, and you can see material, infiltrative material in the choroid as well as subretinal space as well as inner retinal space. If you see all these areas involved by infiltrate, always think of primary vitreoretinal lymphoma. And again, one more useful area is monitoring drug toxicities, HCQ toxicity. You see this flying saucer sign. That is because the parafoveal zone, the ellipsoid layer is lost in the parafoveal, whereas it is intact in the central fovea. So this gives an appearance of the flying saucer. So that is a sign of HCQ toxicity. And tamoxifen toxicity, we have taught to, like it is a crystalline toxicity, and thanks to Sujit, I don't know whether Sujit is here, I recently learned that it can mimic mactel. It was the picture can be very much like mactel. And OCT is very useful when you have an unexplained lesion. This was a young guy who came recently with a drop in vision, and when you couldn't clinically find anything, and when you do OCT, you see an outer retinal defect. So this is either solar retinopathy or a welding arc. This patient was actually involved in welding. So that is briefly the clinical applications of OCT, future directions, again artificial intelligence, wide field OCTA, multimodal imaging, all this is going to make a lot of difference in our diagnosis. As such, OCT and OCT have transformed our retinal practice by giving us high resolution, non-invasive insights into structure and circulation. And it's indispensable, it has become indispensable in the diagnosis and monitoring of retinal diseases. It has its own limitations, but it's keeping on improving on itself. And in future, I think it will be very, very useful. Thank you all.
Thank you, sir, for that detailed talk. Next speaker for the day is Dr. Divya Balakrishnan. Senior Vitreoretinal Consultant, Little Flower Hospital, Angamali. Over to you, madam.
Thank you. At the outset, I would like to thank Dr. Shishira and Team OCULUS for having me here. So after the talk on OCT, where do we stand in the need of B-scan in the era of OCT? Because many of the conditions earlier we used to use B-scan, how now we can diagnose it without that OCT. Like posterior scleritis, VKH, many of the tumors, it is very easy to distinguish and differentiate it without a B-scan even. Yeah. So B-scan, as we all know, it is a very non-invasive tool which is very helpful in managing posterior or identifying the posterior segment pathology. So in the current era, it is basically useful more in cases where the media is very hazy and where we cannot see or the other investigative modalities where light or other techniques which require a clear media is needed. So I'll briefly go through the basic principles initially, because to understand, better interpret the ultrasound, it is important to know how the images are being captured or what is the principle of obtaining these images. So in ophthalmic ultrasound, we use an ultrasound waves, the frequency between 8 to 10 megahertz, and it produces a two-dimensional cross-sectional image of the eye. Basically, it helps to identify the structures behind and assess the size and even the texture of the tissues behind. So it uses a transducer which has a piezoelectric crystal, and it emits sound waves which passes through the tissues, and it is basically the reflected sound waves from these tissues which actually get displaced as the image what we see. So whatever the image you get, it depends upon the reflected sound waves, and what factors determines these reflected sound waves, I'll briefly say. And when you look at the ultrasound, it can be displayed as an A scan and a brightness mode. A scan is basically the amplitude, and in many of these conditions you need to have a combination of both the A scan and B scan to interpret it correctly. So in the brightness mode, you can see that the images are displayed depending upon the intensity or the intensity of the brightness. So that it depends upon like how the tissue reflects back the images and the strength of the return wave. In amplitude, as the sound passes, when it passes through the tissues of different acoustic impedance, the waves get reflected at different levels. And the height of the amplitude depends upon the strength of the sound waves which get reflected at that level. And in ultrasound, what we look at is, one is the height of the amplitude of the peak, and second is the time which has taken for this sound wave to reach back. That gives you an approximate idea of what is the length or the distance. So we use it to measure the axial length or the length of the size of the lesion. So these 2 points you have to keep in mind. One is the amplitude and the distance. And how the distance or the time taken determines. So that the sound travels at a certain velocity. So when the sound waves passes through this tissue, the velocity of the tissues varies at which these sound waves travels. So that is the reason why when there is a vitreous hemorrhage or in a silicone oil filled eye, you tend to see that the length might little different, especially in silicone oil filled eye. So if you see here, you can see the velocity in a silicone oil filled eye, it is 980. That means it takes a longer time for the sound waves to pass through it. So when you get an image, you will see that the distance traveled is long, or it is more. So you might see, if suppose a patient comes to you with a past history of VR surgery and you don't have the details of it, the patient has got a cataract, comes for a cataract surgery. So to know that, you get an ultrasound done, and if you see that these hyperreflected dots with an elongated axial length, then you can know that it still has a silicone oil inside. So these are the practical things which you have to keep in mind. And the strength of the reflected sound wave depends upon the factors like acoustic impedance and the shape of the object or the tissue, what it hits and comes back, and the angle at which these sound waves encounter the tissue. So what is acoustic impedance? It is little complicated one, but it basically depends upon the density of the substance and the speed of ultrasound in that. So what happens is that when ultrasound passes through the tissues like cornea, lens or vitreous, when it passes through these different interferences, these waves get reflected or refracted. So this we have to keep in mind when we assess the B scans. And what happens when the sound waves passes through tissue which is like dense, as it keeps on moving, it gets attenuated. Suppose you have like a clinical diagnosis of melanoma. So when it is a very dense tissue, so as it goes back posteriorly, you will see that the wave amplitude reduces. That is why you get an hollowing in the back and the angle there. And what happens to the waves? It can get reflected and it can get refracted. So when you see that, okay, the patient has got a retinal detachment and the vitreous is clear and it is a acute fresh retinal detachment, it doesn't have any hyperechoic tissue or fluid behind the retina. So when you do a B scan in that case, you might see that if a fresh retinal detachment, you might see the spike of the amplitude will be very high, because in the vitreous is clear and the layer behind it is retina is clear. Suppose a patient has got a trauma. There is dense vitreous hemorrhage in the front of the retina and hemorrhage behind the retina. So the acoustic impedance when compared to a clear vitreous with a vitreous hemorrhage is different. So the deviation at that interface is different from what in a fresh RD. So you have to keep these things in mind when you interpret the ultrasound. So this is, as I mentioned, this is a case of a PVD where you can see an moderate amplitude, but when there is a vitreous hemorrhage, you can see the amplitude is little moderate to high. And one more thing you have to make sure that the area of interest or the lesion, the vector, when you interpret an A scan compared with the B scan, make sure that the vector passes through the area of interest. Some cases you will see that, especially when the PGs comes, like the vector might be somewhere below down here, and the A scan here it will be anechoic. So it will not show any amplitudes. So make sure that the vector passes through the area of interest. And again, the shape of the object which it hits and comes back. If it is an irregular object, then the sound waves will scatter. So then you may not get a clear A-scan picture, or it will have artifacts. So these things you have to keep in mind. And when you use an ultrasound, air is one of the biggest enemy. Whether while you're doing the ultrasound without using a gel, if any air trap in that, then you may not get a good picture. In a post-trauma cases, sometimes after corneal tear repair, air might have been injected into the anterior chamber, it might have been escaped in the posterior chamber, and when you do immediately an ultrasound, you might see these hyper-reflective echoes, which you might take it as for intraocular foreign body. So in case if you have the history is very important, and always remember ultrasound is not a diagnostic one, it helps as an aid for your clinical clues and other investigations. So if you see an immediate post-op a high reflective echo, then don't take it as an IOFB. You can actually repeat the ultrasound because air stays for maybe 3 or 4 days. You can repeat the ultrasound and see whether it is there. One more thing is that you can change the position. So in a sitting position, the air will be upward and make the patient supine, and then it might disappear from the position. So these are the few things which you have to keep in mind. And this is a normal how an ultrasound will look like. And you can see that this is the pro position, and you keep the jelly, which is like a hypoechoic. You can see the corneal spikes here, and this is the posterior lens spike, and you can see an anechoic vitreous cavity, and this posterior spike corresponds to the retinochoroidal complex. So always remember the normal. And when you get the printout or when you see the images, you can actually adjust these images. One thing is gain and other thing is time gain compensation. What is gain? Gain means if you have, when you start an ultrasound, when you look at the images, usually you do it at a moderate gain of 50 to 60 and then look at the images. So if you reduce the gain, it actually reduces the entire intensity which is coming back. When you increase the gain, you are actually increasing the entire thing. So if you increase the gain, you might see even the vitreous which is normal or few vitreous opacities, and it might obscure the clear details of it. So adjusting the gain will help you actually pick up some lesions, like for example in the cases of calcification or an intraocular foreign body. If you reduce the gain and if you still that hyperechoic area there, that means like it is a foreign body. So this is how you can manipulate the gain. And if you want to examine the posterior segment pathologies more, you can actually attenuate the anterior segment echoes. So that is how you do by adjusting the time gain compensation. And these are the settings which you have in your machine where you can adjust. So whenever you get a patient for a B scan, you should follow some protocols. So either you have to examine for the anterior segment, then you have used the immersion technique, or you can use like a UBM is there now. And for the posterior segment, you can use contact method. And patient position, you can do it in either sitting or a reclining position. And always the probe will be having a marker. So keep the marker superior or nasal. And wherever the marker is pointing in your display screen, that area will be in the upward. So whenever you do an ultrasound, you have to think in three-dimensional view of whatever the structure you are imaging. And the basic screening first you have to do. And then you see whenever there is a pathology which is detected, then you have to look at the specific features. One is topography. That means you have to see where is it located, what is the extension of the lesion, what is the shape of the lesion. Then quantitative, look at the reflectivity pattern, what is the internal structure, is there any sound attenuation. And whenever there is required, you may have to do a kinetic scan. What do you mean by kinetic scan is, like you ask the patient to look up, down, and then keep the probe there, and if still that structure is moving, that is after movement. So if that is there, especially to differentiate between retinal detachment and posterior vitreous detachment. So if there is a retinal detachment, the movement will be less, and if there is a posterior vitreous detachment, it will be having an after movement. So even if the patient eye stops moving, then you will still see the movement there. So the protocols which are like axial, actually you have to do in the primary gaze. And how do you identify an axial scan is, you will see the lens echo and the optic nerve in the same cut. So it is very important when you do the scan, which quadrant you are doing the scan, to mention whether it is axial. If it is axial you are mentioning, then you have to see the lens echo there. So that is how you know that it is an axial scan. And this we used to do posterior capsule vitreous cavity disc optic nerve shadow. And transverse scan is, you keep the probe at the limbus, like the position here, and usually you keep it at 3 o'clock, 6 o'clock, 9 o'clock and 12 o'clock. And usually the lens echo actually will reduce the amount of sound waves which goes inside. So when you do an axial scan, a transverse scan, actually you are bypassing the lens and getting the details of the lesion more clearly. And one more thing you have to remember is that when you do the transverse scans, especially for intraocular foreign body, most of them tend to remain in the inferior quadrant because of the gravity dependent and the projectile motion of the foreign body. So you have to ask the patient really look down and move the probe posterior, maximum posterior extent to see the anterior most area. So unless you do that, it is not a good thing to write, there is no evidence of intraocular foreign body. And the longitudinal scan, each clock hour you see, and in the longitudinal actually you look at the antero-posterior extent of the lesion. And in the transverse you see the lateral extent. That means like from 3 o'clock to 4 o'clock, that is the lateral extent. And in the longitudinal, you will see that in the longitudinal scan, in the posterior most cut, you might be able to see the optic nerve shadow there. And the scans to look at the macula is axial, vertical and horizontal, and longitudinal nasal scan and transverse nasal. And always remember that whenever you have a mass lesion or something like that, in the scan area the mass lesion should be in the center of the scan. Then only you will get the maximum details to pick up whether regarding the echogenicity, internal details of the scan. So these points you have to keep in mind that it is a reflected image and it depends upon the acoustic impedance, and then you go to the interpretation or looking at the pathologies. So why you want a B scan? Sometimes, nowadays it is basically when there is a media is hazy and you want to make a diagnosis. Second thing is pre-operative. Assessing the posterior segment, especially patient have a total cataract and whether to go inside and operate, then you get a B scan to see how is the posterior segment. And before planning for procedures like vitrectomy in cases like vitreous hemorrhage with a tractional retinal detachment, to see what is the status of the macula, whether retina is detached, or if there is any point in operating, because if it is a closed funnel and if the RD has features of old RD, then it may not benefit the patient. And in some cases to follow up to disease monitoring, especially in cases of surgical outcomes and in inflammatory conditions. So these are the indications which we already mentioned. So coming to a few cases. So this was a 10-year-old boy, the history of needle stick injury, and the patient was treated elsewhere with topical medications, presented with vitreous echoes, pain, redness, chemosis and all. The fundus appearance was like this. And when we did a B scan, the features of endophthalmitis, that means like there is an increase in the retinochoroidal thickness, the vitreous membranes was there, moderate echoes in the vitreous cavity, and it is actually going for a pan-off kind of a picture. We can see that mild subtenant fluid is coming. So this gives you a clue that, okay, the patient is going for panophthalmitis, and then patient underwent vitrectomy, and because it was delayed, the patient was having a lot of cyclitic membranes also, so all the lensectomy, cyclitic membrane removal was done. Following the follow-up, the patient improved to 618. And this was another lady, again presented with a decrease in vision. She had undergone surgery, so history is very important in these cases. And the fundus picture looks almost similar, both has yellowish deposits in the vitreous, but now here you see that here the RC, retinochoroidal complex, is normal, and you can see these vitreous membranes. So when you see this is whenever in doubt, when you see this increased in the retinochoroidal thickening and this minimal subtenant fluid, then think in terms of endophthalmitis, and here it is normal RCH thickening. And this is subhyaloid hemorrhage. So whenever you have a doubt whether this is because it is a high reflective one. And here you see the vector has passed inferiorly. Maybe if the vector was superior here, it would have shown a little more higher spike. So here you can see that after movements are still there. It is moving freely. And this is another patient, 57-year-old gentleman presented with the history of retinal surgery done elsewhere. There was cataract and there was no view of the fundus. So the B-scan showed these moderate to high reflective echos there. And here you can see there is a slight elongation of the axial length also. So when you see these things, then think in terms of, okay, the patient might have undergone a retinal surgery. And asteroid hyalosis, again, it has these high reflective spike dots. Most of the time, the posterior space will be free of these echos. That is how you differentiate between the silicone oil and the asteroid hyalosis. And so this patient presented non-diabetic patients with traction retinal detachment. And here you can see there is a vitreous hemorrhage NVD here. So it is not very clearly able to make out what is the status of the disc there. So you get a B-scan done, it shows that it is a posteriorly closed funnel. So if you are planning for surgery, then we have to anticipate a poor prognosis, explain to the patient detail and the surgical difficulties in these cases. And this is a case of vitreous hemorrhage. Again, you can see that there is a traction retinal detachment there, and that will be restricted movement. Retinal detachment, especially associated with cataract, it gives a very high spike and restricted mobility. And when there is a cataract, and this is how the closed funnel retinal detachment look like. And this is a feature of a retinal cyst there, which implies that it is a chronic retinal detachment. And this is an old RD chronic with a subretinal cholesterolosis. So here, if you see, the retinal detachment is hypoechoic when compared to the surrounding lesions. So don't think that always the retinal detachment will be hyperechoic. That is why it is important to remember the nature of the material. And this is a 70-year-old patient, status post cataract surgery. Patient had developed raised intraocular pressure and almost like an expulsive during surgery, presented with a choroidal detachment like this. So it is important to know whether it is a serous choroidal detachment or a hemorrhagic, because the management differs. And so here it shows that there is echoes in the subchoroidal space, suprachoroidal space. And so this is a hemorrhagic choroidal CD, and the patient was symptomatically, medically managed, and it resolved with time. And we need to, if it is a hemorrhagic and if it is not resolving, we need to do the repeat B-scan at around 10 days and see whether it is liquefying and plan for a surgery. This is how a serous choroidal detachment would look like. And the spike will be M spike in those cases where there is a choroidal detachment. And this case, a patient presented with the pain in the left eye, and you can see that the B-scan shows an increase in the retinochoroidal thickening, and the scleral spike is there, and minimal fluid is there here inferior, suggestive of posterior scleritis. And intraocular foreign body, this you can have these high reflective spikes with the acoustic shadowing posteriorly. Dislocated nucleus, if it is an anterior, you have to use an immersion scan to see whether the nucleus is there inferior down. And this is IOL reverberation. So whenever there is a smooth surface, the sound waves reflect back and forth. So what happens is that the images what you see will be it gives a image or like that. It is like the image, the lesion is coming from the more posterior than the anterior lesion. Because the sound waves, it is reflecting back and it gets delayed for the transducer to pick up. So this reverberation can happen in intraocular lens, metallic foreign body, calcification, air bubble. And tumors, I think OCT is a better one, but whenever lesions like this where there is a retinoblastoma or a Coats disease, you can see the calcification or a hyperechoic lesions will be along the layers of the retina in case of Coats disease, while in RB, the calcification will be in the intratumor. And choroidal melanoma, as I mentioned, you can see this angle kappa, where as you go posteriorly, the amplitude of the wave reduces and you will see a hollow space posteriorly. And choroidal osteoma, this you might see like a whitish lesion, but if you do an ultrasound, you can see that this like a pseudo-optic nerve hyper reflective lesion with an acoustic shadowing. Especially when patient present with the cataract and you have a doubt whether it is a staphyloma or a coloboma, look at the B scan. If there is a posterior hump, then it is coloboma. You can see that a hump like this. If it is a smooth surface, then it is like a staphyloma. And choroidal hemangioma, it is better with OCT nowadays. And optic disc drusen is another diagnosis where you have a diagnostic confusion between papilledema and optic disc drusen, get an ultrasound done, and this persists even in the low gain. Disc cupping, as patient come with the cataract and you do properly a B scan, if there is a large excavation, then gives that some secondary glaucoma or something was there earlier. So to conclude, B scan remains a cornerstone in diagnosing and managing the posterior segment disease, especially when the media is hazy. Thank you.
Thank you, madam, for that comprehensive coverage. Our last speaker for this session is Dr. Ashok Natarajan. Senior Consultant in Retina, Precise Group of Hospitals, Thiruvananthapuram. Over to you, sir.
Okay. Thank you, Sreekanth, sir. Thank you, Calicut, for inviting me today. So, the topic is fluorescent angiogram and ICG. Now, with the advent of OCT and other imaging modalities, the importance of all these invasive diagnostic techniques have decreased, but it still holds some sway in the modern diagnostic modality because these are all dynamic techniques. It's like you inject a dye, it leaks. It is in real time you can see what is happening, whereas in all the other techniques it's a cross-sectional thing. Only at that point of time you know what is happening. So the dynamicity of FFA and OCG I think still holds, and it has got some importance even in the practice of modern ophthalmology. So these are all the history and all that. So whatever, if it is FFA or ICG, it is like you inject a dye, it goes into the body, it goes into the retinal and choroidal circulation, and you take photographs, you can visualize the vessels. And basically it is done to visualize the retina and choroidal circulation. Now what exactly happens? So there is a term called luminescence. Luminescence means emission of light from some source which is not hot, okay? So, and what is fluorescence? Fluorescence means it is a form of luminescence which is maintained by continuous excitation. So, you emit, you inject the dye, you emit a light, you excite the light with a wavelength, or short wavelength light, and the dye emits a larger wavelength light. And you have a barrier excitation filter, and now you can see what is happening when the dye goes through the blood vessels. Now, the dye used in FFA is sodium fluorescein. It absorbs wavelength at 465, 490, that is a blue wavelength, and it emits light at the yellow-green wavelength. So, short wavelength absorb, emits light of a longer wavelength, which is recorded as this dye passes through the vessels. And the dye is excreted through the urine. So, fluorescein through urine, ICG through the liver. So, that is the basic difference. So, you know, basically you should have some idea about the retinal vasculature. So, you have the inner retina and the outer retina. The inner retina is supplied by the central retinal artery. The outer retina is supplied by the ciliary circulation, postchoroidal circulation, basically. And you have the you have the inner blood retinal barrier as well as the outer blood retinal barrier. So, it is like in a car, when you see oil in the radiator, that means there is something wrong. It is the same way. You should not see fluid in the retina. It should be dry all the time. So whenever there is a leak, so where can the leak come? Either at the level of RPE, that is the outer blood retinal barrier, or leak can come at the endothelial tight junctions of the vessels, that is the inner retinal barrier. So these are the areas where problems can come and you can get abnormal fluorescein angiograms. Now this is the vasculature. So this is the principle, this I have already told you, the excitation barrier filters and all that. So what are the indications? Obviously, retinal vascular disorders, macular disorders, choroidal pathologies, and retinal vascular malformations and tumors. So, you know, fluorescein, it's mainly for retina. It doesn't clearly visualize the choroid. So, mainly for retinal pathologies, you use FFA. Okay. Now, procedure, you know, 3 ml of 20% solution is injected over 5 to 10 seconds. So, fluorescein, you know, you can have hypersensitivity, allergies, etc. You better take a test dose before you give fluorescein. Then these are the adverse, you have the most common adverse effect is greenish discoloration, nausea, vomiting, and severe forms can have anaphylaxis. So what are the contraindications? Absolute allergy to fluorescein and relative like pregnancy, asthma, renal failure, significant heart disease. So these are the things. Now what are the normal phases of an fluorescein angiogram? You have the choroidal phase. You see, you inject the dye goes, because the posterior ciliary arteries, they branch out of the ophthalmic artery before the central retinal artery. So you have the choroidal phase. This happens 10 to 12 seconds after the injection. That is the choroidal flush. And then you have the arterial phase where the artery fills. Then you have the early arteriovenous phase where you have the lamellar flow along the vessels. You can see the vein. The border is white, the center is black. That is because of the differential flow between the dye and the plasma is in the periphery and the vessels are in the center. So this differential flow causes this laminar flow pattern in the veins. So when you have this laminar flow, it is the early arteriovenous phase. And this is the late arteriovenous phase, where you can see the whole retina, veins and the arterioles filled with the dye. And the recirculation phase means the fluorescein, it's all filled up, but the intensity of fluorescein now comes down. And the late phase, where you have staining of tissues like Bruch's membrane, choroid, etc. And the disc remains hyperfluorescent. So the filling of the disc and the choroid happens first. So you should know, the disc gets filled even before the retina. Then you have the foveal avascular zone. So if you see a normal FFA, the center is black. That is because of its relative avascularity and the xanthophyll pigments and the retinal pigment epithelium are tall and more thick. That is why you don't see. And there is something called as the arm retina time, arterial phase transit time. So whenever there is an ophthalmic artery occlusion and some block which prevents the dye from reaching the eye, the arm retina time is increased. So that is the significance of this. Then how will you assess a fluorescein angiogram? You have only two things. Either it's less bright or black, or it is more bright. When you have a more bright lesion, it is called hyperfluorescence. If you have a less bright or black, it is hypofluorescence. So what are the causes of hypofluorescence? So hypofluorescence can happen either something is blocking the fluorescence from outside, or the tissue is not just getting filled with this fluorescent dye. So this is blocked fluorescence. You can see blood is blocking the surface of the retina. So this is retinal block fluorescence. Now this is again another block fluorescence, but you can see the blood is under the retina. So this is choroidal block fluorescence. And filling defect. See, that area is not getting filled. You can see a vein occlusion, the blood vessels are not getting filled there. So this is a filling defect. So these are only two types of hypofluorescence in angiogram. Then hyperfluorescence. Hyperfluorescence can be either leakage, pooling, staining, window defect, whatever. So in order to know leak, you see a pipe is broken. So at 1 minute you see little bit of water has come out. At 10 minutes you see a lot of water is there. Only if you notice that change, you can call it a leak. So to see a leak, it is not a one-time thing. So that is what I was trying to tell you, all the OCT, OCTA, it's a one-time thing. It's a cross-sectional image that you see at one time. But angiogram is a dynamic thing. So that is why it has its importance. Then pooling means it is not exactly leak. Something is filling up the cavity and it remains there like that. And the intensity increases. Okay. And staining, it is not increasing and it's seen in the late phase. And window defect means something is not there. So you can see the bright fluorescence behind that. Okay, something should have been there, it is not there. So you're seeing the bright fluorescence behind that thing. Now this is leakage. So this is the early phase, you can see only little bit white. And the late phase, you can see the white is increased. So this is the neovascular network which is causing leak. So this is how you find out leak. Not with one image, but with early and late you compare and then say there is a leak. And this is pooling. Now this is a PED. You can see the initial phase, the area has not increased. The area is still the same. So the dye has gone into the cavity, and in the late phase, the brightness has increased, but the area is still remaining the same. So it is called as pooling. And this is staining in the late phase. You can see all the scar tissue or Bruch's membrane RP, they become more white. So that is the whole thing. And window defect, you see it's a geographic atrophy. And whatever the whole retina and RP complex is destroyed, so you can see the background choroidal fluorescence more clearly. So this is a window defect. Now there is something called as an autofluorescence. Even before you inject the dye, when you see the disc can be hyper-autofluorescent, you can see it in certain conditions like optic nerve head, drusen, astrocytic hematoma, etc. Then you have pseudofluorescence, etc., etc. Where because overlapping of both barrier and excitation filters. Now coming to diabetic retinopathy, see in diabetic retinopathy, initially we had a lot of indications like you want to know where the macular leaks are because we used to treat diabetic macular edema with laser. But now the indications have come down really. Now it is mainly used to diagnose CNP areas, then find out the area of neovascularization. In PDR where you want to treat the PDR. The other indication is unexplained vision loss. But for that also now we have the OCTA where you can clearly see macular ischemia. Instead of that, you don't have to use angiogram. So these are the changes that you see. You can see here, this is microaneurysm. Okay, there you can see the foveal avascular zone is totally gone. There is macular ischemia, and that is diffuse leakage, etc., that you see in diabetic retinopathy. So these are the changes that we usually see. And usually new vessels, they develop in the margin of the vascular and avascular area. And you can see the NVD there also in the middle picture, there is intense leakage. Now maculopathy, there was this focal, diffuse, ischemic and all that, but nowadays with the treatment that doesn't matter. It's either center involving or non-center involving. So the indication for laser is only in non-center involving macular edema. So if you want to find out where the leakages are coming and you want to give your targeted laser, then probably you can do an FFA to find out where the leaks are. So this is aneurysm, this is diffuse leakage, and that is macular ischemia. There is loss of fluorescein and loss of tissue. So these are the basic things. Then another important practical thing is asteroid hyalosis, because when you look at a patient with asteroid hyalosis, you're not able to see anything inside the eye. That is because whatever white light that you're shining inside the eye, it gets scattered by these asteroid particles, and you're not able to make out anything. But if you do an angiogram, only the yellow-green light comes out. There is no scattering. So in a patient where you cannot make out anything, if you can do an angiogram, diabetic retinopathy with asteroid hyalosis, you will be able to assess the patient and the situation better. Example, visual prognosis after cataract surgery, etc. So this is asteroid hyalosis and this is angiogram. Now you can see the macular leaks, so you can make a better assessment. And this is to differentiate between DME and Irwin gas. So this commonly happens. You have a diabetic patient. He has undergone cataract surgery. And you can see a few microaneurysms. And after cataract surgery, you have seen that the macular edema has worsened. Now you don't know whether it is Irwin gas syndrome or it is worsening of DME. Now you do this, you can see disc leak with macular leaks. That means it is inflammatory Irwin gas syndrome. If you just see macular leaks worsening, now you know it's worsening of diabetic macular edema. So that is one way you can do. Because in the second condition, if it's inflammatory, the patient might respond better to intravitreal steroids rather than anti-VEGF. So that is the importance. Then central lateral artery occlusion. See, now many a time, when you have central lateral artery occlusion, you don't do an angiogram. You feel it's already there. I mean, what's the point? But in certain conditions like giant cell arteritis, which can cause central lateral artery occlusion, the posterior ciliary circulation will also be affected. And if you can pick up that on an angiogram, that means, you can save the patient from having CRIO in the other eye also. So you can send the patient, refer the patient to the rheumatologist and start, immunomodulatory therapy. So that is the importance. Then vein occlusion, all these things. Like you have the vein occlusion study which said CNP areas of more than 10 disc diameters. That means there is chance of new vessels. So that is something which you can monitor with angiogram. And new vessels and CNP areas and macular edema. This is CR view. You can see the gross macular ischemia and retinal ischemia and the new vessels at the disc. The new vessels at the disc, gross CNP areas. Then branch retinal vein occlusion, again new vessels there. And choroidal neovascular membrane. So before, like in wet AMD, CNVM was classified based on FFA. You have the classic CNVM and occult CNVM. So classic CNVM means the CNVM is in the subretinal space. That is, it is type 2 CNVM. So you can see it clearly in an angiogram because it is in the subretinal space. Occult CNVM means the CNVM is under the RPE. So you cannot see it well with fluorescent angiogram. So it is occult CNVM. So classic CNVM means you can see everything very clearly. See, that's a bright thing. You can see a lacy pattern in the late phase. The margins are blurred because of intense leakage. And if you look at occult CNVM, because it is under the RP, you cannot see. You can see just fibrovascular PD or delayed leakage from undetermined source. Few bright dots you can see. So that is how you look at FFA in case of a wet AMD case. Then we have PCV. Actually, PCV is something in the choroid, but still FFA gives you some idea. This is the FFA and that is the ICG. So you can still see the PCV lesion in FFA. Okay. Then CSR is one indication where you can see this ink blot pattern. You see CSR is a condition which happens because of the breakage of the outer blood-retinal barrier. That is breaks in the RPE. So if you know the place where the RP is broken and the fluid is coming out, you can have these patterns where there is a break. So one is the ink blot appearance. The other one is a smokestack. Smokestack means not only it leaks, the fluid rises up like that. That is because of the convection currents in the subretinal space due to different concentration of the protein. Then you can also make out RP tracks. These are all areas of RP atrophy, and this can give a good idea about visual prognosis in CSR. Now, Behçet syndrome, it's a kind of a vasculitis which is affecting both arterioles and venules, and you can see this vasculitis and ischemic areas in the retina. And VKH, again, it affects the RPE, and it is a granulomatous pan-uveitis. So, in VKH, what they're saying is you can have this, pinpoint stippled hyperfluorescence that you usually see in VKH, and you can see the angiogram or the fluorescein filling in the cavity, or you have the serous retinal detachments in the VKH, and this dye can fill in that cavity in the later stage. So you have one sign where you have peripapillary pinpoint leaks. If you have like that, it means it is an acute stage VKH. And if you don't have that, it means probably the VKH is in a chronic form. And again, posterior scleritis, you can see that pinpoint leaks from the RP. These are all because of this RP defects due to inflammation. And wide field angiography, you can see this, the importance, you can see the periphery in FEVR. Okay, so it gives diagnosis of disorders in one go. Now ICG, I'll just give you salient points why we should do ICG. ICG also similar, where you use an infrared light to stimulate, and light of higher wavelength is coming out from the dye, and that using a barrier filter, you can visualize the ICG dye in the vessels and diagnose. And ICG is around 98% protein bound, so it remains within the fenestrated choriocapillaries. So that is why you are able to visualize the choroidal system better with ICG. So this is what technique. So you have the early phase, you have the, early mid phase, then late mid phase, late phase, etc. So the first 5 minutes is the early phase, then 5 to 15 minutes, and after 15 minutes to 30 minutes. So that is how you see. So the first 5 to 6 minutes is important because in PCV, if you see hyperintense area in the ICG in the first 6 minutes, that is one diagnostic criteria for polypoidal choroidal vasculopathy. So what are the types of hyperfluorescence that you see in ICG? You have hotspots and plaques. It just means that hotspot means there is a hyperfluorescence, but the size is less than 1 disc diameter. If it is a plaque, the size is more than 1 disc diameter. So that is how you differentiate hyperfluorescence in ICG. So occult CNVM, the importance is you can delineate occult CNVMs better. Now you have a PED, and if in ICG, the PED is seen as a hypofluorescent area. In FFA, it is seen as a hyperfluorescent spot. So in a hyperfluorescent area, if you see some hyperfluorescence, that means there is a CNVM within the PED. So that is one thing you can pick up with ICG. Another one is RAP lesion, that is retinal angiomatous proliferation. That usually, choroidal neovascular membrane develops from the choroid. But in RAP lesion, the new vessels develop from the retina and go into the choroid. So that can also be clearly delineated in ICG. You can see that picture there where there is a vessel dipping into the neovascular complex, and that is one typical feature of RAP. So this is RAP. That is one important indication for ICG. Then this is the important early ICG hyperfluorescence appearing within 5 minutes. So that is one thing of PCV. So you can see those small bulb-like lesions in the ICG. That is the polyp. And peripheral PCV also, if you can have a wide field angiogram or you can do an ICG, you can make out those lesions also. The another one is retinal artery macroaneurysm. Because retinal artery macroaneurysm, usually FFA is obscured because of the blood. So ICG can visualize things behind the blood much better. So retinal artery macroaneurysm is better delineated by ICG than FFA. And choroidal hemangioma, you can see those hemangiomatous lesion, which is hyperfluorescent in the late stage, early stage and late staining. And CSR, you can see a hyperpermeable choroid. And this is white dot syndromes. This is VKH. I mean, this is what I said. There are, in the acute phase, there will not be this block fluorescence in ICG. So this is not a chronic VKH, but an acute stage VKH where you can see pinpoint hyperfluorescence and choroidal hyperfluorescence in the ICG. That is on the left side. The left picture is FFA and the other one is ICG. And this is another picture. This is another VKH where you can see this is the FFA picture on the left side. And on the other side, that is the ICG. It is showing persistent choroidal hypofluorescence. So that means that is a chronic stage VKH. So just by ICG, you can differentiate whether it's an acute stage VKH or a chronic stage VKH. And advantages over FFA, I said, no, visualizes choroid and anything that is obscuring like blood, ICG can overcome. And adverse reactions, as I said, and the absolute contraindication for ICG is shellfish allergy and iodine allergy. So in those cases, you should not do ICG. And other uses is ICG guided treatment, like, feeder vessel in RAP lesion, with ICG you can identify the feeder vessel and you can treat the feeder vessel individually. So that is one thing that you can do. And conclusion, I think with OCT and OCTA, even after the advent of new technologies, FFA and ICG still has its role and it should be judicially used when it is absolutely required. Thank you very much.
Thank you, sir. I request all the speakers of the session to come to the dais for the panel discussion.
First of all, a very good presentation by all the speakers. These are all very, very big topics. In fact, some of the topics require discussion for more than 30 minutes. I think they have successfully managed to present all the relevant conditions in the limited time that has been allotted to them. So, I would like to, because most of us here, we have got a lot of PGs, most of us are not doing hardcore retina. So I think that we should have some takeaway from these sessions. So what I feel is that we will limit our discussions to such topics. So I would like to ask Dr. Prakash about what are the situations where you will do OCTA in your day-to-day practice, because we know that OCTA actually looks at the vessels. So, and there are multiple studies on role of OCTA in conditions like diabetic retinopathy, venous occlusions, etc. But what are the situations in your clinical practice where you actually benefit from doing an OCTA?
That's a very good thing. The main thing is, like, if you have your structural OCT showing a definite signs of neovascular membrane or this, then I don't usually require an OCTA. It is usually enough. But there are situations where you don't have, like the myopic CNVM I showed, where you don't have much signs of activity on a structural OCT, or you have sometimes a CSR with fibrin, which won't tell you even with an FFA or even with a structural OCT whether there is a CNVM as a neovascular complex inside. So these are situations, and sometimes there is some lesions like a small drusen with a drusen ooze or something. So here you are very doubtful because the patient is symptomatic. Many of these patients have metamorphopsia. Then you don't know whether there is beginning of a CNVM or not. So those are situations where an OCTA will definitely help you to differentiate between these conditions. Otherwise, routinely for a DME or anything else, I don't do an OCTA. And again, neovascular, inflammatory conditions like tubercular granuloma or the white dot syndromes, those are situations again an Octa can be very useful.
Do you assess the progression of dry ARMD using fundus photo or OCT? Because idiopathic RP and outer retinal atrophy, I mean incomplete and complete outer retinal atrophy, do you assess using OCT or still you are using clinical assessment for dry AR?
No, for intermediate and advanced AMD, dry AMD, then it is better to use OCT always for following up the patients. Because you can do things. One is as you told, the macular atrophy changes that are happening can be easily, and you can have, many times they have vision drop, you don't know what is the reason. So there you can, the macular atrophy will explain the lesion, beginning of a geographic atrophy, even though we don't have a treatment right now in India available, but still we can at least explain the patient what is happening. So I always use an OCT.
I think another one is autofluorescence, fundus autofluorescence image. No, if you can compare that as well. And there are different patterns of atrophy, which you can, certain patterns of geographic atrophy can progress faster. I forget the names, there are different patterns. So fundus autofluorescence, I think it's a very good adjunct to, instead of a fundus photo. FAF images are much more effective in diagnosing the progression of. And intermediate, early AMD and antioxidants have a role in delaying the progression of dry AMD to a geographic atrophy. But advanced AMD, there is no point in giving a antioxidant. So that also is some point, because we prescribe antioxidants for every AMD patient. So which is better for what also, we should have some idea.
Sir, in patients with CSER, where the patient has fluorescein allergy, what will be your mode of treatment?
See, one thing is you can take a OCT image and look for the RP break from where it has happened. Or you can see where the fibrin is sticking. That is the point where the RP break might be. And in such patients, better put him on eplerenone or some tablet which can have some adjunctive effect to resolving the CSR, and wait for 3-4 weeks and then only go for targeted laser with this OCT, finding out the RP break with OCT. Because studies have, what studies have shown is, they do an FFA, they do an OCT, and they find that the FFA leak is corresponding to the, I mean, nobody has done this standalone and done a treatment. So I think that should be the last resort to do in case of, where you cannot really do an FFA.
Divya, your presentation on B-scan was extremely good, spot on. And you showed some indications where you used B-scan in patients with endophthalmitis. But do you think that B-scan is required in all cases of endophthalmitis? Because we see quite a number of patients who have clinically which looks like endophthalmitis, where the patients get referred until they develop extensive vitreous opacities. So I think the people, most of us believe that, I also as a PG, I used to believe that B-scan is the ultimate investigation that confirms the diagnosis of endophthalmitis. So what do you think about the role of B-scan in endophthalmitis?
In fact, thank you for asking that question even during my presentation, because the lack of time overshoot. So endophthalmitis is basically clinical diagnosis. So we do get patients referred like B-scan, no vitreous echoes, rule out endophthalmitis. It's not. So any patient when you see, you have to make a clinically, if you have any doubt whether it is an early inflammation or keep the patient under your regular follow-up. Because B-scan will not diagnose endophthalmitis unless it has involved extensively causing significant vitreous echoes. So the early signs you have to pick up clinically. So it is not a diagnostic tool for endophthalmitis. It is your clinical diagnosis.
Prakash, another question again for the general ophthalmologists or people who are mainly doing cataract surgery. Do you regularly advise OCT for all patients who are planning for cataract surgery? Do you think that it's important?
No, I don't think, we don't as a protocol do OCT for all cases. But as I told, if you have something suspicious, like if it's you see few microaneurysms at the center of fovea, it's better to do an OCT, or you see a dull FR, it's better to do an OCT. You see few drusen, it's always better. So any macular pathology, if you are seeing, then it's for a clinical, if your fundus examination is good enough, like if you have asteroids and your macula is not visible, better to do an OCT. In those cases, OCT can pick up those. Even some cases with like the Heidelberg machine and all, even with moderate amount of cataract, you can pick up macula better than a clinical examination, fovea. So 1 or 2 pictures at least you will get. So in those cases you can do, but otherwise, for all cases I don't do. Where the macula is clearly visible to me with a 78D lens, I wouldn't go for an OCT.
I think the stress is on if you are able to do a good macular examination.
One thing, I think the new IOL calculation machine like Lenstar, I'm not very sure. They have an OCT also. Like you get an OCT image also. So many a time it is picked up like that. Like you can see it. And one thing is, see, not all patients are seen in the retina clinic or something like that. So I feel at least premium patients where you're promising a lot of things to the patient, at least in those group of patients, if regular OCT screening of the macula can be made a regular practice, I think that is a fair balance between not taking and taking for all patients.
Ashok, you have got a patient with diabetic retinopathy, and patient also has got cataract. So when will you think that, okay, I will go ahead and do a fluorescent angiogram in this patient? Do you do it for some diabetic retinopathy here and there? Will you think about going for
fluorescent angiogram, if you want to get a good image, you need good visualization of the retina. So if you don't have good visualization of the retina, there is no point in doing a fluorescent angiogram. And second thing is, like, you have OCTs. No? So what is the indication for treatment in diabetic retinopathy? One is center involving macular edema. 2 is PDR and new vessels. Now PDR and new vessels can always wait after cataract surgery. You can do an FFA and find out if you want. The only thing you are worried when diabetes and cataract is there is center involving macular edema. That you can do an OCT and see. And even though in the OCT, if you find that there is a center involving macular edema, like you can combine it with anti-VEGF. Like in Ozurdex is actually FDA approved for combination therapy with cataract surgery. Or you can combine it with an anti-VEGF, counsel the patient, and post-op, if you really feel that it needs more assessment, you go with an FFA and do laser or whatever you want.
Do you have any difference of opinion on doing fluorescent angiogram in cataract patients or Prakash?
I agree completely with Ashok. The fluorescent angiography before cataract surgery is not big, because if you have a good view, you can see clinically all these lesions. And if you're told after the cataract surgery, you can easily do a fluorescent angiogram, which will give better picture. So when the patient, you are subjecting the patient to an invasive procedure, better do it when you have a good view of the fundus.
I am little different. I have got a different opinion because I have had few patients where cataract was there. There was some amount of diabetic retinopathy. Patients were diagnosed to have severe NPDR and sometimes even at moderate NPDR. And ultimately, after surgery, some of the patients they came back with vitrecin. Again, it depends upon how good is your fundus. So for the general public, if you are thinking that you are seeing some of the diabetic retinopathy, if you are not sure about the stage of diabetic retinopathy, at least to prognosticate. You can do the laser after cataract surgery, but at least you can tell the patient that, okay, you are having a proliferative change there. I always prefer. So for the message I would like from my perspective is that if you are seeing some diabetic retinopathy, if you are not sure about the stage of diabetic retinopathy, at least send to a person where who can actually evaluate the fundus properly with confidence and say that there is no diabetic retinopathy. Or then if you have got the facility, get a fluorescent angiogram, at least if it has crossed the stage of severe NPDR, or a patient has got a proliferative change in the other eye. That is how I go ahead with this patient.
For any patient you see diabetic retinopathy before cataract surgery, it's important to tell possible need for injection and laser after cataract surgery and assessment. So for all patients, whatever, irrespective of the stage of the disease, you can tell that. So that will save you from getting sued later or something.
In patients with macula of RD with significant cataract where you cannot do a retinal detachment surgery without removing the cataract, for calculating the axial length, does B scan along with A scan help?
No, the conventional, what I usually do, I wanted to tell this in the previous discussion also, where axial length you have to calculate. Many times you have a macula on RD, macula off TRD or a rhegmatogenous RD where the retina is off. So when I prefer to use the conventional ultrasound based biometry, so So you have the vector, you have to you have to teach your optometrist to look at the vectors. You have first one from the cornea, anterior lens surface, posterior lens surface, and from the retina choroidal. So that vector will be seen as 2 in the posterior-most vector. It takes the fourth vector, the distance between the first and the fourth is taken for the axial length. So here you move the vector to the choroidal or the RP layer and then take the axial length. So this you have to teach your optometrist. So whenever they see 2 splitting of the vectors posteriorly, that means there is an RD in front, or RD or some opacity is in front. So the second one they have to take. The machine automatically takes the first one.
Immersion. Immersion.
No, normal ultrasound also. So they have to just change the vector. They have to put the measure between the last vector and the first vector, the first one from the cornea and the last one. So they can manually do that in an ultrasound, especially sonomet it can be done. So that's what best option to calculate axial length in. Otherwise you will take the retinal surface for the axial length, that will be artificially. So even with optical biometer, we have optical also, but I prefer doing on an ultrasound biometer when you have RDs involving macula or
and again, in OCT, I think this is going to be the last question, so we can move on to the next session. Prakash nicely showed some conditions with the pachychoroid. So, what is pachychoroid? Or what is the cutoff choroidal thickness that you consider for pachychoroid? Just for everyone's information.
This is actually pachychoroid. I want to tell fellows or PGs also, it is not like the normal choroidal thickness can vary from 200 to 500 microns in normal individual. So it is not an absolute number. It is a presence of a large choroidal vessel or a larger outer choroidal space which is compressing upon the choriocapillaries, and the choriocapillaries thinning. So choriocapillaries is the area where the oxygen transmission to the RP happens, because it is only through capillaries oxygenation happens. So it is good, you should have a healthy choriocapillaries under the RP for you have a healthy RP also. So if the choriocapillaries is compressed due to reasons like a large choroidal vessel or a choroidal hyperpermeability, large choroidal perfusion pressure, there is a lot of osmotic pressure in the choroid, then it compresses on the choriocapillaries. So this leads to a hypoxia. The hypoxia is the cause for the pachychoroid related neovascular process like PCV or pachychoroid neovasculopathy, whereas the choroidal hyperperfusion or the choroidal increased osmotic pressure is the cause for the conditions like CSR, where the fluid comes under the RPE first and then under the sensory retina. So it is not actually, it's not a actual number cutoff. What you have to look at the choroid, you have to see if there is a signs of choroidal increased choroidal pressure, or is there anything compressing. So the thinning of the choriocapillaries is the most important finding that you should look for to identify pachychoroid.
In fact, there are also conditions where you don't have a thickening of the choroid. You can have patients with pachyvessels in a thin choroid and can have complications secondary to that. Okay, so I think we will conclude our discussion here.
Thank you, sir.
Yes, Dalia has some question.
Who were on tamoxifen and had this OCT picture. So how do you differentiate?
I think you are lucky. I have only one patient, so you should be knowing more than me by now. Because I only recently came to know that I think we had the common case to all of us. So tamoxifen toxicity can very much mimic macular telangiectasia. Traditional teaching is that tamoxifen toxicity happens after 2 years of usage. And crystalline maculopathy is what is described clinically. So the problem is in mactals also you see crystals. Fine crystals can be seen if you examine clinically in mactal also, and you see this ILM drape and other signs, degenerative retinal spaces, outer retinal spaces, which can be seen both in mactal as well as tamoxifen toxicity. So we recently saw a patient who had hardly been 6 months into tamoxifen and had a similar picture. So only way is to stop tamoxifen and see, I think, because tamoxifen toxicity it can return at least some changes can come back to normal. Whereas in a mactal it is always progressive. It is never going to come back to normal. So I think that's the only way to
any FFA.
FFA again, I think it will be leaky on. I didn't do an FFA in that particular case, but I think I don't think any typical FFA description is given for tamoxifen toxicity.
Since we are talking about drugs toxicity, one point. Prakash showed a picture where it was a flying saucer sign, where we have the intact the ISOH junction only at the center, rest is gone. So one point just I would like to add is that we may have the ISOS junction discontinuity not exactly the same. Sometimes they can have in the periphery also. So you have to screen the entire macula to look for HCQ toxicity rather than just looking at the central scans.
See, before taking for cataract surgery, I have in patients having in moderate NPDR or severe NPDR, is it necessary to stabilize them with laser before doing cataract surgery? Because I have heard that there is a possibility of developing DME, macular edema, after surgery. So there will be a drop in vision. So what is the protocol?
Two things, ma'am. If already there is a center involving macular edema, it is better to treat that first and stabilize before taking up for cataract surgery. But if the macula does not have any macular edema or center involving macular edema, we can take up the patient for cataract surgery followed by OCT evaluation of the macula at 1 month, and then if there is worsening of macular edema, you can take for injection.
Only thing is we have to tell the patient about the
Yeah, you have
prognosis.
to, that is the most important aspect. You have to tell the patient that you have a problem, because many of them won't understand that. So you may need injection, has to be clearly mentioned to them after cataract.
In some cases with the minimal edema, you can actually combine an injection with cataract surgery so that it will prevent the worsening in the post.
Yeah, one thing is worsening of diabetic retinopathy and diabetic macular edema is it is established after cataract surgery. That is a fact. So that thing you have to communicate to the patient that after cataract surgery, DME or diabetic retinopathy can worsen. It is a known thing. And if it worsens and if there is any issue, it has to be treated. So that counseling you have to do to the patient. Yeah.
Madam, if we have got a non-CI DME, a lot of hard exudates adjacent to the fovea, it is very likely to progress after surgery. So what I do is I usually give them an injection and then advise the patient for cataract surgery. Then your question about a severe NPDR, a severe NPDR probably is one of the indications where you can do a PRP before you go for cataract surgery.
The same thing, if you have the patient has taken injection in the last 6 months for macular edema, then the chance of them having recurrence of macular edema after cataract surgery is very high. There, as Rajesh told, we can do a comment. But the patient is having that changes for a long time, has not had any recent injections, then very unlikely to have a development of worsening of macular edema after cataract surgery. They may be explained the need for this thing and taken up for surgery.
You can get a wide thickening, but I think it is not a diagnostic thing.
You can diagnose.
Rajesh sir, this person to answer that.
So optic neuritis is inflammation of the optic nerve. So B scan you cannot conclude. You can only say that there is a thickening of the optic nerve sheath. There is a fluid. You can also see the solid tumor on optic nerve, but you can't say that this is optic neuritis. B scan has been used for patients with papuloedema. That's one of the diagnoses. If you don't have an access to anything else, you do B scan. It can, as she said as well, if you reduce the gain, and if you have a hyperechoic space at the optic nerve, you say that it is drusen. If you don't get that hyperechoic space, and if you have fluid around the optic nerve, sometimes it is used for confirmation of papuloedema, but not as optic neuritis.
It is very useful for benign intracranial hypertension also. Probably the fluid around the perioptic space, you can do a 30-degree test and see if there is a fluid. So those cases may improve with the surgeries.
I think there is one more session before lunch, so we'll stop here.
Yeah.
Thank you very much.
Thank you, sir. I would now request Dr. Padmaja Krishnan Madam to please present mementos to the speakers and panelists on our behalf. Dr. Prakash V.S. Dr. Divya Balakrishnan. Dr. Ashok Natarajan. Dr. Rajesh P. Dr. Shabarish MD. Thank you all the speakers and panelists for being with us today.
I'm back to deliver a sugar spike and a calorie spike. One question. Remember, loudest shout. I may look like glaucoma, but I am not. I raise pressure and love creating doubts. My angles look open, yet the pressure won't drop easily. Treating me with glaucoma drops alone might not help a lot. Want me to repeat? I may look like glaucoma, but I am not. I raise pressure and love creating doubts. My angles look open, yet the pressure won't drop easily. Treating me with glaucoma drops alone might not help a lot. What am I? Yeah, louder shout. I'll give it here.
Posture Shoswitz.
Well done. Thank you.
For the next session, I'd like to invite onto the dais our panelists, Dr. Lakshmi C. Professor in Ophthalmology, Malabar Medical College. Dr. Anju Chandran. Pediatric ophthalmologist, Comtrust Eye Hospital. Dr. Suma Unnikrishnan. Professor of Ophthalmology, Government Medical College, Pariyaram, Kannur. So our first speaker for the next session is Dr. Rashmin Gandhi, sir. He'll be speaking on clinical and imaging diagnostics in neuro-ophthalmology. Over to you, sir.
Thank you so much. Thank you, Dr. Sreekanth, Dr. Sisira, and the entire team at Sreekanth Eye Hospital and Research Center for giving me this honor. I promise, I know that we are standing between you and lunch, so I'll whet your appetite and try to make it as brief as possible. These are all cases. So since I was asked to talk about imaging, these are the questions that you'll ask if you see a patient where you're going to request for imaging. Why are you requesting for imaging? What imaging modality that you will be requesting for? If it's a neuroimaging, remember in neuro-ophthalmology, you'll have two types of imaging, neuroimaging and ocular imaging. So if it's a neuroimaging, you probably would like to say which region you are interested in. How are you going to use this information? This applies to some of the questions. And last one is OO. If you don't request for neuroimaging or if you don't read it properly, then that's how you're going. And you have two cases where imaging actually misguided you. So let's now look at imaging in patient who has presented with you with an acute loss of vision. So this is a 46-year-old male, comes to you with a sudden painful loss of vision in the left eye. His visual acuity in the affected eye is no PL, the right eye is fine, and this is how his affected optic nerves look like. The right optic nerve was okay. Okay, so Why would you like to give a request for neuroimaging? No PL, acute loss of vision, 46-year-old male. Shout out the answer, postgraduates or even practitioners. Why do you require neuroimaging here? Sorry? Amazing. I think this deserves a round of applause because it's not that common, and that's what this patient had actually, to rule out optic nerve infiltration. But to bring it down a notch and say that any patient who has an optic disc edema, you'd like to do neuroimaging because you can only see the optic disc. You don't see the rest of the optic nerve and also anterior visual pathway, which can be responsible for that edema. So only optic disc edema where you may not require neuroimaging for diagnosis or confirmation of diagnosis is non-arthritic anterior ischemic optic neuropathy, where patient has sudden loss of vision, has a sectoral disc edema, and has a very small disc with a small cup in the same eye and also in the other eye. Rest all, you may not be able to conclude saying why this patient has optic disc edema. That's the reason you require neuroimaging. Now, the commonest cause of optic nerve problem in the younger population is optic neuritis. Older population is ischemic optic neuropathy. So first is why are we ordering it here? Now what neuroimaging would you request for? MRI, ultrasound, FFA, we heard all that, OCT or CT scan. MRI or CT scan? Yes, very good. Please remember, for all optic nerve related neuroimaging, MRI has to be ordered. MRI, we need to specify a little more if you're going to request, because otherwise we will not get the entire information. What would you write in your requisition form? MRI, MRI, brain with orbit. Anything else? With contrast. Please remember, unless there is a contraindication, which is a renal failure or a prior history of allergy to gadolinium, contrast is necessary for all patients where you are requesting for MRI for our purposes. So MRI, brain and orbit with contrast. If you are able to provide additional information to the radiologist that you are thinking of optic neuritis, he will run the special sequences. All right, very good. So MRI, brain and orbit, you're looking for optic nerve. And why are you ordering? If you are requesting for MRI in patients who suspect to have optic neuritis, you're also requesting for MRI to rule out the associations. The associations are demyelinating disorders like multiple sclerosis, NMO-related optic neuritis, or MOG-related optic neuritis. Please, all these three can be reasonably diagnosed on MRI itself. This is how the MRI looked like for that patient. There is a thickening, and that's why we concluded that it was an infiltrative optic neuropathy. In fact, the patient had leukemia. Please remember, infiltration is a serious disease of optic nerve. Leukemia can present like this. All right. So we move on to second patient. 34-year-old female, sudden painful loss of vision, right-sided headache, some eye pain. This is how her visual acuity looks like, 3/60, 6/6, disc edema in the right eye. This is how the optic nerves look like. You see here the optic nerve of the right side, and you see the optic nerve of the left side. All right. What MRI? You know that this is probably, there is a disc swelling. What MRI would you request for? We said it. MRI, brain and orbit with contrast. Okay. That is what was requested for. He said maybe this is optic neuritis, brain was normal, patient was given IV methylprednisolone, 2 doses, and she said 3/60 became 6/6. Even by first dose, patient was saying, very good doctor, you are the best doctor. And by second dose, she was 6/6 back to normal. Should you be jumping with joy, or there is something which is, obviously question is being asked, so there is something which should be troubling you. And once patient, the steroid was being tapered, she came back with now 2/60 vision again, and now you see here, there is a peripapillary dirty looking lesion, which probably is a CNVM following an inflammatory lesion of choroid. So patient did not have optic neuritis to begin with. it was always a choroiditis. Please remember, posterior uveitis, retinochoroiditis, chorioretinitis, they all can produce secondary disc swelling. Here, however, not so common, but can happen, where patient actually had disc swelling because of a choroidal lesion which was in evolution. And you can see it on FFA here. This was the first presentation, and this is the final presentation. So question is, since imaging told us, this is a class on imaging, that probably it was optic neuritis, and again, all this inflammatory lesion of uvea respond beautifully and dramatically to these steroids. But optic neuritis would not respond dramatically. So the question is, was it something which was in our clinical examination which was missed out, and we went on a completely wrong pathway? And this is where it was. Patient with 3/60 vision had brisk pupils with no RAPD. Please remember the talk title is Clinical and Imaging. In neuro-ophthalmology, a clinical finding would guide you towards imaging. And this was one of those OHO cases where RAPD was missed out. Every unilateral optic neuropathy, irrespective of etiology, would produce RAPD. If you don't see RAPD, it is not an optic nerve disease, or it is a bilaterally symmetrical optic nerve disease. Great. So that is about acute loss of vision. Let's move on to double vision. So picture on your left, patient complaining of double vision, 64-year-old female, 64-year-old male, uncontrolled diabetes, uncontrolled blood pressure. Looking to the right, to the left, up and down. What are you thinking of? Third nerve palsy. Neuroimaging required? Yes, or you want something else? There is already another photograph on the right hand side. Very good. So now, look at the pupil in the affected eye. What do you think about the pupil? Dilated. Neuroimaging required? Very good, ma'am. Emergency. All right, why emergency? Aneurysm. This patient, 50% of the patients who present to you with pupil involving third nerve palsy can die before they get medical attention. So neuroimaging is an absolute, not only necessary, it is an emergency. What neuroimaging? So V is vein, aneurysm is artery, so MRA. Okay? Rule of pupil does not apply to this patient. This patient also has a third nerve palsy, but this is a partial third nerve palsy. So rule of pupil applies to a complete third nerve palsy. Here you can see that here, of course, the pupil was helpful and also dilated, but here otherwise the ocular motility, let's say adduction was fine, only the elevation with partial ptosis. What it tells you, it is a partial third nerve palsy, but if you see a patient with partial third nerve palsy, that also is an emergency. They should immediately go for neuroimaging. All right. Now the third scenario, bilateral disc edema. 28-year-old female, slightly overweight, visual acuity shown here. This is how both optic discs look like. She has been having headaches for the last 1 year, and for the last, she was not treated. She was given paracetamol and whatnot, and now she says that now there is a little bit of blurring. What are you thinking of? Bilateral disc edema, slightly over a patient, probably on oral contraceptive pills. So you're thinking of papillary edema, raised intracranial pressure. IIH is the disease of, IIH is the diagnosis of exclusion. You need to make sure that all the causes of raised ICP have been ruled out, which will be by imaging. So now the question is, what imaging would you be requesting for? Here, bilateral disc edema, you want to rule out papillary edema, raised intracranial pressure. So you'll be requesting a MRI brain in orbit, but also indicate to your radiologist that you're thinking of, you want to rule out raised ICP so that, no, before lumbar puncture, this is imaging. So very good. Here, MRV would be added if the radiologist does not find any cause in MRI. MRV is done to rule out venous sinus thrombosis. The incidence of venous sinus thrombosis has dramatically increased in the last few years because of COVID and the vaccines. But before that, you need to also make sure that you're dealing with a true disc edema and not with a pseudo disc edema. So if you want to also rule out pseudo-dyskinesia, which can be optic nerve drusen. We'll also look at the OCT, which Prakash beautifully explained. The picture on top, you see there is a lumpy, bumpy appearance on OCT, which is generally seen in optic nerve drusen, versus the lower picture, which also has the dyskinesia, but there's a smooth contour, which is seen in a true dyskinesia. The optic disc drusen can also be ruled out by ultrasound B scan, as we discussed, and also by fundus fluorescent. Now, I want to, in the next 3 minutes, I want to now emphasize on role of OCT in dealing with patients with raised intracranial pressure and why our role as an ophthalmologist is very important. All right, it's not enough for us to say that now go to neurologist, do the lumbar puncture, and be done with it. We effectively nowadays would be guiding the management, and I'll highlight that by some of these patients. So this is a 34-year-old female, headache, minimal blurring of vision. You can see clearly there is a bilateral dyskinesia. For the PGs, what do you see in the fundus? This is a typical fundus picture of raised intracranial pressure, acute raised intracranial pressure. So what you have here is enlarged blind spot. If the disease is not treated, patient actually will have tubular vision. We did the OCT, this is average RNFL, you say it's increased. The treatment is generally acetazolamide in 1 gram, so there is our first contribution. A lot of neurologists generally start with only 500 or 750 milligram, but we know in glaucoma sometimes we give 1 gram as well. In fact, some of these patients who are overweight, we can go up to 2 grams. So one thing is, if the dyskinesia is severe, make sure that the acetazolamide dose is appropriately given. So that's one patient where we did the OCT, we gave the dose. Now this is second patient. 24-year-old female, 6/6 vision. Chronic headache, she said, my vision is fine. I'm not really concerned about my vision. Please take care of my headache. Went to neurologist said, oh, there is a papilledema. Sent to ophthalmologist, and you can clearly see there is a papilledema. We did the OCT. Of course, we know that average RNFL is increased and would be increased, which reflects the dyskinesia. But neurologist said, it's a mild disease. She just has headache, no visual problem. So I'm going to start with minimal dose of acetazolamide, and she would come along. Is there something else which we can do which will determine that are we on the right course at this point? So what can be done, or what should be done, apart from OCT RNFL, is also look at the macular cube and look at the GCC. This patient, though, did not have a massive problems with her vision, but her GCC has already started thinning. What it tells you is that the disease process is aggressive, and if you don't really intervene aggressively, she might actually go downhill. She's fine right now. A lot of these raised ICP can actually suddenly start going downhill. So these are the patients where you have to make sure that you give a higher dose of acetazolamide. I'll take 2 more minutes if you don't mind. So this is a reverse. 36-year-old male has bilateral dyskinesia. Again, RNFL has increased, but here you know that the GCC is fine, and whatever conservative treatment that you're taking, probably he'll come along. This is another chart which tells you that here, this is a follow-up RNFL. So that's another, so one OCT, role of OCT, you do RNFL, you do GCC, you contribute to the management. You know that this patient requires an aggressive treatment. Second is follow-up. When you're following the patient, you now have objective assessment. Patient started with 230, first follow-up visit went down to 133, 133, 152. So you know that it has come down and it is staying in a particular category. So that's the second role of OCT which we can contribute to the management of these patients. Let me conclude with this OHO patient. 10-year-old female, complaining of headache, reduced vision for 4 months, went to neurologist. Neurologist looked at the disc with their direct ophthalmoscope and said, oh, you have bilateral dyskinesia, you have headache, this is raised intracranial pressure. Patient was started with Diamox. For 3 or 4 months, that baby was on Diamox, but she was not improving. So that's why she came to, and while she was with the neurology, ophthalmologist was called to the neurology ward for confirmation. He went with indirect ophthalmoscope and said, yes, there is a bilateral disc edema, I agree. And patient was continued on acetazolamide. She continued to deteriorate, and that's where she sought the second opinion. And even after 2 or 3 months, you see that there is a bilateral disc edema, so that part was correct. However, what was missed out was this patient was never given a complete ophthalmological examination, which was done when she came for second opinion in the ophthalmology OPD. And when we looked at, patient had multiple vitreous cells, and vision was going down because of cystoid macular edema. So patient actually had intermediate uveitis to begin with, which led to eye pain, interpreted as headache, disc edema. Every intermediate or posterior uveitis can produce disc edema. So patient actually continued. MRI, when it was done with the neurology, always when you give a diagnosis, a lot of times it will come back as query, suggest clinical correlation. Now, if your clinical pathway was already little deviated from routine, then you will say, oh, I do correlate that this is a raised ICP. So that's the reason why complete ophthalmic or neuro-ophthalmic examination, which will include pupil and color vision for every patient, and in a disc edema, complete ocular examination to make sure that your disc edema is not coming from the eye is an absolute necessity. And if you do that, your imaging then would be a good adjunct for you. I thank you once again.
Thank you, sir. Our next speaker for the day on orbital imaging is Dr. Marian Pauly. I welcome you, ma'am.
Good afternoon. At the outset, let me thank Dr. Sreekanth and team SKH for giving me this opportunity, and I really congratulate for taking up this topic as the theme. Even though in the era of artificial intelligence, all the patients are also looking into uploading the images into the AI tools, and they're coming to us with a diagnosis. In the first part, I will just speak about, because of the pages, some pages are there, how to read a CT scan or MRI. Sorry for the delay. So why orbital imaging is important for ophthalmologists? We know the better anatomy of the orbit, and we can correlate it clinically, and we can document it. And most important thing, orbital disease accounts for a small part of the radiologist's average scan load. And always remember, it is never a replacement to the clinical evaluation. So which imaging, actually, RAG sir was telling, which imaging we will see through the cases. So how to request for an image? When you see a patient and don't write CT orbit, come back, no. So what is the provisional diagnosis? And if it is a case of dacryoadenitis, you have to write, look for the enlarged lacrimal gland, look for any enlarged superior rectus muscle, lateral rectus muscle, or any proptosis. And orbital size is always 2 millimeter cuts. If you are suspecting something at the apex, go for 1 millimeter cuts. Axial, coronal, sagittal. In case of trauma, ask for a 3D reconstruction also. And quality image is very, very important for us to read the scan. Otherwise, it's very difficult to read. Then ask for tissue windows also. So tissue window means in bone window, you see bone more clearly. And in soft tissue window, you see the muscles, optic nerve, and glaucoma gland clearly. Then how to read? Either you can use an X-ray viewer, or nowadays Radiant Dico viewer is a free software available from the net, where all the patients are carrying a CD with them. You can put the CD and read through the scans. So what is an axial view? So axial view, you can see the anterior end is facing up and the nose flattens as we go superior, and you can see more brain tissues. Coming to the coronal view, so you can see anteriorly the orbital cavity is wide, and as you go posterior, the cavity narrows. This is a 3D reconstruction picture. So now coming to the bone pathologies. So when you see a scan, look at the bone walls first. See, all are uniform. And in this, you can see this left orbit, there is an anophthalmos with a contracted orbital cavity. There is a contracted socket. Then in this case, you can see there is a fossa formation. There is a tumor, that is pleomorphic adenoma. You can see that C-shaped. It shows it's a benign tumor. This is again another lacrimal gland tumor. You can see punched out erosions, shows it's a benign malignant tumor. And if you look at this, you can see some of the walls are missing. So which condition, any idea? Is absence of greater wall of sphenoid seen in? Yes. So coming to the extraocular muscles, so normally it is seen as a ribbon-shaped structures, and you can see middle rectus, lateral, inferior, and superior rectus. In the superomedial quadrant, you can see the superior oblique, and under the superior rectus, you can see superior ophthalmic vein. So when you see the scan, you have to look into each of the structures, even if you are seeing a regular scan or even any inflammation, so that you will not miss anything. So in thyroid, you can see enlargement of the muscles, and this is a fusiform enlargement. Coming to the eyeball, look at the ocular codes, status of the lens, then tumors and foreign bodies. So now coming to the cases. So first is, we see lots of inflammation cases in our OPD, how to go about it. So this is a 54-year-old male, swelling right eye since 3 years, had undergone multiple imaging in the past. So on examination for me, I felt a mass in the superior orbit. So my first diagnosis was lymphoma, because this is the most common intraorbital tumor. So now look at the scan and the radiologist report. So we can see there is a ill-defined mass or fairly well-defined mass in the orbit, extending in the intracorneal, extracorneal spaces, not causing any globe changes. And angiogram is normal. So the radiologist reported it as low flow venous malformation. So now what should I do? In fact, they have done an ultrasound also. They have put it as a vascular tumor. So I just trusted my clinical diagnosis. Even I went ahead with the biopsy, and histopathology proved it as lymphoma. So what is the characteristic in this image? So you can see this mass is actually embracing the globe. Lymphoma usually mold around the structures. That's a characteristic feature of lymphoma. Whereas what you see in vascular malformation. So this is a case of venolymphatic malformation, usually seen in a younger age group, and you can see multiple nodules in the intracorneal as well as the extracorneal space, causing proptosis. Sometimes we can see chocolate cyst-like thing, and sometimes they present with acute onset proptosis. So all these features were not there in the previous case, so it was a case of lymphoma only. So coming to schwannoma, so schwannoma was the clinical diagnosis in the original case. So schwannoma is usually intracorneal and usually present with proptosis and with no evidence of any inflammation. So now coming to the another case, he is a 45-year-old, again presented with a retinal inflammation. Working diagnosis was scleritis, OSSN, orbital inflammation. So this is the clinical picture. This is very characteristic. What is it? Salmon patch seen in lymphoma. So now let us see what the radiologist has written. The most likely differential diagnoses include thyroid ophthalmopathy and orbital pseudotumor. Less likely differentials include neoplastic etiology, lymphoma, or metastasis. So should I trust this, or should I go ahead with my clinical? So I have done a CT scan in this case because he had imaging long time before. So now look at, this is the medial rectus muscle totally infiltrated with the tumor tissue, and this you can see it is involving the whole entire muscle, tendon as well as the muscle belly. So I directly went ahead with the biopsy and turned out to be lymphoma. So now what went wrong in this case? So now look at the original diagnosis was thyroid eye disease. So clinically, if you look, thyroid is mostly bilateral. It can come as unilateral also. And in thyroid, multiple muscles are involved. So But whereas lymphoma, mostly it affects a single muscle, but it can affect other muscles also. So this is a correlation between clinical as well as the radiology. So this is another patient, 62-year-old, again presented with the swelling since 8 months. He had retinal pain, already treated with multiple steroids, etc. So this is his clinical picture with S-shaped ptosis. So you are localizing your pathology to the supratemporal quadrant, most likely lacrimal gland. So this is the CT scan showed there is an enlarged lacrimal gland, and in this you can see it is actually molding around the globe with no definite, if this much inflammation is there, it should cause so much of inflammation in the other orbit also. So that is not there. But radiologist was in favor of dacryoadenitis. So here also my clinical diagnosis as well as the radiological diagnosis was lymphoma, and histopathology proved it. So should we always have to correlate clinically. So now see how a dacryoadenitis look. So this is a young girl, again present with a recurrent lid edema. So look at the scans. So this lacrimal gland area is fully fuzzy, lots of inflammation. And superior rectus is also minimally enlarged. Lateral rectus is also a little fuzzy. And she was a case of dacryoadenitis. Actually, since she was not responding to steroids, we did a biopsy to prove it. And it was IgG4 related orbital disease. So now coming to another patient, 68 years, again presented with the pain, retinal swelling for 3 weeks. Vision is 680. Here RAPD is there. That's a catch point. So my differential diagnosis, either it can orbital inflammatory disease because she was a diabetic, or it can be aorticocavernous fistula or thyroid eye disease. So now look at the scans and the radiologist report. So they have put it as non-specific inflammation with enlargement of recti muscles. Angiogram was normal. So now look at the CT scan. Even CT scan reported as there is mild extracorneal fat stranding in the superior aspect of right orbit with prominent vascularity. Right superior ophthalmic vein appears dilated within the right orbit, suspicious of inflammatory etiology. So since the patient came to us, we had primary diagnosis either inflammation or CCF. You can see this superior ophthalmic vein is really dilated, and this is called J sign in CT scan. So look at the coronal sections also, you can see the enlarged superior ophthalmic vein. Patient was referred to the interventional neuroradiologist, and she did well with embolization. So have to always correlate clinically. Infections, we always see and treat orbital cellulitis. If you're suspecting abscess, get a CT scan done, because to know the source of infection also from the sinusitis. So this girl has got a subperiosteal abscess, which can be managed conservatively. Then in suspecting fungal infections, go for an MRI to assess especially in mucormycosis, you need MRI to confirm as well as confirm the diagnosis and to monitor the disease treatment also. So now in trauma, so this is a 40-year-old laborer, injury with a metal rod, inconsistent PL, orbital apex syndrome. All movements are restricted. Which imaging? CT. So CT scan showed metallic foreign body, which needs immediate intervention. So this is another patient, young patient presented with the history of injury with the branch of tree 2 weeks back with the swelling in the left eye, and you can see an aberration that has even healed. Whether this requires an imaging or not, or should I treat with it needs. Which imaging? MRI, because MRI detects organic foreign bodies. So we can see there is a hypoindent shadow, linear shadow, which was suggestive of foreign body, and it was removed and he did well. So now coming to 11-year-old male who had sustained injury while doing skipping rope game. He couldn't even open the eyes. The elevation is grossly restricted. Now look at the CT scan. Here, image, even though he's a pediatric, the image of choice is CT because you have to assess the fracture. In one cut, you can see there is no inferior rectus at all. Left side, you can see the inferior rectus here. Here, the muscle is missing. So this is a typical trapdoor fracture with muscle is entrapped. Even in the sagittal, you can't even see the fracture also. So here, actually, radiologists called me. I'm not seeing any definite fracture with the displacement. So this was the fracture. This was a typical trapdoor fracture. He had all the vasovagal symptoms and he operated immediately even before the CT scan report came, and he did well at 3 weeks follow-up. So this is another patient, again diplopia following functional endoscopic sinus surgery. Here inferior rectus is partially entrapped. Here you can wait for some more time with steroids. So in CT scan will help in assessing the time of intervention also, but still again depends on your clinical decision. Role of MRI to detect for organic foreign body, muscle laceration, optic nerve injury, and if associated brain trauma. So this is diplopia following trauma. You can see there is a hematoma in the medial rectus muscle. There is fracture also, but there is no entrapment. So that muscle hematoma was causing the diplopia. He was treated with the steroids and he has improved. So coming to the tumors, retinoblastoma we have seen, is the clinical diagnosis. B-scan we have seen. So what's the role of MRI? To assess the optic nerve involvement, that is postlamellar optic nerve invasion, choroid and extrascleral invasion, as well as pinealoblastoma. This is a 22-year-old male, recently came to us with defective vision right eye since 1 month. You can see there is a pigmented mass in the temporal quadrant. Clinically, it looks like choroidal melanoma, but 22 years is little odd. So we did a B scan, looks like a mushroom shaped, not very typical, but no acoustic hollowing. MRI T2 was iso-intense, that is iso-intense to the brain, suspicious for melanoma. So now look at the radiologist report. MRI report, they have reported as choroidal hemorrhage. This patient was very tech-savvy. PET CT also did not reveal any high-grade metabolic activity. But looking at the clinical diagnosis, it was choroidal melanoma. And in fact, we were also confused in the hospital. So we took a second opinion also. We did enucleation and turned out to be large melanoma with a poor prognosis. Coming to the vascular tumors, even though MRI is the imaging of choice, I always prefer to get a CT scan first. So this is presented with the proptosis with the choroidal folds. You can see the CT scan showing a well-defined mass with the intratumoral calcification suggestive of cavernous hemangioma. Varix, in anterior varix, you can get a CT scan to assess the extent. And if needed, you can augment with MRI later. Similarly, this is also a varix. You can see phleboliths. Coming to the pediatric orbit imaging, capillary hemangioma is a clinical diagnosis. If you are suspecting any meningoencephalocele, we can get an MRI to confirm. Otherwise, mostly it's a clinical diagnosis. This is a 8-month-old baby presented with a recurrent lymphedema with a small lesion in the upper eyelid. Just an ultrasound, CT scan not needed because you know there is no proptosis. CT scan or MRI will not add to their clinical armamentarium. So we did an ultrasound, it was parasitic cyst. Similarly, this is another young boy, again present with a recurrent lymphedema. We did CT scan first because showed bone erosions, and it turned out to be Langerhans cell histiocytosis. So most of the time CT scan will give the clue, then later we can monitor with MRI. Again, 9-year-old boy presented with a vague trauma. You can see the globe is displaced down. There is a mild upper lid fullness. The grandmother came with a child. We did a CT scan, reported as hematoma, but there was something very suspicious in this. Now look at where is the superior rectus muscle. So I could not delineate superior rectus from the mass. So we suspected rhabdomyosarcoma because that's the one which presents like this. And biopsy proved it as rhabdomyosarcoma. He did well with radiation. He's now completed his 12th standard also. So this is another case. So since the radiologist here looking at the shape only, he reported as hemangioma or bleed. So now look at this patient, again presented with a sudden onset proptosis. Globe is displaced down, there is a fullness. Now look at here what you can see superior rectus separately from the lesion, and this is bubble shaped. This is the thickened area of the periosteum. So this is the subperiosteal hematoma secondary to intraosseous hemangioma. Ptosis is always very tricky. Acquired ptosis always requires imaging. She just presented with my eyes getting smaller. Already seen by multiple doctors, neurologist. Neurologist did an MRI. You can see an ill-defined mass in the right orbit. But here the trick point was, even with this much mass, she is having enophthalmos, not proptosis. So that gave a twist. We did a biopsy, it was metastasis. So this is again a 41-year-old presented to us for ptosis correction. So what is very striking is there is a mild enophthalmos here. It was Horner's syndrome. He already had MRI when he presented to us. MRI was normal. Don't stop with MRI in Horner's. Go for CT chest. Showed thoracic mass. Role of USG, it is very important. Nowadays, parasitic infections are very common. So with a routine ultrasound, you can diagnose live worm. You can see the live worm in this, moving this parallel echogenic structures. Then role of imaging in watering. When this is patient presented to us watering, you can see there is a fullness in the right maxillary region, mild proptosis. Look at the CT scan. This was sinoorbital mass invading the orbit. He was treated and he did well. So to conclude, judicial use of imaging is very, very important. Always check imaging is correlating with the clinical diagnosis. Mostly CT scan remains first choice. MRI, USG based on the clinical scenarios. The most important thing is you always call up the radiologist and discuss. Most of the time, radiologists will call us also. Marine, I'm seeing like this. Is this okay or what is it? If in doubt, always discuss and get a second opinion. Even you can ask ChatGPT also. Thank you so much.
Thank you, madam. I request Dr. Rashmin Gandhi and Dr. Marian Pauli to join the dais for the panel discussion.
I think since we are in the way of lunch, I think we'll keep the discussion short and sweet so that. So just two questions to start with. In optic neuritis, Dr. Ashwini, do we do a regular screening of the spinal cord as well? Do you suggest that and in all cases or?
Yeah, that's a very good question. So we do spinal screening on the first visit only if following criteria you see. One is bilateral presentation, profound visual impairment, and bilateral disc edema. So if you have these, it might be safe to do spinal screening because you want to rule out NMO-related optic.
One more question to Dr. Rashmin Gandhi. In traumatic optic neuropathy, how do you order for that CT, HRCT?
Trauma and orbit, these are the two situations where you might have to ultimately do both CT and MRI. Your first investigation of choice in most instances would be CT orbit with thin cuts to make sure that you are able to visualize optic nerve and that you don't miss out on a smaller fracture at the orbital apex. But however, as Marian pointed out as well, you may have to follow it up with MRI to say if there is an optic nerve sheath hematoma which can be treated or any other injury in the brain.
So as you pointed out rightly that in IIH, in follow-up, the peripapillary retinal RNFL will be decreased, thinned out. You think that patient is improving, but always look for the macular GCC, whether it is normal, is there any loss for GCC. So both are there, that means the patient is deteriorating.
Thank you, Dr. Rashmin and Dr. Marian ma'am, for such an excellent talk. It almost felt like a handbook on imaging. So my question would be to Marian madam. What is your imaging of choice when you deal with a case of orbital cellulitis?
My first choice is always CT scan. If it is a bacterial, if I'm suspecting fungal, for example, white chemosis. Like usually in orbital cellulitis, we get patient will be very toxic and eyes very congested. But some instances, patient looks very ischemic. That means it is called white chemosis. In that case, I'll go for MRI first. But if I'm asking for an MRI, I will make sure patient is not waiting for the MRI. So that is very, very important. There are instances, patient was seen in the OP, advised CT MRI, then they went for the CT MRI, coming back with no PL vision. So since ours is a single specialty hospital, we have to send the patient out of the hospital for all this imaging. So I personally call up the radiology center, see this patient is coming, you make it fast. If you can't do it now, I'm not sending the patient now. That's it, thank you.
Similarly, one more question. Is there anything that you ask specifically when you are looking for, in cases of trauma, any specific cuts or anything of that sort?
Always, I never write CT orbit and go, no. So if it's a trauma, extent of the fracture, foreign bodies, sometimes patient will have vomiting, nausea. So we don't know whether it is related to the muscle entrapment or brain. So I'll get a primarily CT brain also, CT orbit and brain. Then these are the common things. If there is a defective vision, I always ask for, like suspecting traumatic optic neuropathy, to look for optic canal fracture or bone fragment imaging on the optic canal. I always write specifically 1, 2, 3, 4, 5, so that they have to answer all the 5 questions.
So basically you ask for thin cuts, 1.5 to 2 millimeter.
One more question in the traumatic.
If you write that 1, 2, 3, 4, 5 things, actually they will do the thin cuts.
Suppose if there is no fracture or any compressing pathology, but still the vision is not improving 48 hours. So is there any role for optic nerve decompression if it's not improving, if the vision is not improving? Or
You're talking about traumatic optic neuropathy?
traumatic optic nerve.
So up till now we used to say that there is no role of optic canal decompression, not now, canal decompression, and that there is no role of megadose steroids. Because if vision is not improving, there was one thought that like spinal cord injury improves with megadose steroids. So there was a thought that maybe we should give megadose steroids. That we know it harms. Till 5 years ago, we used to say that optic canal decompression has no role, but Kasturi Bhattacharjee has come up with few papers in IJO where she feels that navigation guided optic canal decompression seem to have a role. I don't know what is your...
It's VEP, actually VEP is, to some extent will help in guiding the management also. But even with the flat VEP, people have done decompressions and vision has improved.
Yes, you've seen. Yeah. Okay. Just one more question from my side. In an optic neuritis, especially in a pediatric population, does OCT ganglion cell follow-up have any role? And one more main problem is we don't have any normative data in that age. So what guidelines do we go about in that?
Yeah, so maybe you're talking more of IIH because optic neuritis would have a clinical follow-up. So yes, agree. Below 16, 17, we don't have normative data. We don't have anything to compare with. There are people who do go ahead and do OCT because they say that the first visit is their baseline and they keep comparing with it. I generally don't do it because in those patients you would rather either look at the optic disc photograph or the fundus and follow.
So if there are no more questions, we can conclude the session. Thank you, Dr. Reshman Gandhi and Dr. Marian Pauli for the excellent presentations. Thank you.
Thank you all. Our last speaker for this session is Dr. Prithvi Chandrakanth. He'll be speaking on DIY devices for everyday practice. There's a small announcement. I request the postgraduate teams who are taking part in the case presentation competitions to kindly take your lots from the counter on the left side of the stage to decide the order of your presentation.
Good afternoon, everybody. Thank you, Dr. Sreekanth sir, for having me here and the whole team to invite me here. I'll be talking on ophthalmology unplugged. രണ്ട് കേബിൾ ഉണ്ട്. ഇതാണ് കേബിള്, അതല്ല. Yeah. So I'll be talking about ophthalmology unplugged, DIY devices, that is do-it-yourself devices for everyday practice. So I have a small financial interest on 4 devices. Okay, so the first device I would be talking about is anti-segment photography with intraocular lenses. This is the ASPI device. Basically, when you really don't have a slit lamp with imaging module, you can actually do this. You have a chart paper. Better to take a black chart paper, which you can cut out 10 centimeter to 1.5 centimeter chart paper, which can be cut out. So what will happen is we can use this as a imaging device. So fold this into half. So once you've done that, you can attach a double-sided tape. So mark the area where you want to keep the intraocular lens. So we'll be putting the intraocular lens at this particular area. So mark this in the initial beginning. And then you can put the double-sided tape. So this is the double-sided tape that can be attached to this. So once that is done, you can take a paper puncher and cut that area where you are marked. So what will happen is you will be making a small hole for the intraocular lens to be placed. So at this stage, what you can do is you can remove the double-sided tape. So once you have done that, you can take an intraocular lens. So better to take a 15 or a 20 diopter IOL. So that will be ideal for an anti-segment imaging device. So keep it with the forceps and put it in. So this will be sandwiched within the chart paper and attach it to your primary camera. So once you have done that, as you can see, you can just align it to the camera, and your phone, you can put it on the video mode with the flash on. So this makes your iPhone or any other phone, smartphone imaging possible. So once you have done that, you can take it without a slit lamp. You can take an anti-segment image very clearly. So you take a video and take a screenshot later on whichever frame you want. So this will help you take anti-segment images without a slit lamp and using an intraocular lens. So these are a few images taken. Like this is the magnified image that can be taken with the optical zoom of your smartphone. And yeah, there are corneal nerves. You can see keratoplasty sutures, blue dot cataract with the PAC, occlusio pupillae, pupillary membrane, and hyperpyon. So all these images can be taken without a slit lamp. So it is very easy and can be used by with any phone. The only thing is you have to place it on the primary camera, not the secondary or third camera. So you can even take videos, and over here you can see how beautifully you can see the phacodonesis happening. So these images can also be used for publications also. So this is the anti-segment imaging with the intraocular lens, ASPI. So what we have done is we have also used the 3D printing technology to make a small clip of it. So this clip can also be just attached to the phone, and it can be used as a anti-segment imaging device. So when you go for outreach programs like community, ophthalmology, all those places, you can actually use this. You can see how clear and how good quality magnified images can be taken from this. So this is ASPI. The next one is slit scope. Basically, when I show this, everybody asks, "What's it? How do you take a slit out of this?" Because there is no slit; it's only diffuse light. So that's why we came up with the idea of slit scope. So the main thing was, what if we could, if we have a instrument which can replicate exactly the slit lamp? So that's where we came with the new idea, the slit scope. So already with the magnification and the imaging device is already done. So then we had the slit illumination needed to be done. So we opened up the slit lamp and we actually saw the components of the slit lamp. So that had an illumination part, a small slit opaque substance, and a magnifying lens like a IOL. So again we took an IOL and put it on a marker pen and then attached it to the slit to the torch. So then we actually started making a slit. So this is the first ever slit that we made using an intraocular lens. And then we reduced the slit size, so we could actually get better slit illumination like a slit lamp. And what we did is we thought of 3D printing this also. So we 3D printed these adapters, which comes in different sizes, shapes, in circular, square shape, every kind of shape that we made a 3D printed thing, which cost just 350 rupees. And these are all the images that were taken with the slit scope and the ASP together without a slit lamp. So you can actually make out how it is actually as good as a slit lamp, but without a slit lamp. So, so one hand you use the slit scope and the other hand you use the ASP, and together you can actually take images just like a slit lamp. So these are all the images: corneal scar with PCIL, brown cataract, mature cataract. You can see how clearly it takes the images. Actually, nobody will doubt that it was not taken in the slit lamp. Then we go to gonio. So ASP gonio can also be done, that is using the same ASP device. The only thing is you have to change the intraocular lens power to around 6, 8 or 10. So that will help you take images using the gonio lens. So just pay the gonio lens and you can ready for taking angle images. We don't really require a slit lamp. So this is all the images taken with just a gonio lens and an ASP of 6, 8 and 10 diopters. Going to the next thing, Scooby-Doo. It's not our cartoon Scooby-Doo, it's a smartphone cobalt blue photography. So over here what we do is, with the ASP device, we just add a separate hole for a acrylic blue filter. So once you do that, it will align with the smartphone camera, and the light goes to the blue filter to give you a cobalt blue color. And this is a Seedles positive that was taken with the smartphone alone without a slit lamp. The next one was the IOL scope. So basically what we were thinking is, what if with one intraocular lens we could do that? So we thought, let's put 4 intraocular lenses. So we put 30 diopters lenses, IOLs, one upon the other. There are 4 of them which we placed, and it gave us a power of around 120 diopters. So we started sticking it with the Fevicol or any other adhesive glue. So you have to keep one upon the other. So around 4 of them were stacked upon another, and it gave us a collective power of 120 diopters. So once that was done, so we, all these IOLs are all PMMA rigid IOLs. It's not the acrylic IOLs. So once this was done, we attached the same way to the smartphone. So put it on the primary camera, and if you have any kind of microbiology sample specimen, just hold it across a illumination source, like a torch over here. Just keep the sample on top, and with the IOL scope, you can start taking images of any fungal microbiology, any other pathological slide, and you can start taking images of like you can see over here, this is a rhizopus stained. Over here you can see a KOH mount of a fungal hyphae. So these are all the images that we were taken from the smartphone with 120 diopter, 30 diopter lenses, 4 of them together. So it is very helpful in our daily practice when a corneal ulcer comes into our OPD. I can show you the video next over here. So over here what we are doing is, so during the COVID time, we actually did one more challenging case where ENT surgeon got us a sample, live sample of the patient, and we started imaging for fungal hyphae right there at the OT itself to help him demarcate the area of tissue which is not involved with the fungal hyphae. So these were all this is the hyphae which was seen over there. And this was done right there at the surgeon's OT itself. So this was the one taken from the IOL scope, and this was then proven with the actual compound microscope. So we thought, why not, if we could do that, why cannot we use this in our OPD setup? So during our OPD, we see a lot of fungal hyphae and a lot of corneal ulcer cases. So we thought, anyway, we are doing scraping, so why should not we use IOL scope on the slit lamp itself? So we thought of connecting it to slit lamp. So this is the arrangement that we did. You can see the illumination part of the slit lamp was removed, and the adapter, phone adapter, was attached to it. So you can tight it pretty good, and it can be done in any of the other slit lamps also. It's reproducible. So once you've done that, you can put this smartphone with the IOL scope, attach it to the slit lamp in this. So once you've done that, then your slit lamp acts as a very stable instrument for the microscope. So this is the whole setup. So you have a illumination source below also, and keep the slide on top. So this is the illumination that we created, and then using the IOL scope, you can actually start taking images in the OPD itself. It's like a point of care diagnostic right there at the OPD. We have a video also which shows how we used to take corneal ulcer scraping and then put it on the slide and then check for fungal hyphae right at the slit lamp itself. So that becomes very easy for corneal specialists to actually diagnose if there is hyphae or not. So next we'll go, so we can also use it for diagnosing all the parasites also. So that becomes very easy for us in the OPD. And then we come to the gimbal scope. So basically this is when we were in PGs and we don't really understand what our mentors used to say about the shadows of retinoscopy. So we thought, why not put the smartphone to the retinoscope itself. So we attached with the adapters the smartphone into the small hole of the retinoscopy device, and then we started taking images of the shadow. So this was, you can see how clearly the width movement reflex can be seen over here, and this was recorded directly from the retinoscope and the smartphone with this arrangement. So this is against the movement, and it becomes very easy to actually teach our mentees how to do the retinoscopy. You can see scissor reflex over here, how clearly it could document that. Then we come to the red cam. So basically when you don't have a fundus camera, you can actually use your smartphone. So all that you require is a hand sanitizer bottle. So you can just cut out this kind of an arrangement with a rectangular flap. So these flaps will hold the red cam the 20 diopter condensing lens. And then you use the adapter and start taking images. So these are all the images that were taken. These are all the traumatic fundus images that were taken with the red cam. So it is very simple. You just require a hand sanitizer bottle. So this is Retigo. So this was another modification to the trastuzerator cam. So I came across this keychain which actually opens up and you can use it to drink water and tea, anything, and it wouldn't spill also. It was tightly sealed. So so we thought because our red cam, the hand sanitizer bottle is very big, so why not make it small? So we thought we took the same inspiration from that particular keychain and 3D printed it in such a manner that it opened up and you can just add the 20 diopter lens. So this is a 3D printed device and attach it and your red cam is ready. So this is this makes it very compact and you can actually start using this to take fundus images. So when you are not having a fundus camera, that becomes very easy for us with using these instruments to take, and it's quite good quality also. You can actually show it to the patient, it becomes very easy. So you can even take videos. You can see a vitreous cyst over here. It was taken from the red cam itself. And you can use it also for the ROP screening. So it becomes very easy for us to even document ROP patients, even babies. You can use the indenter also to actually take these images. So that was Retigo, and then we come to pupil made. So basically, one of my PGs had come asking that neurophthal, we don't have imaging techniques to check the pupil. So we thought, okay, let's do something. So we came up with a small VR headset. So this is the dimensions of the VR headset along with the infrared cameras and the light. And this is a white LED to give the torch-like simulation. And this is the board which was then connected to the ESP32 camera. So we had an electrical engineer set up the whole thing up for this one. This was the particular diagram. And then we could actually start taking and recording images in our smartphone. It was wirelessly connected to the smartphone. And we could actually take images and video. Like over here, you can see. This is my pupil. I think it's not working. Yeah, you can see over here when the pupil constriction during the light reflex, and this was done. This was basically the first time we tried that, and then we made it even also wireless. So actually, without a wire, you can connect it through Wi-Fi to your smartphone, and you can actually start recording the pupil reactions for the patients. Then a small thing of Magnifix. So basically, we thought, why not use magnets for fixation targets as fixation targets in our slit lamp. So because after the COVID, we started having the acrylic boards on our slit lamp. So one major issue was patient don't fixate when you ask them to see straight and here and there. So we thought, why not use a fixation target? So we held a small iron ring-like thing. And on top of that, we kept the fixation target. And across the acrylic board, we had a magnet which could help us fixate. So this was a fixation target. And with the magnet, we could move it. So patient would see with the other eye this fixation. And we could check for the fundus or any. So it actually helped in our pediatric cases because we started using fridge magnets, which comes for around 100 piece. You just have to pay around 100 rupees in Amazon. And it becomes very easy for us to actually examine pediatric cases. So this was a video showing the same. So this was on the slit lamp. So another PDF fix that we made was basically using this projector. This is a small torch projector which has a lot of small disc through which any of these animals and car and all those things come in projects. So what we did is we attached this on the fixation target of the slit lamp, and then when you on it, so this is a small disc which has all the images, and the projector will project whatever is there in this disc. So once you project it, you can see it is projected up. So when we have to check for the retina, we make the kid lie down on this thing, and they actually see the images. So they're quite cooperative when we show them these kind of small images. So it becomes very easy for us to actually check their eye. So there are a lot of other images which can be put. So you can make the examination more easier and reduce the waiting time also. So our optometrists have started using this for even extraocular movements. So patients actually, the children are more cooperative with these kind of torch. Then we come up with the aspirator. So basically we know that there is a huge aspiration device when we do orbit surgeries. So we created a small aspiration device using the fish aquarium motor that we get. So we use that, and so this is a small setup in which we did the whole thing. So this is a basic BSS saline bottle, to which we made it a vacuum bottle, in which with the fish motor, we actually started using it as an aspiration device when the other big aspiration device doesn't work. So this was another small DIY technique. Then we come with diagram. This is another acrylic and 3D printed stencil-like thing. So this is basically for PGs and fellows when they have to write it in their logbook or their case sheet. They run around for something like, I want a circle to draw the retina thing. So we actually made a whole stencil for cornea, for retina, for orbit, for pediatric squint, for glaucoma, for ROP and pupil. So we made almost all stencils for different these things, because they don't have to run around for the stencils, and it can be attached to your keychain also. So that is why all the rounds over here, it can be attached to your keychain also. Then we come with tactile. So tactile basically addresses the need of all our patients who are blind, basically our retina patients. They have 3-4 eye drops. They don't know which drop to put what time. They mix up everything. So we thought, why not use the tactile sensation, and let's make something which would help them understand which eye drops has to be put what time, how many times. So we came up with 3 different solutions. So one was the basic Indian bindis that we use. So this was the first prototype where we used the Indian bindis to put how many times. So if you have 3 times, you put it 3 times, so it becomes easier. Then we have the label embosser that we get in Amazon for around 1,000 rupees. You just have to press it and you'll get an embossed mark. So once you do that, you get the embossed mark. You just have to take it. It's already a sticker thing. So you just have to stick it on top of the eye drops. So this makes it very simple for the patient to just touch and feel and understand how many times they have to put the eye drops. They don't have any confusion. And then we have 3D printed also. This cost at least 1 per piece. So we have different symbols also which can be added to the eye drops to show this one is cornea or this one is for glaucoma drops. But basically the tactile embosser works fine. So then we have another innovation, that is the Lumi indent. As we know, retinal surgery is, you need 3 hands. You need the endoilluminator, the surgeon is having the cutter, and the assistant will help you indent during the surgery. So what happens is there are a lot of miscommunication, slippage, and a lot of retinal holes, accidental retinal holes happening. So we thought, well, how to reduce these kind of things and keep it in the control. So we had the depressor and the endoilluminator combined. So here what we did is we took a hypodermic needle cap and put the endoilluminator inside that. I can show you a video where the endoilluminator was covered with the hypodermic needle cap. And now your illuminated depressor is ready. So this is all that you have to do. So when you do this, the surgeon himself can, from externally to transclear illumination, will help him navigate through indentation with endoillumination. And the other hand can be used for doing the vitrectomy, or even use it for endolaser and other things. And it becomes very easier for, it actually reduces the accidental retinotomies and all those things. So these are all the images of endolaser being done with the other hand. So that was Lumi indent. And still not over. Then we have Glowport. And this is the Glowport. Actually, what we did was, retinal surgeons actually have a very tough time finding out where the ports are, because the room is all dark. So we thought, why not do something which will help the retina surgeon to check where the ports are. So we came up with a 3D printed glowing device. So this was 3D printed. This is the two small glow device that can be inserted on top of the small ports that we have. So once that is done, you can use it during surgery, and I'll just forward it. So you can put it during surgeries. I know it's a little big, but we are making it smaller. And once you've done that, you can just shine the endoilluminator on top of that. It hardly takes 2 to 3 seconds. And once you've done that, you can actually do the surgery in dark, and your ports will be glowing. So your ports will glow. As you can see over here, we are charging it. Because through the microscope we have a green filter, you will not be able to see the ports. But when the surgeon looks out, it becomes very easy because these ports will be glowing. So these are all the glow in the dark ports that will help the retinal surgeon actually to see where his ports are to go inside. So this actually reduces a lot of time for the surgeon. This is a glow port seen without the green filter attached on the side scope. So you can see how clearly it becomes easy for the retina surgeon to actually use this during the surgeries. Then we have the Retilite. This is the last one. So this is basically, like I told you, we need endoilluminators, we need illumination during the surgeries. So what happens, and it actually happened that we lost our endoilluminator light. So when that happens, we cannot go ahead with the surgery, and what are we going to ask the patient or tell the patient, like, sorry, we couldn't do the surgery because we don't have so thought of making a novel, frugal illumination device. So first thing what I did was I tried using the endoilluminator on the smartphone torchlight, flashlight, but the intensity was not that great. So then we made 2 adapters which could be matched with any other company and any LED or torchlight. And this was the second prototype where you can see this is the 2 adapters. One adapter is for the illumination, any LED illumination device, and the other one is for the endoilluminator. So once you on it, you will be able to see light in the endoilluminator. But the problem was this small LED light was not very intense, so it was not very easy to do the surgery. So we came up with the next prototype. We increased the illumination to that of the slit lamp. So we got a LED of the slit lamp. We connected to the power bank, so it can also run on a power bank. You just require a USB port. Once you put it, it is easy for us, and it can also be used as an orbital focus light also. So can be used for endoilluminator as a source for the endoilluminator. You can use it as a spotlight for orbit surgeries, and also for anti-segment surgeons who don't have a vitrectomy machine. They can have this, and they can use this for during cornea to check the DSEC and DMEC flaps, and also for retroillumination during cataract surgery when the cornea is very opaque. So they can use this Retilite also. So these are all the other uses of this. I would like to acknowledge all the other co-authors over here. Thank you.
Thank you so much, Prithvi. Actually, we should be clapping for each and every innovation because such a lot of hard work has gone into it, and it has opened a whole new world of ophthalmic investigations. Thank you for the great presentation. Next, I'd like to call upon Dr. Padmaja Krishnan Madam to kindly present mementos to the speakers of the last session.
Accurate and precise knowledge with a deeper understanding. So that's what we expect knowledge should be all about. So deeper understanding to help our patients recover from their illnesses. So the objective of this competition is to encourage postgraduate students to present interesting cases in ophthalmology to enhance their diagnostic and clinical skills, critical thinking, and effective communication skills. So we have a few judgment criteria which the PG students should be aware of. So the marks are being given according to the clear presentation, the time adherence. So you have a allotted time of 5 minutes for the case presentation. So try to adhere to that. The knowledge of the case, communication skills, and of course the discussion where you answer the questions. So hope we have a very interesting session today. So all are welcome.
I think they get 5 minutes for the presentation.
Yeah. So also I'll introduce our chief moderator, Dr. Padma Prabhu, who is the additional professor at Kozhikode Medical College. She's a academic, we all know her academic brilliance. She's a gold medalist and also a very good teacher. And she's got 20 years of experience in postgrad teaching. She's also the convener of the NMC Regional Center for Medical Education Technology. So welcome, Dr. Padma. And we all know she's the apt person to do this. So we're very honored to have you here.
Okay. So anchorage by Dr. Padma. Fine.
So along with Dr. Padma, we have Dr. Aisha, who is a corneal consultant at Dr. Sreekanth Eye Care, who will help us, and also myself. So it's my proud privilege to call upon our esteemed panel of judges today. So first, Dr. Srini Adaklon, the dynamic personality, not just in KSOS arena, but also national AOS arena. He's the Chief Surgeon and Medical Director of Malhari Eye Care, Talasheri, and Chief Surgeon at MAMS Trust Eye Hospital, Kanyangad. He's actively involved in professional leadership and a lot of academic contributions to his name. So he was organizing, he organized the major ophthalmology conferences in Drishti 2009 and 2018. Very warm welcome to you, sir. Also, it's my proud privilege and what do you say? Honor to welcome my dear teacher and my mentor, Dr. Padmaja Krishnan, who is the Emeritus Professor and HOD of MES Medical College and Hospital. She was formerly the HOD of Ophthalmology at Medical College, Calicut, and formerly Chairperson of Institutional Ethics Committee at Baby Memorial Hospital, Kozhikode, and Member Scientific Committee, Ethics Committee, Complex Eye Hospital. She is an experienced postgraduate teacher and examiner, and definitely the apt person to be the judge in today's program. Welcome, ma'am. It's an honor to welcome Dr. Radha Devi, ma'am, retired as professor and HOD from Medical College, Thrissur. She's worked in, she also as a professor and HOD in Amala Institute, where she started the PG course, and she's worked in PK Das Medical College 2018. She has publications in KJO and IJO and was a coordinator for International Council of Ophthalmology. She is also an experienced postgraduate teacher, an examiner, and a thesis guide, and definitely an apt person to be a judge today. Welcome, ma'am. So I will hand over the mic to our chief moderator, Dr. Padma.
Okay, thank you, Dahlia. So team A, are you ready? So we have given them false codes so that the institution is marked. The team A ready? Please come over. We have put you as a team so that you feel at ease and support each other. So be calm and cool. It's quite appreciative that you are able to do a platform presentation and take it as an experience, please. And all in the audience, please take your book and be a critic. Anything you want to add, you add. If you have a question and an answer, you put that answer. If you have a question, you just add on that question. We'll collect it at the end.
Also, I would like to announce we have exciting prizes today. For the first prize is a cash prize of rupees 20,000 and a second prize of rupees 10,000. So all gear up.
Yes.
So the first team, Team A, is Dr. Merin Baby and Dr. Rashmina. Please take your seats. After. Yeah, one person can sit, another person can.
After introduction?
Just start the case. I think you can go ahead with the case. Introduction. Straight with the case. Yes, straight with the case. And remember, I am with you. Okay, judges, I am with them. Yeah.
Good evening. Today we are presenting a case of 53-year-old female who is a known case of thyroid disorder and hypertension, referred from surgery department. She complains of prominence of both eyes, more than 6 months duration, and it was insidious in onset and progressive in nature. It was dull aching pain, more of retrobulbar discomfort, and it was non-radiating. There was swelling around eyes which was progressive and get worsened in the morning. She also has mild discomfort, dryness, and foreign body sensation of eyes. No history of postural or diurnal variation of eye prominence, increase in prominence of eyes while coughing or straining, redness or discharge, double vision or defective color perception, fever, nausea, vomiting or headache, nasal block or epistaxis, no history of trauma. She was diagnosed with hyperthyroidism in 2021 and had undergone thyroidectomy in 2025 January. Currently, she was on tab thyronam 100 microgram. For hypertension, she was taking tab amlodipine 5 mg. No significant personal history or family history. General examination. A well-healed transverse scar was present at the lower anterior neck, just above the suprasternal notch. Vitals are within normal limit. Systemic examination including ear, nose and throat within normal limit. Ocular examination, head posture normal, no facial asymmetry noted, Hirschberg test shows visual axis parallel and extraocular muscle movement full range. Of right eye, the best corrected visual acuity was 6.6 and N6, color vision normal, eyelid fullness was present, upper lid retraction with 1 mm scleral show present, lid lag on downgaze present and inferior scleral show of 2 mm present. Conjunctiva shows diffuse conjunctival congestion with sparing of the rectal muscle insertions, and the cornea is clear and rest of the anterior segment was within normal limit. Pupil is 3 mm brisk and no RAPD, no relative afferent pupillary defect noted. Dilated fundus examination showed disc and vessel normal, macula normal and no evidence of choroidal folds. Of left eye, best corrected visual acuity was 6.6 and N6, color vision normal, lid and adnexa, eyelid fullness present, upper lid retraction with 2 mm scleral show noted, lid lag on downgaze present and inferior scleral show of 2 mm present. There was diffuse conjunctival congestion but the cornea was clear and rest of the anterior segment was within normal limit. Pupil is 3 mm brisk and no RAP relative afferent pupillary defect noted. Dilated fundus examination shows disc and vessel normal, macula normal with no evidence of choroidal folds. Evaluation of proptosis. On inspection, proptosis of both eye was noted. Eyebrows are normal with no evidence of madarosis. Both eyes showed no signs of inflammation, pigmentation, ecchymosis or dilated vessels over the eyelids. There was periorbital fullness present and Dalrymple sign was present, von Graeff's sign present, Vigorok sign present, Coker's sign present and Stelbach sign present. Both eyes showed no visible mass in the orbit, no variation of proptosis with postero-Valsalva maneuver, no visible pulsation or engorged vessels, good Bell's phenomenon and no ptosis or nystagmus noted. On palpation, resistance to retropulsion was noted and it was a non-compressible and non-reducible proptosis. There was no local rise of temperature or tenderness, orbital margins are intact and no palpable mass felt, no thrills or pulsations or no change in size of proptosis with jugular vein compression or carotid artery compression, no palpable pre-auricular and submandibular lymph nodes noted, no infraorbital or supraorbital anesthesia and no paranasal sinus tenderness noted. Auscultation, no bruit heard, and on measuring the proptosis, there was on axial measurement, the right eye showed 4 mm more than that of the normal and left eye showed 5 mm more than normal and rest of the measurements were within normal limit. IOP in primary gaze of right eye was 19 and left eye it was 18 and IOP, the differential tonometry is within normal limit. Other tests, the tear breakup time of right eye was 7 seconds and left eye it was 6 seconds and the central field testing by germ screen testing was within normal limit. Diagnosis, moderate axial proptosis, probably due to thyroid disorder with a clinical activity score of 2/7 with no evidence of dysthyroid optic neuropathy. Thyroid function test recent shows the TSH6 and this is a reference CT since our patient can't afford for a CT. This shows tendon sparing muscle belly enlargement and there was no apical crowding based on the Barrett's index. The management given was supportive measurement with cool compressor, compressors, head and elevation, lubrication for exposure and increased supplementation of green leafy vegetables and tuna for intake of selenium intake, and lid taping at night. Systemic drugs advice was to continue as per the surgeon's advice. Thank you.
Bilateral proptosis you have mentioned. How can you say bilateral proptosis on inspection? You can say prominent eyes, both eyes.
Okay.
It will show both.
Since there was scleral show in both eyes, in usually
When will that occur? What is that a manifestation of?
the upper lid retraction is probably due to
Actually, that's the answer partly to Radha's question. When will you have upper and lower scleral show? Upper lid, you said retraction. Is the lower lid retracted?
Yes, it was retracted.
What happens when you have proptosis? I'm sorry, Padma.
Yes, ma'am.
I tend to teach and ask, and when
Yes,
I'm
ma'am.
examiner, it's terrible.
Yes, ma'am.
So I think there should be somebody to put a thing
No
on
worries,
me.
ma'am. You give the explanation also, ma'am.
Okay, fine. No. I would like the others to ask as well. So actually, when you have proptosis, a larger diameter of the eyeball is out, which is why both the lids are pushed back. So the proptosis, just a prominent eye, you have a large diameter coming in. That's when you will have both upper and lower. Of course, if you have a large eye, larger than the palpebral aperture, the same could occur. The other thing, you looked for choroidal folds. Can you tell me why and what would the presence of choroidal folds tell you?
choroidal.
Yeah.
The presence of choroidal folds says that whether the vision is affected or not.
Not unless it's over the macula, right? Okay, maybe. But if in the context of proptosis, if I see choroidal folds, what will I conclude? In fact, my question is in thyroid orbitopathy, do you expect choroidal folds?
Yes. Yes.
Why is the choroid being thrown into folds? What has happened there? Padma, I
So
think it's
is
fair
there
to tell
something-
them.
Yes, ma'am. If there is something pushing, you get folds. In thyroid, you hardly expect pushing. It's a uniform infiltration of this thing. No? So choroidal folds, we do not expect in a patient with thyroid. So for completion, probably they would have added.
So
There is
no,
presence.
when you have a mass in the orbit, pressing and flattening the sclera, obviously what was like this has become flatter, and therefore the excess choroid is thrown into folds. I agree, you must have read in the book, proptosis look for choroidal folds, but choroidal folds in the context, or of course, if you have scleritis and you have fluid there, that again could throw the choroid into folds. You said something about compressible and reducible. Can you tell me what you did and what was the relevance of looking for? Was it the swelling that was compressible and reducible, or was it the proptosis that is compressible and reducible?
Whether the proptosis is compressible or reducible.
So how did you do it and what does it indicate?
Ask the patient to look down, and over the upper eyelid, we have to press with our index and middle finger. And if the swelling is reducible, if there is a resistance, which means it is a non-reducible mass.
No, so when you said, so when it is compressible and when it is reducible, what would you find? How would you look for compressibility and reducibility? And if it was compressible or reducible, what would be your finding?
Reducible means it won't come back, it will only come back after pressure is applied or if,
No, so the first answer is number one, it would decrease, right? You put pressure and it would decrease the proptosis. And now tell me, when will you say it was compressible and when will you say it was reducible?
it comes back itself when
If it comes back immediately,
it's compressible.
What does it indicate? What is the cause? What is it that you can press and immediately it comes down?
Orbital varices are usually
Okay,
compressible.
fine. So if it's a vascular thing, you're emptying the blood and that's why. What about reducible? What happens there?
It stays after
Yes, only when you
pressure or inner pressure, an orbital pressure increases.
spontaneously it does not come out.
Spontaneously does.
Yes, there's something which is precipitating proptosis. So what could be it?
You have reduced hernias,
Correct.
right? Can you similarly reduce something in the
Yes.
orbit? Some mass in the orbit, which it's possible for you to push back into something and then...
Yes, there is space around the orbit.
If there is a solid mass, we cannot reduce it. But if it
Now
was
can you compress it, right? So both if it's compressible or reducible, you put constant pressure and the proptosis decreases. My question is, if it's compressible, you told me correctly, it will increase immediately. The proptosis will come back. So the opposite must be that it will come back slowly.
Anything involving the sinus?
Madam, let's ask audience. Audience, which is the reducible mass? Meningocele.
Actually, no, it's neurofibromatosis with
Correct.
what happens to the sphenoid.
Dysplasia, sphenoidal dysplasia.
Okay, fine, fair enough, I suppose. I'll give it to you. Answer parayanda. Padma, what should we do? I mean, it's a learning session.
Yes, madam, it's a learning aid. You can tell the answers.
No, okay, fine. Before I
Does it
hog
mean that you have
everything,
done anything?
I have one more last thing which I think is useful for all postgraduates. You looked for IOP straight ahead and you looked for IOP in upgaze. What was the tonometer you used?
We used a non-contact tonometer. And
So you once you put it on the cornea and the second time onto the sclera.
for upgaze, we used Shiot's.
Okay, fine. Now, if you're doing a Shiot's and I'm able to move my eye up, how did you chase my cornea? And finally, what is the relevance of doing this? Why are you doing it?
It's a differential tonometry. There will be a rise in intraocular pressure.
Due to?
Suspecting a rise of intraocular pressure
Due to?
On upgaze, if there is rise, we are suspecting inferior rectus restriction, muscle restriction.
So I'm arguing with you that the first thing you need is you shouldn't be able to move the eye up, and you're trying to rule out a restriction of by the inferior rectus as against paralysis of the superior rectus. So unless there is inability to move the eye, doing this tonometry has no meaning. Like you've proved, I don't know how you did it, but you got lower values when you did it, right? There was no movement restriction. I will do it only when the eye can't move. The aim is to differentiate a restrictive from a paralytic. Did you understand? Restriction of I can't look up because my superior rectus is paralyzed or my inferior rectus is fibrotic. I think I'll retire now.
So how did you measure the proptosis?
By Lutz exophthalmometer.
So what are the other ways in which you can?
So we have Hertel's exophthalmometer and Nagel's.
So if you don't have any of these, how will you do it?
Ruler method using scale.
Or we can, for evaluation for whether there is prominence or not, we can check by Navsiker's method.
Okay, and see what would be the what are the features that you find on ultrasonography in?
There will be increased muscle mass with sparing of the tendon, and also there will be orbital fat will be enlarged.
Will we be asking for the management? Or
It's ultrasound, sir, or CT?
So, when will you actually go for some surgical intervention in case of thyroid ophthalmopathy?
Surgical interventions are usually done once the patient is stable. It is never done in an active stage unless there is a dysthyroid optic neuropathy. So in surgery, we go for lateral orbital decompression initially, and it has a reduction of around 0 to 4 millimeter. And if the orbital fat is reduced, it is around 2 millimeter. And if it is not enough, we can go for a two-wall procedure, where we can go for lateral and medial wall decompression. And it gives around a compression of 3 to 7 millimeter of proptosis. And if it is not sufficient, means we can go for 3-wall and 4-wall respectively. But if the orbital floor is decompressed, it has a more chance of diplopia.
What did you do for this patient?
Since we have advised, since our patient has got clinical activity score of less than 2, then we ask, and she is having mild disease, we have given general measures. But since she has a moderate proptosis, we asked whether she is willing for any surgeries. But since our patient was not able to afford these things, she is not willing for.
Is there any temporary surgery that can be done? Will you do it?
Ma'am, the patient had moderate proptosis, but the cornea was clear. There was no signs of exposure. If it was there, we could have done tarsography to prevent exposure.
Any drops that can be given?
Guanethidine, sodium can be given. Lubricants can be given other than it, but the guanethidine has not much.
What was the measurement of proptosis?
In right eye it was 24 millimeter, and left eye it was 25 millimeter.
Which instrument did you use?
Lutz X of.
Is there any disadvantage of you using that instrument?
We can only, like in hurdles, we could simultaneously measure both the eyes, but for ludes, only one eye can be measured at a time.
Which is the best one supposed to be?
Hurdles is best. Even for follow-up, hurdles is best.
Okay, thank.
So we don't have the instruments.
Thank you, judges. That was very well done. Thank you, team. So a few points in your presentations: add skull spine within normal limits, ENT examination normal, neurocutaneous markers, corneal sensation specifically. Come back, team 2, take charge. Lid closure has to be mentioned. The signs you have described, and then tell this is suggestive of Dalrymple sign or Cocker sign. And can there be ptosis? Ptosis measurement, that is lid retraction you said, but how much, how far? Dry eye, grading of dry eye. And in your investigation antibodies, role of steroids, the acute thyroid ophthalmopathy, these are the things you should read. Yes. So team, be ready. Do we have a question for the audience? No.
So
Yes.
in team B, we have Dr. Aishwarya Pillai and Dr. Meghna.
Good evening, everyone. So today I am presenting a case of 70-year-old female patient who came with complaints of pain, redness, watering, photophobia, and defective vision in left eye since the last 1 year. She presented with gradual progressive diminution in vision since 1 year post left eye cataract surgery, which was done 2 years back. It was associated with multiple episodes of pain, redness, watering, and photophobia in left eye, more pronounced on waking up. There was no history of vomiting, nausea, headache, flashes, floaters, colored halos, or ocular or head trauma or joint pains. She consulted a local hospital during the episodes and was given topical medications, and contact lens was placed in left eye 2 weeks back. She gives history of right eye cataract surgery 5 years back and left eye cataract surgery 2 years back. Immediate post-operative period was uneventful and she had good vision for 1 year. The left eye vision started deteriorating after 1 year. She is a known diabetic patient on oral hypoglycemic drugs for the last 10 years, known hypertensive and dyslipidemic on treatment. She has a history of coronary artery disease on antiplatelets and gives a history of hypertensive urgency 2 months back. There is no history of COPD or renal insufficiency. General and systemic examinations were within normal limit. On ocular examination, head posture was normal, facial symmetry was normal, ocular alignment was orthophoric for near, and extraocular movements were full in all gazes of direction. Functional test, right eye functional test showed uncorrected visual acuity of 6/18 with improvement to 6/6 parts on, with pinhole, and her near vision was N6. Intraocular pressure measured with Goldmann sublination tonometry was 14 millimeters of mercury, and field was full. Gonioscopy showed open angles. Left eye had a vision of uncorrected vision of counting finger close to face with no improvement on pinhole or glasses, and her near vision was N36. The intraocular pressure measured with Goldmann applanation tonometry was 22 millimeters of mercury, and field and gonioscopy could not be assessed. On anterior segment examination, right eye anterior segment examination was within normal limit. In left eye, the lid and adnexa were normal with negative Roplast test. Conjunctiva showed diffuse conjunctival congestion, circumcorneal congestion, and a superior scleral scar. The cornea showed diffuse nebulomacular haze with localized macular haze of size 5 to 6 millimeter, diffuse microcystic edema and stromal edema, few scattered ruptured bullae, few subepithelial scars, 5 to 7 linear folds suggestive of Descemet's membrane fold in the central cornea, no neovascularization or KPs, BCL was in situ, and corneal sensations were intact in all quadrants. Anterior chamber depth was Van Herrick grade 2 to 3. Cells and flare could not be appreciated due to hazy cornea. ACIOL was seen in situ, which was displaced slightly inferiorly and nasally. The iris was normal in color with some iris atrophic patches, and pattern could not be appreciated. A surgical PI was present at 1 o'clock. The patency could not be assessed due to corneal edema. The pupil was peaked superiorly with superior optic touching the pupillary margin, and the pupil was 4 to 5 millimeter in size, and sluggish direct and consensual reflex was elicited. The lens, the ACIOL was seen in situ. This is a picture of the case and the corneal diagram, which shows stromal and epithelial edema with microcystic edema and DM folds with some ruptured bullae, and circumcorneal and conjunctival congestion with BCL in situ and ACL present. On fundus examination, right eye parameters were within normal limit except a generalized arteriolar attenuation with an AV ratio of 1:3. On left eye fundus examination, there was dull red glow on distance direct ophthalmoscopy. The media was hazy, and other details could not be made out because of the hazy cornea. Provisional diagnosis, right eye pseudophakia with PCIOL with grade 1 hypertensive retinopathy. Left eye pseudophakia with ACIOL with endothelial decompensation and bullous keratopathy. Thank you.
Why do you think? So I'll just go straight ahead, not with the presentation. So why do you feel that it has gone? Because it was clear for some time, about a year. Why did the cornea decompensate?
Initially, the corneal cell count might be above the critical limit. When it dropped below the critical limit due to the presence of anterior chamber IOL, there might be corneal decompensation and leading to corneal edema.
See, why should an anterior chamber IOL cause corneal decompensation?
Sir, in this patient, there has been a subluxation, a slight dislocation of IOL. So probably it could have caused a endothelial touch.
So is it more anteriorly placed, or is there a mobility for the? See, like, so how do you decide? I mean, there are different sizes of ACIOLs available. How do you decide on what sized ACIOL is to be used?
Usually, the horizontal visible iris diameter plus
what?
HVID, the wide to wide diameter plus 1 millimeter is taken for the ACIOL.
Okay, so what happens if it is larger than 1 millimeter, more than, so what happens?
The haptics might impress on the angles and cause secondary glaucoma, and if it is smaller than the size, then the lens may be excessively mobile.
Okay, you couldn't actually measure the intraocular pressure in this particular case. Why?
We did measure the intraocular pressure.
When you said it's not recordable?
Intraocular pressure.
Left eye is okay. Okay. If in case you can't measure, see what is if the cornea is really hazy, you can't use it. What is the option for what sort of a tonometry will you do?
Usually, tonopen or dynamic contour tonometry can be used in such cases.
Have you seen any of these?
No, sir.
Okay. So see, in this particular case, the IOP is normal. So what could be the two possible reasons why the endothelial decompensation happened over time? One, I mean, you can answer from whatever you have mentioned on the sizing. So what could be wrong there?
There could be a smaller sized ACIOL placed with increased mobility leading to endothelial cell loss.
Okay. Is ACIOL bad?
ACIOL, if properly placed, and can give approximately similar visual rehabilitation in patients.
Okay. So if this has decompensated, then you feel that it is not because of the IOL per se, it is because of the initial
Intraoperative trauma.
Okay. What other options do you have in case the patient doesn't have any support at all? PC support.
Iris fixating, iris claw lenses can be used in such cases, or scleral fixated IOLs can be used.
Okay. What is the care that you should take if it is an iris claw lens with what are the types of iris claw lenses that I mean? Okay, okay, just tell. It's a plain iris claw lens. Surgically, so that so what can be the complication of an iris claw lens?
There can be pupillary block if
Okay.
PI is not done.
Okay.
There can be iris chafing leading to iris atrophy. There can be secondary glaucoma.
Iris chafing where?
At the site of insertion of the
Will it
claw.
be clinically significant?
No, sir.
No. Last question from my side. Something that, some sign that you see with an iris claw lens, usually on slit lamp. Have you seen one with a
Dimpling of.
Like when you put an ACIOL.
In case of ACIOL, we have to use dispersive viscoelastic during the intraoperative period and do a peripheral iridectomy along with ACIOL. And in case phacoemulsification is done, then the irrigation fluid BSS plus is preferred along with vaulting should be seen to prevent any endothelial damage, and instrumentation should be done carefully.
Was there any vitreous prolapse in this patient?
In this patient, due to the corneal edema, the vitreous in AC could not
Very
be
easy.
assessed.
I'm glad I'm the last, okay. Anyway, so hopefully, look, I talk a bit confrontationist. I have nothing against anybody, but I would like all of you to become competent ophthalmologists tomorrow. So my first question is, why did you ask for flashes and floaters?
It could be, there could be sequelae of cataract surgery, which might have led to retinal tears or retinal detachment.
I agree.
So
But now your patient is presenting with painful loss of vision 1 year after. Can you correlate this to a possible detachment?
What should be the onset in a retinal detachment? Onset of the disease will be sudden, correct? Sudden.
This is gradually.
Can detachments over time give rise to pain in any way? Could it be that because she had good vision in the other eye, she didn't realize the loss in this eye? And now she's presenting with loss of vision and pain, but it's when the pain comes that they usually compare to. And could you correlate that to a long-standing retinal detachment?
Especially if it is inferior, it may not be detected at all. So what will happen over time? Audience?
Complications of long-standing RT?
Hypotony? Endothelial decompensation we're discussing now. So, starts with U. Uveitis. Chronic uveitis.
Can it cause glaucoma?
Yeah, it can lead to UGH syndrome.
Not
Any other RT, can it give rise to glaucoma? And could glaucoma have caused the decompensation? By the way, you told me the IOP is 22, and in the other eye it was much lower, okay? Is this the true IOP that you have recorded?
It might not be, because in this case there was corneal edema. So in corneal edema there is underestimation of IOP.
Exactly, so you should assume. So can you tell me any cause for glaucoma here, which could have added on to the endothelial decompensation? I heard you talk about a PI, right? You saw something black. Are you sure it was patent? I heard you say patent.
Patency could not be seen. So hazy cornea, patency could not be seen.
How would you normally assess a PI? Because if I leave the posterior pigment epithelium intact, the PI looks black, right? So how are you supposed to assess for a patent PI?
We can do it by retroillumination.
Okay.
The slit lamp width is kept at 3.
Okay, fine. I'll accept retroillumination. Could you have done it here?
We tried, but the red glow was not.
Okay, fine. You said that the IOL has come down, right? And you said that it's what displaced IOL, and you said that it's probably touching the endothelium. Was there any evidence that the haptics had actually moved forward?
No, ma'am. It was touching the pupillary border.
So what happened to the pupil?
Pupil was peaked superiorly.
So when the pupil goes up, what will the IOL appear like? You're saying centered in relation to the pupil. So if the pupil went up, the IOL would seem to have?
Downwards. Displaced downwards.
Exactly, which is what I think happened here. Because usually we wouldn't estimate and put. And the last you said, after surgery, she had good vision. This was your... But I'm arguing that when I put in an AC lens, unless I'm that well equipped, I may not have put the accurate power. Will I have to put more or less power? Can I roughly decide if my PC power is 20, what would be the AC power?
Around 18.5 diopters.
How did you work that out?
1 to 1.5 diopters is reduced.
No, actually the only thing that has changed in your formula is the A constant, right? So what is the normal A constant for a PCIOL? What is the A constant for an ACIOL? You've been doing this every day, right? Right? Your biometry tells you AC and PC values, no, for emetropia.
Audience, any idea? Okay, 118.5. Which lens? Explore. Depends upon the lens.
One more question. How will you manage this patient?
In this patient, first we will evaluate the patient for any pre-existing corneal disease in the other eye and do ASOCT and specular microscopy. Then do a fundus examination to see whether the visual potential is there in that eye. Since this patient had...
You said you can't do it because of the corneal edema.
This patient had symptoms since last 1 year, we are going to pose this patient for keratoplasty with IOL exchange. And in the meanwhile, supplement this patient on topical medications like hypertonic saline, lubricants, antibiotics, anti-glaucoma drugs, and the BCL was already placed in situ.
You can do the fundus examination while doing surgery and decide.
Thank you, judges. It was an interesting presentation. Team C, please. Yes, ma'am. Yes. So one thing which we forgot probably was a long-standing diabetes with CAD. I would rather think about ocular ischemic syndrome, do a Doppler, to know whether that is responsible for the loss of this thing. And when you say CFCF, when vision is less than 1 meter, always check projection. It will tell you whether the retina is abnormal. A long-standing inferior RD with madam, with short syndrome, chronic uveitis, endothelial decompensation, B scan becomes a must. Cornea haze, orthophoria, don't mention orthophoria when one cornea is hazy. And then corneal sensation, check it again. With this much corneal opacity and edema, I don't expect corneal sensation to be normal. Okay, fine. Team C ready? Yes.
So team C, we have Dr. Sreeshma and Dr. Heba Ravishankar.
Good morning to one and all. Today I am going to present a case of a 39-year-old female who came with complaints of defective vision in right eye for 16 days, which was associated with right-sided headache and fever for 10 days. So the patient came with complaints of sudden onset of defective vision in right eye, which was gradually progressive, and she was not able to see faces clearly at near distance. It was associated with right-sided headache and fever, which was low-grade, intermittent, and more towards the evening. There was no history of any redness, photophobia, colored halos, floaters, double vision, and no history of contact with any pets. On past history, she's a non-case of hypothyroidism for 8 years on regular medication, and there's no history of any TB contacts.
Please help her.
No history of any similar illness in family members. Patient is on tyrosine tablets for 8 years. On systemic examination, central neural system, higher mental functions were normal. Cranial nerves 2, 3, 4, 6 will be dealt along with ocular examination, and respiratory system and cardiovascular system were normal, and there is no generalized lymphadenopathy. On ocular examination, head posture is normal, no facial asymmetry. On Hirschberg's test, orthotrophic. On cover-uncover test, orthophoric, and extraocular movements were full in both eyes. On functional examination, best corrected visual acuity of right eye was 2 meter counting fingers and left eye was 6.6. Near vision was N36 and N6 in left eye, and color vision could not be assessed in right eye, and left eye it was normal. On ocular examination, right eye anterior segment was within normal limits with no evidence of any keratic precipitate cells of flare and showed grade 2 RAPD. Left eye anterior segment was within normal limits and concentric light reflex were sluggish. So in fundus, right eye, media was clear, disc hyperemic, cup obliterated, and disc edema of 2 disc diopters was seen. Peripapillary edema was seen, and there was a venous dilatation and tortuosity seen with no evidence of any sheathing. A yellowish white elevated round lesion of half disc diameter in size at the temporal disc margin, suggestive of juxtapapillary choroiditis with surrounding macular edema is seen. So in this picture, we can see disc edema, tortuous dilated veins, surrounding macular edema, and the lesion, which is half disc diameter in size at the temporal disc margin, suggestive of juxtapapillary choroiditis. OCT macula at the time of presentation showed macular edema of 578 micron, and left eye fundus was within normal limits. At this juncture, our differential diagnosis was juxtapapillary choroiditis right eye and neuroretinitis right eye. Investigations, total count was 13,000, ESR was 85, CRP raised and Mandro test was positive. Rest of the investigations came normal, including toxo, IgG, IgM, serum ANA, serum ACE, HIV, HBCG, and HCV, and chest X-ray was within normal limits. MRI brain orbit was normal. Diagnosis, acute infectious juxtapapillary choroiditis with macular edema right eye, probably due to tuberculosis. After consulting a pulmonologist, on their advice, we had started antitubercular drugs along with systemic steroids. After treatment, macular star was seen in right eye. And after 1 week of treatment, we can see that macular edema is decreasing, and after 4 months, there is complete resolution of macular edema. Thank you.
You said right-sided headache. Yes. What's the cause of that?
It can be due to, if it's
various causes.
It can be it can be due to congestive glaucoma, acute onset congestive glaucoma. It can be due to any intracranial lesion. And again, it can also be acute onset uveitis also. Apart from ocular, migraine.
She's come to you complaining of defective vision, right? Yes. And one of the questions you asked her was about diplopia. Can I ask you why?
To see if there's any restriction in extraocular movements, sudden onset.
Supposing she did have a restriction of extraocular movement and she had defective vision, what would you expect?
Retinal 6 pals.
No. I'm asking, would you still ask for diplopia? I can see that there's a squint. She says the vision in that eye is bad. Would I still ask for diplopia? In other words, will every squint give rise to diplopia?
No.
Okay, so which squint will give rise to diplopia?
If there is decompensation of squint from foria to tropia, they can present with
The patient is having good vision.
Patient is having, I'll accept that. Patient is having?
Good vision.
So if you have poor vision in one eye, what will happen?
There will be suppression of that eye.
So you won't have diplopia, right?
Yes.
So I would love to know why you asked for diplopia. What was the relevance? I'm saying I can't see. You're asking me, instead of seeing one, am I seeing two?
Okay.
Then I heard you ask for a similar illness in the family. Fever, headache, defective vision. Which of these did you seriously ask for? And what was your aim of asking? Which disease were you trying to rule in or rule out? You asked this question and you put it up as a relevant, right? So what about this lady would you have asked for in the family, if at all?
Multiple sclerosis.
So you would have asked whether other people lost vision. What was your other, so when I ask for family history, I'm looking for something that could be, what shall I say, transmitted, like an infectious cause or an inherited cause.
Syphilis is an infected.
Well, recently I had my PG ask one of our nursing students history for STD. She's not even sexually active. So I think all of you need to have some sensitization to what you're asking and why you're asking. And her immediate answer was, medical student, nursing student, she knows what is STD. I thought for that reason she should slap you, honestly. So I'm asking, the only relevance might have been tuberculosis, right?
Yes.
In which case you have to ask for tuberculosis, not for 10 days history of fever, unless what is the other fever that might give rise to optic neuritis, which 10 days ago everybody in her family
Post-viral infection.
Exactly.
Post-viral infection.
So you have to tell me what history you asked for in the family. Was it for tuberculosis? Was it for people, if it is MS, you should lose vision and regain it. And I would have thought it's more relevant to ask her whether she had episodes when she lost vision and regained it. Okay, you said I can't test for color vision. Why not? She's not blind in that eye, right? What was the vision in her affected eye?
2 meter counting fingers.
Correct. So if I really wanted to know about her color vision, what could I have done? In fact, what do you say in optic neuritis? What happens to the color values?
It will be disproportionately, color vision will be more affected.
Any particular color and
red.
And what happens to the red? You stop seeing red?
It will be dull. It will be rose. It will be desaturated.
Exactly.
Desaturation.
Could you not have asked her?
Yes,
Could you?
Yes, ma'am.
But what you couldn't do is?
Ishihara's chart.
Correct. Which is not needed. In optic neuritis, we know vision will be poor. So we don't need them to read the Ishihara. We need to ask them about color desaturation. The management was okay. But at 4 months, you showed me the OCT. Why didn't you tell me about the vision?
Vision has not much improved. Like 660 is the vision.
Okay. Can you postulate causes why the vision did not improve?
Can be due to epiretinal membrane formation.
Pardon me?
Epiretinal membrane formation.
Was there? There was nothing on
No,
your
no,
OCT that
no,
I
no.
saw.
Foveal thinning was present.
Was there?
Yes.
I saw.
No, foveal thinning was there.
Was
Like
it?
178 and all it has become. No, from normal.
So you're postulating there's been loss of the papillomacular bundle.
Yes.
Agreed, which was the. But would you see something on the disc in that case?
Disc pallor.
What type of pallor? You saw
Consecutive disc pallor.
papillomacular bundle is gone. Where would you see the pallor? Is that also a sign of optic
Which part of the optic nerve head?
In optic neuritis, the papillomacular bundle is more involved, which is why central vision goes first. So what will you see on the disc if you lose those fibers?
Band shape, bow tie.
No, which part of the optic nerve head where the macular fibers go and end?
Temporal disc pallor.
Temporal pallor.
Were you able to do field studies in this patient?
No, ma'am. No.
Why?
Still at 660, she was having lot of false positives. It was not clear.
So you tried?
Yes, sir, ma'am.
So if she gets false positives, what is the reason? What is the reason? What do you mean by a false positive? I can understand false negative being a problem, but false positive, what does it say? Okay, when will the computer record a false positive?
When the patient, trigger happy patients will have false positive, high
Correct.
false.
So if you had told her properly that she presses only when she sees the light, you could have overcome that, right? Whereas with a false negative, I can't be, there's nothing. I can tell her to be attentive. That's
Test for the blind spot in this patient?
No, ma'am.
You did not try? Suppose you have got the field test for central vision. What type of wheel would you expect?
Centrocecal scotoma. Centrocecal scotoma can be present.
Okay. Enlargement of blind spot also will be there because it is very close to the disc. What treatment did you give for this patient?
Antituberculous drugs were started and systemic steroids were given for this patient long term.
Long term means?
For 1 month and all it was given.
How much?
According to her weight, it was like she was short, so like 40 milligram.
What is the usual dosage that you will give for adults?
1 milligram per kg.
So how much? Suppose she is about 60.
60
kg.
milligram.
How many days?
For
how long?
60 tab prednisolone. Tab prednisolone 60 milligram. 60 milligram OD. 5 days we can taper. Next 5 days, 550
What are the
milligram.
precautions that you have to take before giving steroids?
We have to look at the RBS. Blood sugars should be checked. Then ECG can be checked, and after then bone density. If it's an old patient, bone density should be checked. And we have to say about gastritis and all. We have to give pantoprazole tablets also.
Okay, then what about BP?
BP measurement also. Yes,
All those things should be done prior to that. Then what will you do?
No, for 5 days or 1 week. Then we have to taper to 50 milligram, then 40, 30, 20, and 10, then stop.
And in between you will have to?
We have to record the blood sugar values and BP also, blood pressure.
Eye examination also.
And eye examination, visual acuity.
Then only-
Visual acuity and color vision should be examined.
Can I target my question to the non-playing member for a minute? You said that TB was diagnosed on the basis of a positive MAN2. How positive was this MAN2?
It was more than 15 millimeters.
More than 1.6?
1.5.
1.5. You don't know how much exactly. You're saying because you said positive, it must have been.
No.
I have a MAN2 of 20. And I've never taken ATT. I've got scars on both sides. I've got a fibrotic and a calcified. So would I have to take ATT? My husband doesn't let me. So what other tests could you have done to rule in or rule out tuberculosis?
TrueNAT.
Pardon me?
Sputum TrueNAT.
TrueNAT.
Quantiferon TB.
an ordinary CBC ESR for activity, an X-ray chest, because that's the commonest type of TB we get to see. And your TrueNat was actually negative, right?
Yes.
None of those, including quantiferon gold, it only tells you antibodies. I mean, I must have had TB sometime. But like somebody told me, you should be happy. You're responding so well to that. So there's less chance of you suffering from TB. So if just because my antibodies are high, it doesn't mean I have active TB. Okay, so I'm not, what was your reason? Every juxtapapillary choroiditis is Jensen's and is probably tuberculosis. Not true, actually. Anyway.
Suppose the patient is diabetic or hypertensive, would you not give steroids in this patient?
We will ask the general physician to adjust her oral hypoglycemic drugs, and if needed, they can add insulin also during the time of taking steroids.
Yes, you have to give the steroids, but the control of hypertension and diabetes, if any, should be done.
Okay, thank you, judges.
Thank you.
That was quite interesting. Team D, please take over. The few points. When the media is clear, toxo is unlikely unless the patient is immunosuppressed. And pets specifically asked with toxo probably in mind, but think about Lyme's and other animal-borne diseases as well, Bartonella. Then 2-meter vision, color vision, contrast, as well as visual field can be charted. It should be monitored on a daily basis to this thing. And juxtapapillary, you should also think about infiltrative optic neuropathies, as was heard in the morning. Team D ready?
Yeah, before we go to Team D, I think we'll have an audience
Yes,
question.
yes.
So,
For
what
the
is-
seniors or the juniors?
Yeah, everyone included. So, what do you know about COTS calculator? Have anybody heard COTS calculator? COTS calculator. COTS calculator. Has anybody heard about it? So because ATT was started here, so that's relevant to that. So it's an online evidence-based and based on experience scoring system which is available online whenever you want to start ATT in ocular tuberculosis. So you can just enter in the Google COTS calculator, you reach that site, you can enter the patient details, the clinical features, your findings with the immunological test, MAN2 and IGRA, plus the radiological findings. You get a score based on evidence and also experience of the doctors who are treating it, the uveitis specialists. So it's a very good thing because ATT has a lot of, you have toxic optic neuropathies, you have hepatitis, there are a lot of side effects with ATT. So when you start ATT for a patient, which you're going to give more than 6 to 9 months, you should have evidence behind you why you started ATT. So this is a very safe thing to go to the COTS calculator, put in your data details and get a reply. So which you can actually use it in your legal proceedings also. Thank you.
Well said, Dahlia. Thank you. Yes, Team D.
So Team D, we have Dr. Sumaya and Dr. Sahana.
Good evening, everyone. So presenting a case of 52-year-old female who is a homemaker coming from Cheruvadi, presented with complaints of blurring of vision in both eyes since 7 months. History of present illness, patient was apparently normal 7 months back when she noticed blurring of vision in both eye, which was insidious in onset, gradually progressive and painless. No history of flutters or flashes of light, no history of redness, photophobia, no history of micropsia, macropsia or metamorphopsia, no history of any ocular or head trauma. Coming to past history, she is a known case of type 2 diabetes mellitus since 12 years and on tablet metformin and tab glimepiride. No history of hypertension, dyslipidemia, coronary artery disease, stroke or kidney disease. No history of any ocular surgeries or lasers in the past. She is using his spectacles since 6 years. Last spectacle changed 6 months back from an optical shop. Her recent fasting blood sugar value is 137 and PPBS is 214. Personal history, she takes a mixed diet with normal sleep and appetite, no alteration in bowel and bladder habit, no addictions. Family history, there is a history of type 2 diabetes mellitus for mother and 2 siblings. Coming to general examination, patient was conscious, oriented and cooperative, moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing and lymphadenopathy, no pedal edema, Vitals were within normal limits. Systemic examination were within normal limit, including the carotid pulsation. Now coming to ocular examination, head posture was normal. There was no facial asymmetry, orthophoric, and ocular movements were full and free in all direction of gaze. Vision in right eye was 636 with an improvement to 6.9 with pinhole, and left eye 636 improving to 6.9 with pinhole. Near vision with 2.25 D sphere improving to N6. Wet retinoscopy with tropicamide and phenylephrine at a working distance of 66 cm was +3 diopter in both horizontal and vertical meridian. Coming to anterior segment examination, right eye lid and adnexa was normal, conjunctiva was normal, cornea clear, normal size, shape and transparency with normal sensation. Anterior segment was von Herrig grade 3 with no cells and flare. Iris normal color and pattern, no neovascularization of iris. Pupil was round, regular, direct and consensual light reflex brisk, no RAPD. Lens nuclear sclerosis of grade 2 with peripheral cortical cataract was present. Intraocular pressure by Goldman applanation tonometry was 16 millimeters of mercury in both eyes. Similar findings were seen in left eye also. Coming to fundus examination, right eye fundus, media was clear with disc normal in size, vertically oval with a well-defined margin with vertical cup disc ratio of 0.4 with neuroretinal rim is pink following ISNT rule. Vessel arising from the center of the disc, branching dichotomously with an arteriovenous ratio of 2:3. Background retina showed many pinhead-shaped lesions continuous with the retinal vessels, suggestive of microaneurysm. Deep red round, not continuous with the vessel, suggestive of dot hemorrhages were seen in all 4 quadrants. Yellowish fluffy lesion with indistinct margin seen 3 disc diameter away from the disc along the superotemporal arcade, suggestive of cotton wool spots. Yellowish waxy lesion with distinct margin seen 1 disc diameter superotemporal to macula, suggestive of hard exudates. Fine lacy branching vessels were seen near the inferotemporal arcade about 4 disc diameter from the disc, suggestive of neovascularization elsewhere. Foveal reflex was present with no significant retinal thickening noted. Left eye fundus. Media was clear, disc normal in size, vertically oval with a well-defined margin with vertical cup disc ratio of 0.4. Neuroretinal rim was pink following the ISNT rule. Vessels arising from the center of the disc branching dichotomously with an arteriovenous ratio of 2:3. Background retina showed many pinhead-shaped lesions continuous with the retinal vessel suggestive of microaneurysms. Deep red lesions not continuous with the vessel suggestive of dot hemorrhages seen in all 4 quadrants. Yellowish waxy lesions with distinct margins seen 1 disc diameter superotemporal, temporal and inferotemporal to macula, suggestive of hard exudates. And fine lacy branching vessels were seen near the superotemporal arcade, about 4 disc diameter from the disc, suggestive of neovascularization elsewhere. Foveal reflex was present, no significant retinal thickening noted at macula. Diagnosis, both eye early proliferative diabetic retinopathy with maculopathy, both eye nuclear sclerosis grade 2 with cortical cataract with type 2 diabetes mellitus. Thank you.
Why do you say it is proliferative diabetic retinopathy?
Because neovascularization elsewhere was seen in both fundus. Neovascularization was seen in 2 disc diameter away from the disc along the inferotemporal arcade in right eye and along the superotemporal arcade in left eye.
What is the vision in this patient?
Vision was, ma'am, right eye 636 improving to 6.9 with pinhole and left eye 636 improving to 6.9 parts with pinhole.
Okay. So what will you do now for this patient?
So we'll do an OCT and we'll look for any retinal thickening. If at all retinal thickening is present, we'll look whether
What is the first thing that you will have to do for this patient?
Patient already had done FBS and PPBS, and we'll also ask the patient to do an HbA1c to look for the control of diabetes to see whether it is controlled or not. And then we'll ask the patient to do an OCT to look for retinal thickening.
What is the blood sugar?
Blood sugar was, madam, 136 FBS and 270
The first thing is to control the blood sugar.
Yeah. I'll advise the
HbA1c has not much value. It is only considered for patients who are not taking treatment regularly. Irregular treatment, so we can say that you have not controlled blood sugar. So fasting and blood sugar and postprandial blood sugar is more important, and you control it initially. And then start your treatment. Only if you control the blood sugar, you can do any manipulations in the eye.
How did you confirm that you have clinically found that you have NVE? So would you go for an FFA to really confirm neovascularization, or would you go for just an OCTA, or you have it there? So, what would be your course of action to really confirm that the patient has PDR?
In this case, NVE was evident. Also, we can do FFA to confirm it is NVE and not intraretinal microvascular abnormality or anything else. So, yeah, we can do FFA to confirm that it is clearly NVE.
And also to rule out foveal ischemia.
Macular ischemia.
Macular ischemia.
You did OCT to confirm there is no CSME?
No, there is no we have done OCT and
there was no thickening, sir.
Okay. And the clinical examination, ma'am will ask, and then I will go to the...
I will certainly ask, but I would like to sit out marking on this one because I happen to teach these people at Contra. So I'll definitely ask the question, but you will take the average of their marks. So my question to you is, she came for defective vision, right? So what is the cause for that defective vision?
She also had nuclear sclerosis of grade 2.
But her...
Any of these retinal findings,
yes,
are they going to actually affect the vision?
Yes, there was hard exudates in the macular area. Yeah.
So the patient has CSM?
No,
Not within 1 disc diameter.
What did you tell me? She had glasses. The glasses were last changed 6 years ago. And you had vision that improved with the
6
pinhole.
months back, madam.
6 months?
Yes.
Okay, better still. So what might have happened between 6 months and now that she lost vision where you can't see much in the fundus?
Her cataract might have improved, increased.
Could her blood sugar have changed and caused the refractive change?
Yes, blood sugar also can.
So can you tell me, pinhole, what was the power that she accepted?
Plus 1.5, ma'am.
Oh. Usually you become myopic when the blood sugars go up. Then the last one is a comment for all the retina specialists here. I've tried telling these people that whether it's a microaneurysm or a dot hemorrhage, it's from the capillary. It's got nothing to do with the blood vessels themselves. But obviously, I don't know, is that what the retina people now teach? In my day, capillaries are there all over. It's the same microaneurysm that bleeds to cause the dot hemorrhage. The only thing is that when there is an area which is secreting VEGF, microaneurysms tend to cluster in that area. But I'm not aware that microaneurysms occur close to blood vessels and dot hemorrhages occur. In fact, in my day, it's very difficult to know whether it's a hemorrhage or a dot hemorrhage or a microaneurysm. And we used to talk about waiting time to see whether it should go. So this is not for them, it's for all the retina people, because this is obviously what they've been taught. It's what they've been telling me in many classes so far. This question is to educate me.
Okay, ma'am. We'll discuss it.
Will you do fluorescent angiography in this patient? Is it required?
No, because the NV is already was evident and it is early proliferative diabetic retinopathy.
When will you examine the fundus first in a diabetic patient? Well, suppose a patient is detected to be a diabetic. When will you advise him to get the fundus examined?
In type 1 diabetics, after 5 years, and in type 2, at the onset of diagnosis.
Why after 5 years?
Type 1 will be diagnosed very early age groups.
It will usually take some time to so, but not that in type 2. So immediately when the patient knows that he is a diabetic, he should be advised to. But it is not being done nowadays, so we'll have to advise our physician friends to do that.
So we'll counsel the patient.
What is the reason for
Refractive changes are there, induced diabetic. So we'll yes.
only in one eye, but that's not seasonal. So that the other eye has nothing for macula.
Exudates was there in the macula.
Both eyes?
Yes, both eyes was there. It was there, but not in the central part, sir. It was there in the macular area. It was there.
So is it cataract that has
Yeah, it could be because there was no edema in the OCT and no ischemia in the FFA.
now the patient has come to you with disease, you have to take care of it.
Yes.
What are you?
We counsel the patient regarding her present condition
Glycemic.
and I'll advise her regarding the glycemic control and then we'll
counsel her for
pan. Okay. Cataract extraction has to be done. Yes.
Okay. So what is the problem with you? After all this, what is the problem with cataract?
In cataract surgery, in diabetic patients, the pupil. The pupillary dilatation could be.
No. The question is, the patient has proliferative diabetic retinopathy with maculopathy.
It can increase the macular edema. The
whole diabetic retinopathy can progress.
yes.
So would you just straight ahead, go ahead with cataract surgery, or what?
Treat the retina.
Pan-retinal photocoagulation. PRP.
Okay. Would it be PRP that we preferring? A lot of how many?
Yes, what are the other treatment options available?
PRP and intravitreal injections, anti-VEGF can be given. But in this condition, there is no macular edema as such, so we'll go for pan-retinal photocoagulation. Yes.
if patient is willing to for proper follow-up, multiple visits, multiple injections,
then we'll go
we
for
can.
If the patient didn't have cataract, no cataract at all, then how will you manage?
Pan-retinal photocoagulation.
When would you not do pan-retinal photocoagulation? Let's say 6/9 only, it's not really. When would you not do pan-retinal photocoagulation?
If there is macular edema involving the center.
No. Instead of pan-retinal photocoagulation, you're not able to do pan-retinal photocoagulation. If the cataract is dense enough.
Yes. In case of
those cases, what do you do?
Intravitreal anti-VEGF has to be given.
Yeah, and then do
Cataract
Yes, cataract
extraction
surgery.
followed by PR.
Pan-retinal photocoagulation.
And when will you give the intravitreal?
If there is center involving DME.
How?
In this particular case, you have to there is a significant cataract.
Yes.
And you have to do cataract surgery.
Prior to cataract surgery, when will you schedule IVR injection?
1 week prior to cataract surgery. Sorry, cataract surgery along with cataract
Yes.
surgery. No, along with cataract surgery, we can do.
You showed a retinal chart, no? Retinal chart you have shown.
Yes, sir.
What is the name of that chart? You can
Amsler-Dubois chart.
no. You can find out.
And for the audience, what are those 3 rings representing?
Retina chart in the retina. You show the
Amsler-Dubois.
Pars plana.
Amsler. That.
Okay.
Find.
So, yes, thank you, judges. That was an interesting presentation. So, few point NVE. Is it a raised or a flat NVE? You have drawn orange or purple. Color coding of NVE, and draw everything within the arcade. That is where you have to know what are the 3 rings, and depending upon that, draw the binding and start the vessel from within the disc. Peripapillary, it's just papillary vessel, so all vessels will merge with the disc. And maculopathy, type of maculopathy, focal, diffuse, CSMA, that has to be mentioned properly, and the plan of action. And as far as consultants are concerned, always, though we are ophthalmologists, we would rather like to know the sequelae, the comorbidities. When you have PDR, you have nephropathy and other microangiopathy as well. So evaluate prior to IVR, do a urine microalbumin creatinine so that we know whether there is microalbuminuria. That's team D ready. Team E, ready?
So team E, we have Dr. Navami Sreekumar and Dr. Sripriya.
Yes, ma'am. Like microangiopathy, what ma'am said is absolutely correct. It affects capillaries, and in the posterior pole, you have capillaries much more than the crowding of the capillaries are more appreciable in the posterior pole. So if you take an angiogram, if you have a wide field angiogram, you will see network issue, problems with periphery also. Periphery is supported by the choroidal vessels. You have less activity, everything less in the periphery, and well supported by the watershed zone of the choroidal, posterior ciliary circulation. So unless there is a coexistent ocular ischemic syndrome, you don't see much issues in the periphery of the retina where the demand is less. In the center, the demand is more, hence microangiopathies manifest more. No, it's not close to the vessel. It is the outskirt of the capillary non-perfusion areas. So whichever area is ischemic, you get angiogenesis, new vessels, dilatations, microaneurysms. First comes fluid, then comes cells, then come RBCs. So even a single microaneurysm tells you that there's abnormality at the level of the capillaries. No, that sentence is wrong. No, that sentence is wrong.
Good evening, everyone. Presenting the case of a 62-year-old male with complaints of double vision, pain around left eye, and drooping of the left eyelid since the last 30 days. The patient gives a history of a sudden onset diplopia since 1 month, which was associated with pain around the left eye, which was dull, aching, and intermittent in episodes, followed by drooping of the left upper eyelid, which gradually progresses to complete closure. He is a known case of type 2 diabetes mellitus, 15 years on oral diabetic medications. He is a known case of hypertension, coronary artery disease, and is recently detected with chronic kidney disease. General physical examination was within normal limit, and on systemic examination, the central nervous system, the following cranial nerves were involved: oculomotor nerve, left complete ptosis and external ophthalmoplegia; trochlear nerve, left indorsion deficit; trigeminal nerve, sensation over the left forehead and the upper eyelid, and corneal sensation was reduced; and abducen nerve, left abduction was deficit. Ocular examination, head posture was normal, and on corneal reflex test, there was a 15-degree left exotropia. Extraocular movements was full in all directions in the right eye, and there was a -3 restriction in all gazes in the left eye. Anterior segment examination of right eye was within normal limit, and the left eye shows complete ptosis. Corneal sensation was reduced, and there was a nuclear sclerosis of grade 3. Functional examination, the best corrected visual acuity was 6.9 in the right eye and 6.18 in the left eye. Color vision contrast sensitivity was normal in the both eye, and the visual field was full. Ptosis measurement shows left complete ptosis with poor levator function test, and the diplopia chart shows cross diplopia in all cases, and the force section test was negative. A provisional diagnosis of cranial nerve 3rd, 4th, and first division of the 5th cranial nerve and the 6th cranial nerve palsy, probably left superior orbital fissure syndrome, was established. And on investigation, ESR was found to be 45 mm per hour. normal total count with neutrophilia, and the fasting and the postprandial blood sugar was found to be high. The HRCT brain plus orbit shows an ill-defined soft tissue thickening noted involving the lateral wall of the left cavernous sinus extending to the left superior orbital fissure, suggestive of an inflammatory or granulomatous lesion, and etiological diagnosis of Tolosa-Hunt syndrome was established. After ruling out the infective causes and controlling the diabetic and maintaining the diabetic control, IV steroids was started, and the pain was reduced after 2 doses of IV steroids, and the patient was was maintained on oral steroids. So
What
the
happened
patient
further?
was given IV steroids for the initial course, and later on he was discharged on oral steroids. So after the first 2 doses of the IV steroids, the pain around the left eye was reduced, and the ophthalmoplegia, the extraocular muscle restriction was reducing, but ptosis was persistent. And the patient is on steroid, and since his diabetic control is not maintained, he was planning to be started on steroid sparing agents.
When did you see this patient after the complaints?
Actually, the patient presented to our hospital after 1 month. So first he went to, first he had diplopia, and later on he had pain around the left eye, and then he consulted a local hospital, and after consulting the hospital they start some the medication history was not known, but he told he was started on some oral medication and topical drops, and later he got the drooping ptosis, which gradually within 2 days it progressed to complete ptosis, and they did an imaging MRI, and the patient came with an MRI report to us suggesting it is orbital cellulitis.
When you saw the patient, was he having ptosis?
Yes, when he came to us, he was having complete ptosis.
Did he have diplopia at that time?
No, he was not having diplopia. Since it's complete ptosis, he was not having diplopia at that time.
Okay, then after the treatment, when did you see him later?
Madam, after he was first admitted, and then he was.
He didn't come for review?
Yes, madam, he came for review. After getting admitted and ruling out the infectious causes for the same, we started him on steroids, and on the follow-up, the extraocular movement restriction was reducing, but ptosis was persisting.
Okay, how long will it take?
Usually, it takes long, 4 to 6 months time.
Okay.
What were the infections that you had in?
Since he was an uncontrolled diabetic, mucormycosis was a possibility, and on ENT evaluation there was a polyp identified in him. There was a nasal polyp, so they did a biopsy to rule out the mucormycosis, and then again the imaging doesn't show anything which was consistent with it, but still it was done. Sorry, ma'am? Pupil was bruised, ma'am. Both the pupils were bruised.
Why the pupil is not involved in this case?
Probably the orbital apex would not be involved. The lesion would be in the superior orbital fissure, near the superior orbital fissure, where because compressive lesions would be causing a pupil involving, and this would be inflammatory, so not pupil sparing.
Can we have the slides on movements? No, they'll help you. No. All movements, were they affected equally?
It was -3 restriction. Yes. In Hirschberg test, exotropium, it will be nasal. Left exotropia, 15 degree. Yes, I don't know.
Ma'am, can you use the mic, please?
Can I have the ptosis measurements? Yeah. Can you interpret this for me, please?
So the first one is the marginal reflex distance one, which is measured from the upper lid to the center of the corneal. After showing the the light to the glabella, it is measured, and from the apex of the light.
No, from the
Corneal
From
reflex
the
to the
corneal
margin.
reflex to the upper eyelid, the marginal reflex
fine.
distance one
So
is
on
measured.
one eye you got it as 4, and in the other you've written -5. What did you mean? Tell me, so what does it mean?
What did you do to get that minus value?
Means
In ptosis, how do you measure?
okay. Means in the left eye, I lift his upper eyelid and then shone the light, and then I calculated the MRD2, marginal reflex
So the
distance
5
2.
stands for?
From the distance from the corneal reflex to the lower eyelid.
That's MRD2.
That is MRD2.
I'm asking MRD1, -5.
-1.
That is how much you...
It would be the relative position of the lid margin to the corneal reflex.
Okay.
So if it is above, it is plus. If it is below, it is negative.
Okay, fine. Now MRD2, you got a different on the two sides, right? What does that indicate?
Loss of the inherent tone of
Why did you have MRD2, that is the distance from the lower lid to the corneal center, 6 on one side and 5 on the other?
What does that indicate? Has something
That would
happened to
be-
some nerve?
The inferior retractors of the lower lid are supplied by the sympathetic nerve.
So you're postulating now sympathetic palsy. Something simpler than that could have happened too.
Enough.
So the lid is where it was. Something else came to meet the lid.
Extraocular movements? Related to extraocular movements, placement of the...
What would happen if you had hypotropia on that? What would happen to MRD2 if I had?
hypertropia.
It will decrease.
Less. It will be less.
Of course, the main reason why you get MRD2 wrong is you stand up in front of your patient and the patient is looking up at you. What did you tell me was the pathological height on the right? 10, okay?
10.
On this side, you said 0, right? So theoretically, you have to lift it 5 only from the, right? Anyway, think about it. So after this, you told me it suggests complete ptosis and poor levator function. But I'm going to argue if the sympathetic was working, would you have had a small palpebral effect? Now, if I postulate sympathetic palsy along with this, when will you worry about sympathetic palsy? How does the sympathetic come in?
What does that suggest?
Horner syndrome.
No.
That is
I'm
sympathetic
asking,
plexus along the
you have
internal-
got 3, 4, 6 involved and 5.
5. V1.
When will you get sympathetic also in?
when the carotid artery is
Ah,
involved in the
so-
cavernous sinus.
Fine. So if the sympathetic was involved, would the pupil necessarily be involved in this?
It will be meiotic. Yeah, it will be meiotic if the sympathetic is involved.
You have a dilated nerve, a dilated pupil of third nerve on one side and a small pupil on the of Horner's on other side. So,
Okay, thank you.
So what was the imaging that was done?
So, we did an HRCT brain plus orbit, and in that the ill-defined soft tissue lesion on the left.
Why?
Ac-
Why did you prefer CT over
MRI. Actually, he did an MRI from outside, and the report.
What is it, a plain MRI or MRI with contrast?
Plain MRI.
What is actually preferable in these cases?
MRI brain plus orbit plus contrast.
But they wouldn't have diagnosed orbital cellulitis without any findings, right?
Yes.
So were there findings suggestive of orbital cellulitis?
No, ma'am. Actually, when he presented to us, there was no signs, and in his previous record also, nothing was.
Marian is not here. I'm glad my husband is not a radiologist because today we are casting aspersions on the radiologist ability. Right? So I wouldn't diagnose orbital cellulitis if there were no findings with the orbit.
No. The first MRI finding was written as fat stranding. There was orbital fat stranding, but clinically.
So I could argue that that was orbital cellulitis, which has now gone in for cavernous sinus thrombosis. Would you agree with me? Would you agree with me? I'm saying it started as orbital cellulitis, which is what the scan showed, and now what's happened is cavernous sinus thrombosis.
No.
Clinically, what will you see?
Would you agree with me?
No, proptosis is not there.
Oh no, proptosis.
What are the other signs? Like orbital cellulitis going to cavernous sinus? What will be the sign of orbital cellulitis?
There will be congestion, hemosis, and
Would be there with orbital cellulitis. Supposing it goes in. Anyway, don't even think of agreeing with me. People with cavernous sinus thrombosis are almost terminally.
Yes.
They're not people who are going to sit and help you do with their heads. Don't even think of agreeing with me. Unless you're going to postulate some low-grade inflammation in the orbit and low-grade inflammation in the cavernous sinus, and like you proved, both of them probably immune.
Any more questions? Yes, ma'am.
You treated with steroids alone, no antibiotics?
No, antibiotic was given along with it. Madam, it was started with an empirical therapy of IV cefosulbactam.
I have a relative who's a microbiologist who's really worried that us ophthalmologists are going empirical higher-end antibiotics are a big risk to the community because they're arguing that most of our organisms are becoming resistant because we use them indiscriminately. Anyway, what?
Thank you, judges. It was an interesting case. A few things for the audience. If you see proptosis, think about orbit, massive proptosis. When you have a 346 issue, you will have mild proptosis, maximum 3 millimeter. When the apex is involved, optic neuropathy, optic nerve dysfunction, visual loss, anterior cavernous, you get sympathetic also, posterior cavernous, fascicles split, so the distribution will not be equal. Dense involvement of the nerve distribution, muscles will not happen. So if you have a chronology, even you can and assess the prognosis as well as progression of these cases. Okay. Last team, ready? Please.
A very good evening, one and all. So today we will be presenting a case of 75-year-old male patient from Kundamangalam who came with complaints of defective vision in his right eye for the past 4 years, and he complains of a superior field defect in his right eye for the past 1 year. It was gradual, progressive, painless loss of vision. He has been using spectacles, and there is no history of any usage of topical medications, no history of trauma or ocular surgeries. He is a non-case of systemic hypertension and dyslipidemia on treatment for the past 5 years. He is a non-case of coronary artery disease who underwent angioplasty 2 years back and on antiplatelet therapy. There is no family history of glaucoma or usage of topical medications. His general and systemic examination were within normal limit. Coming to functional examination, his uncorrected visual acuity in right eye was 6/60, which improved to 6/18 with pinhole, and left eye it was 6/9 parts, which improved to 6/6 blurred with pinhole. Near vision was N12 in right eye and N10 in left eye. Subjective refraction, right eye 660 improved to 618 with -1 diopter sphere and -0.75 diopter cylinder at 130 degrees, and left eye it improved to 6/6 blurred with -0.5 diopter cylinder at 110 degree. With a near vision add of +2.75 diopter cylinder, sphere, it improved to N10 and N8 parts. Coming to ocular examination, there was no facial asymmetry, eyes were orthophoric, ocular retinixa was normal in both eyes, conjunctiva was normal, cornea was normal in size and shape and clear, anterior chamber was normal in depth with Van Herrick's grade 3, iris was normal in color and pattern, there was no evidence of pseudoexfoliation or there was no evidence of any iris atrophic patches. Pupil showed a grade 2 relative afferent pupillary defect and left eye it was brisk in reaction. Both eyes showed lenticular cataractous changes of nuclear sclerosis 2 with early posterior subcapsular cataract in right eye and NS1 with early PSCC in left eye. His intraocular pressure measured by applanation tonometry at 1 p.m. In right eye, it was 32 millimeters of mercury, and in left eye, it was 16 millimeters of mercury. On correction, after central corneal thickness, it was 33 and 18 millimeters of mercury. On doing gonioscopy, it was open in open angles in both eyes. In right eye, it was seen up to trabecular meshwork in superior nasal and temporal quadrant, and seen up to scleral spur in inferiorly. And in left eye, it was seen up to scleral spur in all 4 quadrants. Color vision, patient could identify primary colors in right eye and in left eye it was normal. Coming to fundus examination, media was hazy due to lenticular opacity in right eye. Disc was normal in size and shape with well-defined margins. Vertical cup disc ratio was 0.9:1 and horizontal it was 0.8:1. Neuroretinal rim was pale and cup was deep. It doesn't follow INCT rule and there was inferior thinning present. Laminar dot sign was present. A nasalization of vessels seen. Bionetting was seen superiorly. There was bearing of circumlinear vessels superiorly and there was beta zone peripapillary atrophy present and inferior retinal fiber layer defect present. Vessel showed general arteriolar attenuation with arteriovenous ratio of 1:3. Macula showed a dull foveal reflex and drusen was present and background retina was tessellated. And left eye fundus was, media was hazy due to lenticular opacity. Disc was normal in size and shape with well-defined margins. Vertical cup disc ratio was 0.6:1 and horizontal it was 0.5:1. It was a healthy neuroretinal rim with a deep cup. ISNT was not followed. Nasal was thicker than inferior, than temporal, than superior. There was laminar dot sign present, nasalization of vessels present. Bionetting was seen superiorly and inferiorly, and a beta zone peripapillary atrophy was seen. There was generalized arteriolar attenuation, and arteriovenous ratio was 1:3. Macula showed a dull foveal reflex, and drusen was present, and background retina was tessellated. On doing perimetry with Humphrey field analyzer 30-2 study with reliable indices, right eye had a superior arcuate scotoma and left eye there was inferior arcuate scotoma seen. And on doing OCT, RNFL for right eye and left eye there was RNFL thinning was, the defects were noted, thinning was present. So with the history, examination and relevant investigations, we came to diagnosis of advanced primary open angle glaucoma in right eye and primary open angle glaucoma left eye. Thank you.
Ma'am, can you use the mic, please?
What's your diagnosis?
In right eye advanced primary open angle glaucoma.
You couldn't see the fundus?
Fundus finding was
you did 90D?
Both 90D examination and was done and indirect of color.
Indirect. Both you couldn't see?
View was there.
Yes, ma'am. It is visible.
Visible, ma'am. Disc was visible, yes, ma'am.
Right eye?
Right eye, yes.
Oh. Okay. Okay, what's your diagnosis?
In right eye, advanced primary open angle glaucoma, ma'am, and in left eye, primary open angle glaucoma.
What did you do for this patient?
After
field studies were done?
Field study was done, and in right eye, there was superior arcuate defect, and in left eye, there was inferior field defect as well. Vision in right eye, ma'am.
For distance and near.
In right eye, and for the and he has been using spectacles since then.
No, and you also added that he had a superior field defect, right?
Yes, ma'am.
The superior field defect would have developed over time. What are the chances of me detecting a superior defect? And he has an inferior defect in the other eye, which apparently he hasn't noticed.
No, ma'am.
Theoretically, would I notice a superior or an inferior?
usually we notice inferior field defects more than superior, because due to our daily activities, we notice inferior defects more.
What was it? I mean, I can't interpret your HFA at all. I can't make out anything. Was the field effect, what are the values, raw data? What are the decibel values in the upper part?
Raw data, it was upper value, it was 10, 12 and all, ma'am.
I know, it's not less than 0 anywhere, right?
No, ma'am.
No, ma'am.
So he was seeing, but he wasn't, I mean, sensitivity was low. He actually detected this, or was he seen somewhere else and they told him that, look, you have loss of the superior field?
No, actually patient himself noticed, because while going out and while he is riding and all, he noticed that he could not, when he looks at a person, he can see lower part of the person clearly rather than his upper torso and upper part and all. That's how.
With both eyes open, with a normal superior field in
First
the
he noticed with both eyes, and then he did with his two eyes, each eye closed.
But the superior field was normal on the other side. What were the values there on the left?
Left side was.
You said inferior arcuate, right?
Inferior field defect, ma'am. Yes.
But the values are 11, 12, 13, same, similar.
Same on both sides.
Yes, ma'am.
Okay, so both eyes he has a superior defect then. No, or 11, 12 is for the inferior field. I can't make out anything here.
Inferior 22, 26,
That is
17,
Anyway, it's
18.
food for thought, okay?
Yes, ma'am.
I only once in my life have I seen a POAG patient who came to me and drew the scotoma for me. But he was a pilot. He was an airline pilot. And he said there is this area, and it absolutely corresponded to, of course, we were doing germs then. But absolutely, the way he drew it and where I found it was the same. And that was superior. But I don't know, I'm not a glaucoma specialist, but I'm sure that most glaucoma patients come to you when they lose central vision. They are losing their periphery so slowly, and the other eye compensates to some extent. So this is my other advice to all PGs, that listen to your patient and tell us what the patient said. Don't make him say what you want to hear. No? I know that PGs often add to the history. You ask the leading question. Because you've seen the field. Then he says, "Adu ശരിയാണ് ട്ടോ. ഇപ്പൊ നോക്കുമ്പോ മോളെ is not so clear," which is not his presenting symptom. In many ways, I've seen you people elicit after the fact, not before the fact. Okay. Anyway, CCT. Just one last question. What is the role of CCT?
Actually, while we measure intraocular pressure by 80, usually it is for 520 micron thick cornea. So in thinner corneas, they tend to underestimate the IOP.
False low IOP seen in low thickness, low CCT, and if there is high CCT, there will be false positive value.
Is there any chance of glaucoma developing in people who have
Thinner
higher
corneas.
or lower?
Thinner corneas tend to develop glaucoma rather than thicker corneas.
Have less of. Is that what you said? I thought you said the opposite.
No, ma'am.
Okay.
How helpful is you've shown the fundus photograph, and would you actually take a fundus photograph and give it to the patient for follow-up?
Not usually. We used to document it. We used to draw it on the OPD cards. We usually not give the fundus photograph.
So what would give you the actual help to take a fundus photograph, take a printout? Would it be helping you in making the proper diagnosis of a glaucoma, just a printout, or something else would help you?
RNFL.
No. I'm talking with the fundus
photograph. To see the progression of the disease, it is better to do a.
No. The thing is, it's just a photograph doesn't actually help. If it is on the system and where you can actually magnify and see and all, then only it has value in following up. Take a printout. It's not actually going to help. Fundus photograph is a very important tool. Okay, I mean all this. So how are you going to manage this patient?
So for this patient, considering his systemic condition and his comorbidities, we have, since he is a CAD patient, based on that, we started him on topical anti-glaucoma medication. We started him with prostaglandin analogs. We started him on latanoprost eye drops, HS, and there is decrease in his IUP value.
So how much, what percentage are you?
Usually,
See, it is 33 and all, right? And what is the target IOP that you're going to see? You just started this patient as advanced glaucoma with RAPD. And are you going to expect the IOP to drop down to the level where you want the target IOP to be in this particular case? You just started on one medication. Is that enough in this patient? For that, is a prostaglandin analog your first go-to treatment in this any patient?
Okay, for a patient with such an advanced cupping and RAPD, we have it's a severe case of glaucoma, so we should at least reduce 40% of the IOP. So with prostaglandin analogs, there will be a reduction of about 25 to 32% reduction will be seen. For this patient, there was reduction of his IOP.
Till what?
In the next visit, there was about 18 millimeters of mercury, and it is reducing with prostaglandin analogs. And his last recorded was 14 millimeters of mercury. So with prostaglandin analog, it is working.
Just one drop, you could get 15% reduction.
In the follow-up, there was reduction.
If it is there, it's good, but very, very unlikely there. And would you go ahead? See, let's say if you're not able to control with medications, and you want to, the problem is compliance, right? Okay. In this particular case, what combination, if it is not, let's say it is 40 or whatever, and you want to bring it down to 14, what is the combination that is available which will help you to reduce it to the maximum? A combination that has the maximum number of molecules in it?
New drug is available. A new drug is available, latanoprost in Buonid. It is 0.024%, and it has two mechanisms of action. One, increase the trabecular meshwork outflow and increase uveoscleral outflow by releasing the nitric oxide.
No, in the question, what is the what?
Combination drugs, there
So
are
what
fixed dose
combination do you?
there are various drug combinations available, like brimonidine with timolol dose. We can't use timolol, is not possible. With prostaglandin analog and
what combination?
brimonidine, alpha adrenergic agonist with.
See, you have a combination of brimonidine and dorzolamide or brinzolamide, or you want to add
brimonidine
more?
with brinzolamide, yeah.
Add more? Okay, fine.
Yes, ma'am, 25 seconds.
Field studies, OCT and fundus correlate. Is there correlation between the fundus finding, OCT and field studies?
Yeah, for this patient, there was inferior thinning, which correlates with inferior RNFL defect, and there is field defect of superior field is seen in his right eye. OCT, there was RNFL defect seen.
What was the reason why timolol was contraindicated?
He is a CAD patient.
Okay. So can a CAD and glaucoma go together? Anything which is leading to, is the patient on antihypertensives?
He is on antihypertensive.
Is he using at night?
Yeah,
There is a cup asymmetry. There is a field which is probably involving the center and horizontal, follows horizontal meridian.
So
Can this be an infarct? Is MRI essential? So these are the things which you should think when you get a patient. As we heard in the morning, describe the field, identify whether it is correlating, identify whether it is going with the cup findings, and then think about neuroimaging. Okay.
Any systemic drugs that can be given in glaucoma? Now, apart from acetazolamide?
Yes.
Any other?
Hyperosmotic agents like mannitol. Mannitol is given as intravenous.
Not for reducing tension, I am telling. Any other systemic drugs that can be given? Because the etiology is not exactly known, no? So, is there any drugs which can be given?
It's a neuroprotective agent.
Ischemia.
As a neuroprotective, yes.
Vasodilators can be tried.
Yes, yes, ma'am. Thank you.
Nitric oxides in this inhibitors.
Some people suggest that vasodilators may be helpful in some cases. But we don't know how to study the vascular studies in glaucoma, so it is not exactly known. It's only postulated.
Yes.
Vascular entity is there.
I have to add just one thing to coronary artery disease and beta blockers. I don't know whether there is any direct contraindication. Beta blockers only cause a heart block.
Yes, ma'am.
So in the presence of a heart block, they will worsen. And definitely they'll cause bradycardia in everybody. But I know hypertensives with coronary disease. Many of them are on beta blockers
Yes,
for their
ma'am.
hypertension.
Yes.
So I think that's a point I should make.
They may be on systemic beta blockers. Yes.
Okay, he's on a systemic beta blocker.
So thank you, judges. Thank you, Radha ma'am, Padmaja ma'am, and sir. It was very interesting discussion. And the team, would you like to give us a feedback? Judges, would you like to give us a feedback regarding the teams?
I would definitely love to give a feedback. I always enjoy asking questions, even if I don't have all the answers. So I must thank Sreekanth, Shivan, Dalia, Shishra, everybody who thought that I benefited from coming here as much as anybody else. So thank you very much for having me. And of course, never mind what I ask and what you answer. It's always difficult when you're facing an audience and having questions thrown at you, worrying about the next question. And I know what you're preparing for is your exam. And I've seen generations of candidates, right? And I know my own candidates, some of them who are really good and who want to perform well, who do badly only because they're anticipating the next question. It's not this question that is flooring them. They wonder what will be asked next, and therefore they say something without thinking to the straightforward question, and then the examiner says, and it's sad to see people, dissolve in front of you. Whereas I've had candidates who I know were not good, but who've come and answer. There have been mistakes, but they sit up front, they face the examiner eye to eye, and they talk so confidently, and the examiner gives them such super marks. I know they've made mistakes, and being the internal, there's no reason to pull down my own candidate. So my advice to all of you is, examiners are not there to bowl the googlies. They are there to find out what you know and how deep or how accurate, what is the level of the knowledge that you have. And none of us can kill you, right? So answer what you're being asked. Wait for the next question before you answer. Don't anticipate. Don't start talking thinking that, oh, idan ippa chodiche aduthathu adu varanam. That is what you are anticipating, okay? I wish all of you well. I must say that over the years, the quality of the students has only improved. I know that in my own day, we didn't have as much exposure. We weren't taught as much. And you people are lucky. You have access to so much. In fact, I feel some of the time, what actually hinders your knowledge is knowledge overload in some way. So my advice is read one text, understand what it says, and make that knowledge yours. Don't learn the words. In fact, I didn't see it this time, but on the PPT that I had, there was somebody who said, finger cannot be, what was it? Not insinuated, cannot be, it was a wrong, no, I forget the word. Imbibation or it made no sense at all. So actually think of what you are saying. So if I have a swelling that is attached to the bone, I will not be able to put my finger between the swelling and the bone. That's the only relevance that it has. So think before you, and it helps. I mean, it's fun learning if you know what you are learning. And anyway, all the best and thank you once
Can
more.
they actually get the examiner to ask the next question that they want?
Actually, they can. I'll tell you. Very many times you say something very ridiculous and the sleeping examiner wakes up. Wait a minute, what was that you said? Now, if you are the smart person who knows all about that rare or something, then it's the best way because he woke up, asked you thinking that you know nothing about it. And if you know everything about it, you impress a lot more.
Inviting me for this session, and I really enjoyed the session after a long time. During the teaching days, I used to enjoy these classes, and I was very lucky to have a good professor. We used to have discussions every day, and it went on for hours. From 12 o'clock to 2 o'clock, 3 o'clock, it will go. So we had good sessions, and I wish all the medical colleges should have such sessions every day. That is the only thing, best thing to learn. So thank you, Calicut, for giving me this opportunity, and thank you, Shishira, for calling. Thank you very much.
Thank you, ma'am. Srini, sir?
I thank Sreekanth, Shishira, Dali, and everyone for this. I mean, I'm not in the habit of teaching, so it is quite evident from the questions. I'm basically a clinical person, but I'll just tell you something. See, what ma'am said of these people, because this is something that I face personally when I was in RP Center. You go to North India, it's a totally different this thing. In our place, when I did my undergraduation in Calicut Medical College, until and unless you are asked a question, the brilliant person won't answer. So there, they don't know anything. They will answer. They will answer. It was a real culture shock for me, and I lost 20 kgs in six months. Okay. And one more thing that I really want you to understand is that this is the time. See, you might feel that your teachers are troubling you. See, for me, in my first 6 months, we had to go to the OPD at 8 o'clock, draw blood. The sisters won't draw blood, do everything. They'll come for rounds. The consultants will come for rounds. I mean, I've personally been pulled like this to answer Pata. So that happens. Then you have to go to the OPD, then you have a presentation. Evening, the senior resident will come for runs at 11 o'clock at night, wake up the patients and do everything. And you have to go to the library stays till 2 o'clock. You have to read for the next day's presentation. But and at that time, daily I wanted Pakistan to come and bomb off RP Center. I mean, I'm not, but you come out of those 3 years. So these are the 3 real crucial years. This is what is going to make you. See, surgically, I learned my surgeries after coming out of RP Center in Shankara. But even now, when I see a case, I just remember many of the discussions that we had in the rounds. So make use of your 3 years that are there, and your teachers are there. If they are putting a lot of pressure on you, it will benefit you in the future. That's something.
Thank you, Srini. I agree. My culture shock was the reverse. I did my MBBS in Bombay, and any question that was asked, everybody would shout out something. And what's the worst? They would say, "Arey, maybe you don't know, go and read." They couldn't kill us, right? And I came here, and for the first few months, I thought all the students here are real dunces. You ask the simplest question, nobody answers. They all stare at you. Then I realized there is some stigma attached to being a padipist, trying to impress the teacher. So that is another reason why they used to shut up. But it's in your own interest to start talking, because when you go for the exam, and tomorrow when you have a patient, you simply have to talk. You can't say, I have the knowledge. You've got to learn to bring it out, to express it in a way that is, what shall I say, sensible and believable.
That's what I said. This type of presentation should be there daily in the medical colleges, so that people will be able to answer and understand the situation better.
Yes, ma'am. Well taken. What about the audience? Was the session useful? What aspect of it did you like? Yes, the discussions? Yes, super awesome. Then approach to the case, approach to discussion, the content, the way in which it was done. Yes. So I think we'll all give a standing ovation for the judges for making this last 1.5 hours really, really fruitful and worthy. Yes, ma'am. Are the scores ready? Okay, ma'am. Jyoti, ma'am, would you like to add something? Feedback on the session.
It's a very interesting session, especially when Padmaja madam, Srini and Radha madam were there as teachers. It was really wonderful to hear them, the way they had learned and how the way they had asked questions. It was all very useful, very interesting. Thank you all.
And you will be the next person, ma'am. We'll call as judge. Suma, ma'am. Ma'am is looking at the other side. One word.
Actually, it was very interesting and interactive, and I think all these students might have benefited out of this, because it is very a rare incident, I mean, a rare opportunity to be an examiner by Padmaja madam, Radha, etc. So, yeah, it's very good.
Justice KOS will do similar PG-oriented training programs with faculties who are really well experienced and guide them towards brilliance. Yes. In-house, what is your opinion? Your program, did we reach the mark?
You certainly did, as
Thank you,
always.
sir.
And I think Dr. Shishira had put in a lot of effort for this.
Yes.
Coordinating for this. I was just heading the committee, that's all. So I think it was a very good program, and congratulations to all the 6 teams that participated. I think it must have been a very good experience for you. And I think some of you have your exams also coming up, so wish you all the best. And as regards the competition, may the best team win. The evaluation is going on.
Yes.
Good luck.
So participating is more important than
Certainly.
getting the prize. All of you deserve prize, doesn't matter. Yes, the score is ready? Okay, Sreekanth sir, it's your time now. Speak.
Yeah. Like this session, it was a brain idea of Shishira, Dr. Dahlia and Aisha, and they have put a lot of work for this. Coordinating the PGs, getting the cases done, coordinating with you. So it has come out very well. We'll have some sessions like this, something different next time.
Yeah. So I'll just lighten things at the end, okay? 2 more models, only for the passing teams. Very easy, you'll breeze through this one, unlike questions you faced. Ready? Loudest voice. You see me when you sneeze too hard or push too much. I may look alarming to others. Very soft voice, but that was the only answer. Okay, the last one. This is very easy. I live behind the cornea. I am clear, but never empty. I don't hear anything. Loud, loud. Who said Aquas? Okay. So let's wait for the result. May the best team win. Thank you.
And I'm sure we have to give a hand to Padma too. Oh yes. I'm sure you'll all agree that a lot of the activity and the, what shall I say, The Josh during that was Padma's. I'm honestly proud to have her as my student.
Before announcing the results, I would request Dr. Vijayan sir to please come forward and present mementos to our judges and moderator. First, a group photograph, please. Dr. Srini sir. Unfortunately, Dr. Srini has left to catch his train. First memento to Dr. Padmaja Krishnan. Radha Devi. Dr. Padma Prabhu. Thank you all, and thank you, Dr. Vijayan sir, for doing the honors.
So to announce the results of our PG case mania epignosis, the second prize goes to KMCT Medical College, Team F, Dr. Shruti and Dr. Tessie Jose. Please come forward. I would like to request Dr. Shivan sir to please do the honors. And the winners today is Malabar Medical College, Team B, Dr. Aishwarya Pillai and Dr. Meghna. Please come forward. Thousand? 10,000 each. All other participants, please collect your certificates from me.
That we come to an end of today's CME. Thank you all for coming and gracing the day. I'd like to thank all the delegates and all the faculty and all the postgraduate students who came here to attend our CME in large numbers. I'd request everyone to rise for the national anthem.